Very good morning, everyone. We're beginning the program. I request everyone to kindly be seated. It gives me immense pleasure to welcome you all to SURGX 2026 hosted by Fortis Hospital, Banagatta Road. Today is more than a scientific conference. It is a celebration of extraordinary milestone, 3,000 robotic procedures reflecting years of innovation, collaboration, and commitment towards advancing patient care. With experts representing multiple specialties under one roof, today's program promises engaging clinical discussions, cutting-edge innovative capsules, and meaningful conversations on the future of robotic surgery. Thank you all for being part of this remarkable journey. Every successful journey begins with light. In Indian tradition, lighting the ceremonial lamp signifies the triumph of knowledge over ignorance, hope over uncertainty, and wisdom over darkness. I request the dignitaries, Dr. Bishnu Panigrihi, Group Head Medical Strategy and Operations, Fortis Healthcare, Dr. Ritu Garg, Chief Growth and Innovation Officer, Fortis Healthcare, Dr. Anant Rao, VP and Business Head, Fortis Hospitals, Bengaluru, Ms. Renu Malik, International Head, Dr. Mohan Keshamurthy, Principal Director, Renal Sciences, Fortis Hospitals, to please come on to the stage. Dr. Priya Sridharan, Senior Director, Anesthesia. I request all the dignitaries to please come on to the stage for the lamp lighting ceremony. also request Mr. Ravindra, Mr. Gautam CB, Mr. Ganapati Hegde to please join the dignitaries on stage. Thank you, everyone. Can we have the lamp remote, please? As we celebrate this remarkable milestone, it is equally important to understand the vision, perseverance, and multidisciplinary collaboration that have made this journey possible. From introducing the robotic surgery to becoming one of India's leading robotic surgery centers, Fortis Hospital, Bannerghatta Road has continually pushed the boundaries of surgical innovation. To set the context for today's conference, it is my honor to invite Dr. Mohan Keshamurthy, Principal Director, Renal Sciences, Fortis Hospitals, Bengaluru. Please welcome Dr. Mohan Keshamurthy.
Good morning. It's a privilege to see a lot of familiar faces in the room who have shared the journey of excellence, not just in surgery, but also robotic surgery, to make Fortis Bengaluru a destination and Fortis Bannerghatta Road a center of excellence. It's not just the numbers, it's the range of surgeries that we have done.
Thank you, Dr. Mohan. I now request Dr. Ritu Garg, Chief Growth and Innovation Officer, Fortis Healthcare, to please come onto the stage and address the gathering. Please welcome Dr. Ritu Garg.
Thank you, Jessica. Good morning, everyone. Good morning, delegates who have come from all across the world, our esteemed faculty, guests, ladies and gentlemen. It's truly a privilege and honor to be here today as we celebrate not just a milestone of fastest 3,000 surgeries, but a clear commitment to what Fortis stands for. At Fortis, as we continue to expand our wings across India, now with 36 facilities and doing more, the core has always been to bring the best that's possible in the world to everyone in India. And we are guided in that mission by our clinicians who are passionate about adopting technology, not for the sake of technology, but truly because it leads to better outcomes and better patient care. I was there yesterday hearing some of the testimonials and some of the patients, and it was so heartwarming to hear the experiences they have had with the teams here. So it is really a great milestone, and Dr. Mohan Keshamurthy brings in that warmth, that empathy, which is truly the intersection of innovation, excellence, and empathy. And that is what Fortis truly stands for. As we continue marching ahead, we look forward to getting the data, AI, experiences together to make sure that we improve the access and have a much wider impact for everyone. I also see a lot of people who have come from many countries today, who have joined us from Africa, from Malaysia. We're honored to have a special delegation come in from Malaysia as well. And that kind of reinforces a joint commitment and vision for doing something that no one else does. And we're truly looking forward to the exciting exchange of ideas, panel discussions. They're great thought leaders. I saw the agenda. It's extremely exciting. And I'm definitely looking forward to a lot of learning and wishing all of you a very best for deliberations over the entire day. So thank you very much.
Thank you so much, Dr. Ritu. Now, may I invite on stage to address the gathering Dr. Anant Rao, VP and Business Head, Fortis Hospitals, Bengaluru. Please welcome Dr. Anant Rao.
Good morning, everybody, and a warm welcome to the city of Bengaluru. I think in the last 20, 30 years, almost 3 decades, we have all learned that technology binds us and has bound us in many ways. Of course, the testimony stands in our friends who come from far and wide to be a part of this conference. I think robotic surgery is one such technology which is kind of perfected over the last 2 decades. And I think one of those biggest innovations that changed the way surgery does at Fortis and at Bengaluru, we are one of those proud institutions who have 2 robots side by side. I think that itself is a privilege to have. I don't know how to acknowledge leadership on their confidence on this, but from this stage, I think it's a matter of pride to express our gratitude to the leadership on this trust and faith that they have placed in the team. Thanks to all the surgeons, right? So we have surgeons who adopted to robotic surgery even almost 20, 22 years into their careers, the seniors, and then they've also got a generation of juniors, the next level and the next level. So today we have almost 45, 50 surgeons, who can conveniently do robotic surgery of all forms. I think that itself is a testimony to what the longevity of this program is going to look like. Also, Fortis Bengaluru is very proud to say that we are a well spread out Fortis robotic surgery program, where we have equal contributions from urology, cardiac surgery, ENT, general surgery, GI surgery, onco where Fortis Bannerghatta Road is completing 20 years. So this is like an anniversary gift to Fortis Bannerghatta Road, this conference. And make sure that we have all the arguments in favor of the patient. I think that itself is a testimony to how the program has grown. So as a typical administrator, yesterday when the Honorable Minister said, he will be present here for the 5,000th surgery also as the chief guest. So I was wondering, because we are administrators, we are used to doubling. So I was thinking, why not 6,000? So I think my request to all surgeons today, whoever is present, and to all of them who are learning their robotic surgery today is, maybe we should celebrate a double much more quickly. Yesterday I heard myself and Dr. Mohan were chatting. So he said 1,500 next year. I think we'll have to beat that number ourselves. So all the teams should be more ready, more equipped. We are getting one more robot pretty soon into the city of Bengaluru, and we are very hungry for one more, sometime, during the next calendar year. So looks like we are, at the edge of technology. But again, like I say, technology has bound us to be here together. Let the same technology keep us more bound with the mission of learning more and delivering patient-centric care. Thank you very much.
Thank you, Dr. Anand. Thank you, all the leaders. Your vision and leadership have laid the foundation of what has now become one of the country's most comprehensive robotic surgery programs. Moving on, we would like to honor and felicitate our leaders who have come all the way from Delhi to join us and be part of this two-day conference. Dr. Bishnu Panagrihi, Dr. Ritu Garg, and Ms. Renu Malik would request all three of you to please come onto this stage. And to do the honors, I would request Dr. Anant Rao, Dr. Priya Sridharan, Mr. Ravindra, Mr. Gautam, and Dr. Mohan to please join us on stage. May we have the bouquets and mementos for the dignitaries, please. Round of applause for our leaders, please. Thank you, everyone. Moving on, behind every successful robotic procedure is a highly coordinated team where anesthesia plays an indispensable role in ensuring patient safety and optimal surgical outcomes. To share his experience on this important aspect, it is my pleasure to invite Dr. Murli Chakravarti, Senior Director, Anesthesia. Please welcome Dr. Murli Chakravarti.
Good morning, ladies and gentlemen. It's a proud privilege to be amongst you and to be the numero uno lecturer on this great day, which all of us will remember for many years to come. 6,000 may come, but 3,000 will not be forgotten. Sometimes I feel whether Mohan is my friend or my enemy. He calls me one day and says that we have to do a robotic nephrectomy and the patient's ejection fraction is 15%. I told him he is not fit for a haircut. You are asking me to do a robotic nephrectomy. He had a cardiomyopathy. He said we have to do it. And of course at Fortis BG we have an ecosystem which always starts with how we can do, then how we can cancel. This patient, I am sure, would not have been touched by anybody else because it's not just an anesthetic risk, but also a surgical risk. And death on the table is something which we'll never want. And we did this patient under ECMO and kept the patient on ECMO for a couple of days. And the patient went home. And actually, we had done his CABG many years ago, so he knew me. He told me, "Doctor, even I didn't have the confidence of Dr. Mohan. I thought I'm going to die, but thank you all very much." So, such cases are the cases which gives us confidence to do other low-risk cases. And I always feel that if you want to start a robotic system, first ask yourself, do you have a right ecosystem in your place? If you are full of, as one of the HR person told me, the biggest enemy of progress is no mas and no pass. You say something, they say, no ma, we can't do. If you have that ecosystem, don't buy Da Vinci. You still will be doing open surgeries. But the whole system should surge with the positivity that we will do. If we don't do, who will do? Kind of a thing. And of course, it's not that all high-risk cases I only anesthetize. My colleagues, extremely capable, extremely confident, knowledgeable colleagues who are the backbone of the operation theater. And somebody says that we don't see you outside at all. I said, that's a good news for you. If I am in the cafeteria, then the hospital is making a loss. So we are all very busy people. So anesthetic consideration in robotic surgery is mostly philosophical rather than anything anesthetic. We all know that benefits of robotic surgery. I will briefly go through them, and my lecture is not going to be too long. So it's a minimally invasive surgery, very, very precise surgery. I like that word the health minister told yesterday, you know, small hands, big eyes. It exactly describes what a robot is. And it is actually made for the pelvic cavity. After that, we realized that it is also good for thoracic cavity. Then we realized it's good for oral cavity. So any cavity, robot is good. And it's actually, I do the rounds every morning in post-operative patients. Sometimes I have a habit of telling them, we forgot to operate on you yesterday, we'll do the surgery today. Some patients say that, you're joking. Some of them say that they don't have pain. They think that I'm telling the truth. So it is as painless as that. And if with time, the learning curve of our surgeons has been extremely steep. Very quickly they have plateaued and they have all mastered. And it is now, we have done on one single day, we have done 14 robotic surgeries, which is an Asian record. Early recovery, cosmetically superior surgeries. Yesterday, Dr. Mohan showed what a open transplant incision would be those days to what it is nowadays. And it enhances the surgeon. It converts him from an ordinary human being to Lord Ganesha with big eyes, 4 hands, and all that. I'm not talking about the tummy, but because he's sitting and operating, even that might come. And the top class, the 3D magnification. I urge all of you, even if you are not operating, to peep through the console to understand what a wonderful vision it is. And it's all under operator's control. For the first time, surgeon's legs are also being used. So he's indeed got 4 arms. And the scope of robotic surgery first came in for gynecology and urology for the obvious reasons that it is into the closed space where there can be no retraction possible. You have to operate on that. I have been a part of growth of prosthetic surgery from the days of blind prosthetic surgery. Patient would be here, surgeon would be looking like this and remove the prostate. Patient would bleed like hell, and we gave tons and tons of blood and had a lot of problems. From there to now, they do radical robotic prostate, preserving the bladder and the sexual function of the patient. What more can the patient ask? I think this is excellence at its pinnacle. And we are very, very happy with, it's not that it's some patient, it may be one of our own relatives. For all you know, it's one of us. I always tell, take care of Baswaraj and Karthik well, because they are going to do my prostate. So please do well and use the robot. And of course, cardiac surgery, we initially thought that cardiac surgery, it will be ideal, and then we realized it is not so good. Then we came down to the pelvis. Again, we have climbed up. And doing cardiac surgery with robot is an attitude. You have to start saying that we will do this, come what may, and safely. Outcome should be superior to the open surgery. See, you have got so many challenges, but I think we have done that. Transoral surgery, the scope is now tremendously expanding. Obstructive sleep apnea surgeries are all going to be robotic. Thyroid, we are doing a lot of thyroids, and the scarless neck is only appreciated by the patient himself or herself. And we have done pediatric surgery, pediatric transplant, pediatric robotic transplant for the first time. So these things, and some surface surgeries, you may wonder, radical neck dissection, parathyroid, these are all wonderfully possible because the visualization is very, very good. And our 3,000 cases, we have about 2,100 urology, oncology 400, abdominal 350, gynec 75, oral 7, thyroid 72, cardiac surgery 106. This is possible only because of continuously collaborating. We realized one thing, forming our robotic steering committee was an important step in the progress of robotic surgery. Because there should be somebody who understands the robot and the surgery and then set up a protocol which will not be breached. And this is a robot in action. I think some of you may have seen the intuitive. It's very fascinating to watch this. When the robotic surgery is going on, everybody will give you comments to the surgeons. And also, luckily, we can also write on the robotic screen. So they'll say, why don't you try here, why don't you cut here, and all that. They tolerate all that nonsense and go on concentrating on that. But it is so fascinating, sometimes my colleagues forget to see the monitor. I said that that monitor is for the surgeon, patient monitor is for us. So please look at that. And surgeon is at console. One benefit that he has is it doesn't have to scrub, doesn't have to remove his rings or bangles, which otherwise he has to do that. And scarlet thyroid, the entry point is on the chest. So when the surgery is over, there is no scar on the neck, and all the incisions are covered by usually worn dresses. And also transoral robotic surgery, you may wonder why it is required, because oral manipulation should be without much tremors movements. It has to be accurate. There are very important structures in the neck which you can injure from inside also. Jugular vein, carotids can be hurt from inside. So these surgeries have to be very precise, so we do that. And the anesthetic technique, like I said, is not largely different. A well-balanced anesthesia, good neuromuscular monitoring block is important. Some surgeries, if some of the surgeons here may have encountered the patients suddenly move, they start breathing, all that, that is not allowed in robotic surgery. We cannot allow the patient to even breathe because the robotic arms are uncompromising. They can move away an object of even 200 kgs. Actually, the current robot, which has no sense, in the sense it cannot give you the feeling of the structure, a surgeon can put a needle through a bone also. It won't hesitate because it is so powerful. Imagine if the patient starts moving and shaking on the table, then you can injure viscera like liver, spleen, aorta, etc. So we should not at any cost allow the patient movement. Termination of anesthesia may not immediately be in reversal and extubation like in many other surgeries. Operation may be over, patient is not yet ready for extubation. Thankfully for us, all our robotic surgeons never ask us why you have not extubated a patient, why the patient is in the intensive care, still on the ventilator. Patient tells us, I am ready to be removed from the ventilator. And also, pain relief in the initial stages must be attended to. All our surgeons give local anesthetic block. We also give additional nerve blocks to make sure that the pain relief is attended to. And we have to make sure that the patients don't wake up in between. Because the muscle blockade is so dense, the patient gets what is called as awareness under anesthesia. It should not happen. So we have not had those things. Thumb rule is if the robotic surgery is scheduled by a novice surgeon, if his lap collie time is 1 hour, then multiply by 4 hours, that is his robotic collie time. But with time, they shortened, and it almost comes to the same time as the lap surgery. Generally protracted learning curve is sharp. Our surgeons are good. I have seen surgeons from the US, Europe, China, and of course a lot of Indian surgeons. In my life, I must have seen about 700 to 800 surgeons operating. I feel that our surgeons are extremely sharp and they can very quickly adapt and they can operate at half the cost of a European surgeon, 1/4 the cost of an American surgeon. So this also slowly gets better. And then the time complications such as thromboembolism, hypothermia, volume deficit excess, unattended blood loss can also happen. Also, paradoxically, patient can have thromboembolism, so we have to be ready with Clexane. And all our robotic patients get Clexane. And we have special warming devices. Patient is warmed under the, the body, and also we have a warming IV fluids. The fluid that gets into the patient is at 38.5 degrees centigrade. My patients, after 12 hours of anesthesia, don't cool down. If they cool down, your outcome is not going to be great at all. Patient access is nearly impossible. Many of the times when I get into the theater, I think the part which is low towards the floor is a head end, but I may be wrong. We don't know where the head end is, where the foot end is. Surgeons are all over the patient. Even I cannot feel a pulse. Patient access is completely gone. My lines, IV lines, arterial lines, jugular lines, all that should be perfect and perfectly fixed. I can't afford to have an arterial line slipping out in the middle of the surgery, and then there is no arterial pressure. Surgeon has a problem, I will not know. I cannot have it at all. And I will not have access to the patient. Everything, including the bladder catheter, temperature probe, should be perfectly placed before we start the surgery. And then we really don't mind having one more extra line. And also protect the organs. There is a shoulder strap which prevents the patient from sliding off the table, and then the eyes can get injured, so appropriate protection is required. And we have to understand that a good technician, we have our robotic technicians are very good in setting up the robot, but it takes time. There cannot be a compromise on that. And it has to be docked, and once it is docked, you cannot say, undock, I have a problem, I have to re-intubate the patient. That's very, very low quality service that we are providing. So we have to understand, once it is docked, you will undock at the end of the surgery. And we have not nearly had any situations where we had to undock in the middle. And to stop the surgery, remove the robotic arm, and then to attend will not only take time, it can also amount to morbidity. Patient movements are not expected. I have told you of that. Pelvic surgeries, there is a steep Trendelenburg. We give head-low position till the operation table touches the floor. I'm not kidding. And also many times I'm worried that a patient may slide off the table, so we have shoulder supports to do that. and monitor heart rate, blood pressure, awareness, everything remotely. We have to be monitoring continuously. And then support the pressure source. 12-hour surgery patient may get a pressure injury. Make sure that it is avoided. And it's prudent to check the pressure points that are accessible. Sometimes when they are operating in the lateral positions, the ear pin, the scalp are lifted gently, and we put some cotton pads under that. Steep Trendelenburg position will cause brain edema. It is a rule than an exception. When the patient has got brain edema, they will be very fast asleep. They will not wake up from anesthesia. So we have to make sure that that goes off. How do we know? Conjunctival edema is the indicator of brain edema. When the conjunctival edema goes, brain edema is gone. So we have to monitor all the pressures, all the cavity pressures that are required. Sometimes we have put transesophageal echo probes. Sometimes, yeah, I think Mohan will never forget that patient. He told that his patient is a former MLA and needs a renal transplant, and she was 130 kgs. We did her, and we did well. So these things are possible with experience, exposure, and confidence that we will achieve it. And postoperative mechanical ventilation is not a big thing. If a patient gets ventilated, it doesn't mean that surgery was bad or anesthesia was bad or patient is sick. Better to ventilate. When in doubt, intubate. When in doubt, don't extubate. That is the rule. While being mechanically ventilated, maintaining normal carbon dioxide, normal blood pressure, normal CVP is necessary. See, I told you this is a head end. Can you see the head end? So the syringe pumps are at almost on the floor. So they are very, very low. They need that. Especially the intestines coming into the field can be an issue. So they need that. And I have talked about the monitoring. We do all the monitoring. This was the conjunctival edema that I was talking about. We use an ultrasound probe to monitor the optic nerve sheath diameter. Optic nerve sheath is a direct extension of the cerebrospinal cavity. So if increase in the CSF pressure, nerve sheath will become wider. So we monitor it until it becomes normal. We will not extubate the patient. Daycare surgery is possible. One of the patients she underwent hysterectomy in the morning. By evening she was transferred. It is possible. Robot helps us do that. And robot is very bulky. We need big theaters, good theaters with good power supply, good internet connectivity. These are the infrastructural requirements. And it can, some surgeons who are not sensitive can have a sword war, as they say, inside the abdomen or chest. It is difficult for the anesthesiologist to access the patient. And in addition, almost impossible to reposition. Watching robotic surgery is extremely interesting, and that is a strict no-no to the anesthesiologist. They should not watch that. And why patients postoperatively do well is minimal tissue damage, lesser pain, length of stay is better. We have a rule that all robotic patients will go out of the ICU the next day. Very rarely we keep them for one more day. Open surgeries, it was a common affair after a radical prostate, radical nephrectomy or cystectomy we used to keep. And earlier physiotherapy and ambulation is a must. In our hospital, patient walks within 24 hours, sometimes on the same day as surgery. And therefore, we can discharge them earlier. Robotic surgery is here to stay. In fact, in one of the panel discussions, they asked the surgeons, do you think robotic surgery, what is the future? Then I told you should ask that question to me also, because I have seen the surgery, I have seen the recovery, and I have seen the outcomes of the patient being much, much superior than the open surgeries. So robotic surgery, if any one of you have a doubt that it is a gimmick, it's not necessary to do robotic surgery, I think you should discontinue from this conference, because come to the positivity that robot is here to stay. We already have two, and Vishnu was saying that we may get one more. I don't know whether he meant BG Road or other hospital, but we are ready to take the third one also. So anesthesia for robotic surgery is not easy, but it is doable. We have done 3,000 times. Extremely important to document complications, attend, and be very, very open with the patient. They understand. If there is a problem, sometimes the robot stops working, then you cannot make it work by yourself. It is not like a laparoscope, put it in Savlon and clean it and put it back. No, it is all internet controlled. So we have to be open with the patient about that. Highly accurate, precise procedures enabled by robot requires the anesthesiologist constantly innovate, remain abreast, and support the surgical colleagues. After all, without surgery, anesthesia also ceases. Therefore, I am very proud to say that at Fortis, we have been constantly innovating, constantly making sure that we take up more and more difficult cases and give better outcomes that is not possible with open surgery. Thank you very much.
Rapid fire sessions, panel discussions. Each clinical case discussion is thoughtfully curated by our expert surgeons. So we will begin with our first session, and to moderate this discussion, I would like to invite on stage Dr. Rubina Shanawaz, Additional Director, Urogynecology, Gynec Oncology and Robotic Surgery. Please welcome Dr. Rubina.
Thank you, Jessica. Good morning, everyone. Welcome to the first clinical case discussion of SURGX 2026. To maintain time, I'll move on to introducing my panelists and calling them on stage. So our clinical case discussion is about robotic precision at the apex. For my first panelist, I invite Dr. Bhanu. Dr. Bhanu BT is a senior obstetrician and gynecologist with over 18 years of clinical and academic experience. She served as a senior specialist at Bangalore Medical College and Research Institute for 13 years and currently a consultant at Fortis Hospitals, Yashwantpur, Bangalore. She's trained in advanced laparoscopy and hysteroscopic surgeries, multiple publications to her credit. Please join me in welcoming Dr. Bhanu BT. Next, I invite Dr. Punyashri RM, Gynec Oncosurgeon, who has done her MBBS from BMCRI and MS from MMCRI, Fellowship in Gynae Onco from Kidwai, FMAS Console Certified Robotic Surgeon, Executive Committee member of the Karnataka chapter of Gynae Oncosurgeons, India Book of Records achiever for being the first and only Indian doctor to summit the Everest Base Camp, raising awareness on HPV vaccination. Proud to have her with us at the hospital and here. Dr. Prakriti S., consultant in gynecology at Fortis Healthcare Bangalore. She has done her MS, DNB, FMAS, holds a diploma in urogynecology from Kiel University, Germany, and has latest been certified in the Scarless V-Notes technology. Youngest console certified Da Vinci surgeon, our resident intuitive expert, teaching faculty for International Urogynec Postgraduate Program. Please join me in welcoming Dr. Prakriti S. on stage. Moving on to the first clinical case discussion. I don't know, you are able to see the screen? Can this be turned to them, please? So we have our first case. Okay, can you see it? No? Can they have something, or can the chairs be changed so that they can see it? Can you move that screen to the panelist? They can't see the case. Now? Can you see? Ma'am, can you see it? Okay. Okay, so I have set a 2-minute timer for each of the 6 cases so that we don't overshoot. The first case, okay, my panelists can see, I can't see, is a 52-year-old sexually active lady, all 3 normal deliveries, normal BMI, stage 2 UV descent, stage 3 cystocele. She's had a hernioplasty 3 years ago, no SUI, nothing else. First question, I think I'll Dr. Bhanu, would you like to take the first question? Elsewhere, for this issue, she was suggested vaginal hysterectomy, anterior-posterior colpoperenuraphy. Would you concur with that decision? What would be your concerns on that?
Yes, I concur with this decision. So,
I mean, the surgeries mentioned are correcting one hysterectomy, anterior-posterior repair. Considering her age and the fact that she's also had a collagen deficiency earlier needing a mesh repair, wouldn't you want to do something to prevent a wall prolapse later?
yes, in this case, maybe we can do bilateral uterosacral ligament suspension, which can maintain the vaginal axis, because you have mentioned she's sexually active.
Yes.
So that might help her.
Okay, thank you so much. Dr. Prakriti, would you concur with Dr. Bhanu? Native tissue repair is her choice. Is that also your choice? And what else would you think of? What are your other options?
All approaches of surgeries, they have their own merits and demerits, ma'am. So currently in the given case scenario, because she is 52-year-old, sexually active, looking for a definitive management, we could give her options of both vaginal and the more preferred approach, the robotic mesh repair approach. Give her the merits and demerits of both the approaches, and definitely we can ask for the patient's opinion.
Okay.
But given the studies, and the gold standard is the mesh repair in the long-term outcomes, and robotically it helps us even more to anchor it more precisely and correct the defects more precisely.
I think considering the age and the history, yes, yeah. I think we would prefer a more long-standing durable approach.
Yes.
Thank you, Doctor. And Dr. Punyashree, how would you counsel regarding recurrence and mesh-related risk?
The patient, if she's willing for a mesh repair, like Dr. Prakriti mentioned, we would give details about what the procedure would be and what are the pros and cons of each of it. So that is when we also say that robotic sacrocolpopexy repairs usually do not have recurrences. The chances are really, really low. It's less than 0.5%, and that also has to be mentioned. But of course, there are patients who would have some mesh erosion, and those will be individually tackled and tailor-made based on if it occurs or not. So that would be mentioned.
That. All right. Moving on to the next case. Similar younger patient who has a stage 3 prolapse but wants to conserve her uterus. So this, who would want to take it? What would you suggest to this patient when she's, seen in your clinic? Dr. Punya, would you like to take that?
Since the patient is young and she does want to retain her uterus, of course, uterus preserving procedures can be done, like hysteropectopexies and hysterosacropexies. So the main thing that is we'll always have to kind of do some screening tests and rule out any pathology or atypia inside the uterus. That is, the endometrial biopsy has to be taken prior to the deciding on the procedure. Also, a pap smear has to be normal. So these are the things that we would check on to before giving her an option of a uterine preservation. If those are normal, then we definitely can do it.
So, abdominal approach, and considering with the robotic technology,
yes, definitely, ma'am.
That would be, vaginal wouldn't be a question in this case, right?
Not really.
Okay, all right. We'll move on to the next case. A 60-year-old woman who has a recurrent vault prolapse. That's the picture you see. She's had an SSLF done, a sacrospinous fixation done 5 years ago. What are your concerns? Which approach would you prefer? And how does the anatomy vary? Is repeat native tissue repair an option in this case? So for this, I think, Dr. Prakriti, would you like to take this?
Definitely, ma'am. Thank you. So because she has had a recurrent wall prolapse, and that wall prolapse had also been repaired using a sacrospinous fixation, a vaginal approach. Clearly, the vaginal approaches has not helped her in both the surgeries. So we'll now have to consider an abdominal approach, and robotics gives us an edge where we can give a definitive repair for her. So a robotic sacrocolpopexy, because it's a global descent, would be the best approach for her. And previous surgery has been done in the lower vaginal area, so we might not expect much of a distorted anatomy. Only the hysterectomy might give us some adhesions at the vault end. Otherwise, robotically, this case can be very beautifully managed.
If the same was a 90-year-old, would you still do robotic?
Yes, ma'am.
You would?
It's a failed vaginal.
Yes, it's
so
a recurrent.
You would still do robotic if MC was giving anesthesia.
Unless anesthesia has no other risk, then we can definitely.
That is debatable. We leave that since we are running. I'm looking at the timer here. We will debate that later. Then moving on to the next one. 64-year-old lady, BMI of 38. I think we had this case recently. She had Mount Jaro. She was on Mount Jaro for 1 month. Diabetic, hypertensive, operated for endometriosis 20 years ago. Now, stage 4 wall prolapse. So what do you anticipate? Complication, obese patient who has adhesions inside wall prolapse. What is your anticipated complication and how would you go about? Dr. Bhanu, would you like to enlighten on what complications we anticipate when we see this obese patient walk into our OP?
First of all, anesthesia complications. It is difficult to give deep Trendelenburg, and long surgical hours is going to be a risk for her. And we anticipate dense adhesions and difficulty in getting the planes. Because she also had undergone surgery for endometriosis, chances of bowel injury and ureteric injury are high while doing the dissection. So we need to be very precise.
Okay. Dr. Punya, intraoperatively there is dense adhesion. You planned a sacrocolpopexy and you went in. Sacral promontory is just not accessible. What would you do? Abandon and finish vaginally or do something else robotically?
We can still do a colpopectopexy, because if we are not able to approach the sacral area, we can always think of an alternative. We can dissect the Cooper's ligament and attach bilaterally.
Okay. And Dr. Prakriti, she's just not holding the pneumo, the bowels are falling. Will you still complete it robotically? Would you move to laparoscopy? Would you move to vaginal? Would you open her up?
Especially with the given history, shifting it to a laparoscopy would not be a feasible option when we have a higher technology which is not able to tackle this situation. So if there is anything which is not letting us finish the surgery on time, a vaginal approach in this case would be the best option. Sure. We could give an apical support vaginally as well.
Vaginally as well? And yes. Which of the supports would you look into?
Given that she's 64-year-old, we could consider, if she's sexually active, a bilateral high uterosacral ligament ligation.
A V-nodes technology.
A V-nodes technology also would help here, if the pneumoperitoneum can be allowed, or even a sacrospinous ligament fixation as well.
Okay. Moving on to the next case. Yeah, so this patient has a concomitant occult SUI. You have elicited it when you have reduced the prolapse. What would you do? Would you tackle the SUI in the same sitting or would you not? How do you make your decision? And how do you counsel? We know a lot of them have de novo urgency post mesh repair. How would you counsel? What would you do to avoid it? So this, I think, Dr. Bhanu, would you want to say, do you routinely perform a prophylactic continence surgery? Patient has no complaints. Do we routinely go and do something to fix the continence issue?
Routinely, it's not done if she has no symptoms. Yeah, we can counsel the patient that there is occult SUI. So we can reassess her after 3 months of surgery and see if she has SUI, then we can go ahead with the surgery.
Okay.
If she is not willing for the second surgery, then we might have to do it in the first sitting itself.
Okay, all right. And would you do a concomitant mesh repair for the TVT in the same sitting? Dr. Punya, Dr. Prakriti, would you like to take it?
It's always better to do it as a staged procedure. because that's why the pre-op counseling is really important. We need to we need to inform the patient that this could happen post-surgery, post the mesh repair, but it might subside. Most of the times it subsides within 3 weeks to 3 months. So that reassurance can be given, but if it doesn't, then we can always do it as a staged procedure.
Okay. Moving on to the last case, I think we'll skip this case since we are out of time. It is about a rectocele. So would you also, always do you add a posterior colporrhaphy? I think that one question we'll take it. And about a year later, there's mesh exposure. What would you do? Dr. Prakriti?
Whenever there is a rectocele, we have the upper 2/3 and the portion below the levator ani, which is the lower 1/3. So the mesh repairs will definitely correct, if it is anchored at the lowest, the upper 2/3 of the prolapse. After the mesh repair is done, we reassess intraoperatively on table if the lower 1/3 also needs to be repaired. If so, we can definitely perform a perineorrhaphy, not a colpoperineorrhaphy, just the perineorrhaphy just for the lower 1/3 and the lax vagina and widened genital hiatus in the same setting. No. So if done correctly, mesh erosions are very, very, very rare. But in case if it happens due to vaginal vascularity issues, we can definitely counsel the patient and tackle it in the OPD as well with topical estrogen creams and freshening up the vaginal edges and taking stitches under anesthesia as well.
Okay. And moving on to the last of the panel questions, the future pathways. Dr. Punyashri, a most reluctant convert, but now an ardent believer of robotic surgery. Which patients do you think benefit most and who do not from robotic surgery?
Since the past 2 years after joining Mohan Sir's team, I feel all patients can definitely benefit from robotic surgery. But it again depends on the patient concerns as well as the disease itself. So the most benefited patients, considering the patients as well as the surgeon, is those who are really obese, who've had a previous surgeries with a lot of adhesions, and the disease per se which causes a lot of adhesions, and recurrent surgeries. All of these are the patients who would definitely benefit. And young population wherein we need not give them a huge scar. So those are the patients. And of course, those who are on anticoagulants, so the blood loss is really very minimal. So most of the times our patients have had blood loss as less than 5 ml, 1 ml. So such patients definitely benefit.
Okay. Dr. Bhanu, considering they are talking about a new robot coming to the cluster, which are the patients you would not do robotics on? Definitely not the obstetrics part of it, but the gynec part of it. After listening to all of us, is there something you think we should not be doing, which we are doing right now? I think we'll take it down later, since we are running short of time. And Dr. Prakriti, what is the innovation you think in the next decade we should be prepped for so we keep surging ahead?
Two things which is immediately coming into my mind is AI integration into the robot, which will help us leaps and bounds in giving a better patient care. Second major thing why the robot was introduced in the first place was telesurgery. We sit in one place, mentor, or do the surgery in another place. These two are in near future is very possible.
Yeah. Thank you so much. Thank you, my dear panelists. I think due to lack of time, I'll conclude here. And we will, I thank the chairperson and my panelists for being here, giving us this opportunity. Robotic technology has definitely transformed apical suspension. It used to be a very technically demanding surgery. Now it's precise, reproducible. You won't know by the videos which one of us has done it. Reproducible and patient-centric reconstructive approach. Thank you all for your patient listening. Thank you.
Urogyne fistulas. And to moderate this session, I would like to invite on stage Dr. Mohan Keshamurthy, Principal Director, Renal Sciences, Fortis Hospitals, Bengaluru. And joining him are the panelists, Dr. Rubina Shanawaz, Additional Director, Urogynecology, Gynec Oncology and Robotic Surgery, Dr. Karthik Rao, Additional Director, Urology, Uro-Oncology, Andrology, Kidney Transplant and Robotic Surgery. Dr. Santosh Krishnamurthy, Additional Director in HOD, Radiology. Dr. Parimala Devi, Senior Consultant, Gynecology. Over to Dr. Mohan.
Also would request Dr. Usha, Consultant Gynecology, to come on stage. It's a privilege to conduct a case in an auditorium where a gynecologist and a urologist meet. More often than not, a gynecologist requires a urologist in a hurry in an emergency situation when something has gone wrong. So this particular case is all about looking at what can be done that the gynecologist doesn't need the urologist in a hurry. So this is a standard generic case. We are looking at a patient who underwent a planned surgery but started leaking urine on table, and then was called in, urologist was called in to stent, looked good, but on the second post-operative day continued to leak per vagina. This causes both a practice problem and an issue with the patient's ability to accept something which possibly wouldn't have been explained appropriately. Starting off with Dr. Parimala Devi, the senior most gynecologist in the panel. In this situation, when you have gone in for an elective procedure, you have done a good job, had a problem on table, you have called in a urologist, stented the patient, but still leaks on the second post-op day. What would you do next?
Thank you, sir, for the opportunity to be with this esteemed group, first of all, and congratulations. In this case, as it is told, like the total laparoscopic hysterectomy is done, and they have recognized there was some problem with the ureteric fistula, and it has been repaired then and there only. That's one of the good thing. And also it has been again carried by the cystoscopic examination and bilateral stenting done cautionary. But still, on the second day when she starts leaking, I would like to think in terms of there is something like a multi-organ injury. There may be another part of the this one renal tract also is injured, like it may be a vaginal fistula which is not attended. That's my way of thinking. I would like to again go ahead with more investigations and confirm the findings.
Dr. Rubina, what would you expect the leak to be coming from? Ureterovaginal, vesicovaginal, or both?
Ureterosa. So either it is bladder or it is ureter or a combination of the two, or urethra is very, very rare. Considering that the catheter was reinserted and the leak persists, so the bladder is empty, but still leak is coming, it's most likely a ureteral injury.
Dr. Usha, where would you expect, considering that you're a brilliant lab surgeon, have had the privilege of, we have had the privilege of participating in your robotic journey, where would you expect the injury to be when the laparoscopic hysterectomy was done?
Okay, so thank you for the opportunity. So in this case, you're asking me, sir, where is the... So mostly this would be somewhere at the vault or just lateral to the uterosacral. So that's why we're probably anticipating a ureteric injury or probably a vesicovaginal fistula also. Many times I think just continuing the catheter being in situ, treating for infections, if it is a small leak, would usually settle over time. But yeah, after 2-3 months, when you see that there is a nice tract formed, it can be tackled if it is persistent. But many a times it would settle also.
So that's the point this slide wants to make out. You assume it is ureterovaginal or you assume it is vesicovaginal, but 1 in 4 patients will have a combined issue. And those are the ones that will trouble you the most. So if it is just a vascular injury because of a thermal current, that's an issue. But if it is a mechanical undervascular event, that is, you have a bleeding intra-op, you don't know how to control it. First you try to burn it off, then you try to clip it off. That's when injury to the ureters happen. So usually low injuries are a combined ones. High injuries, as you rightly pointed out, are ureterospecific. Very low injuries can be both bladder and urethra. So it's very difficult to distinguish what to do, but 1 in 4 will be a combined injury is what we wanted to highlight. Dr. Santosh, then the point Dr. Parimala Devi made, what would you investigate, how would you investigate this patient?
So I think we should do a CT urography that would show on the plain scans itself, even before we give contrast, we would see some kind of pneumoperitoneum if there's an obvious leak. And after giving contrast, 2 things we can do. One, we can also place a swab inside the vagina, which would detect a VVF. If it's a ureteric injury, obviously there will be some extravasation of contrast, either outside or into the vault, which would confirm the site of injury.
So this is what was done. So you can interpret it for us, Dr. Santosh.
Yeah, so like I said, you can see some amount of air around the terminal part of the ureter. There's also air around the ureter extending into the lateral pelvic wall. There is, I think, some amount of contrast extravasation, I think, as we see on the around the ureter into the vault.
So the question to all three of you in sequence, Dr. Karthik, Dr. Rubina first, Dr. Usha second, and Dr. Karthik third. How would you approach this, lab or robotic?
Robotics.
Usha ji.
Robotic.
Robotic
only.
So the consensus here is for combined fistulas or for vesicovaginal fistulas, robot is far superior. We'll let Dr. Karthik lead us through our in-house expert on managing robotically gynec fistulas. Dr. Karthik. So I will let you go through the repair.
So basically, initially we go ahead first assessing where the injury right is. So we do a cystoscopy. The patient was already stented, but then ideally you have to remove the stent and put RGP or a retrograde pyelogram to see where the level of injury is. We keep ureteric catheters in place. In this patient, she had both a VVF and a concomitant UVF. The conundrum here was whether we operate from inside the bladder or outside the bladder. Traditional repair involves opening the bladder, bivalving the bladder and repairing it from inside. Here it would have been a more morbid surgery because she had just undergone a bigger surgery earlier. So we decided to go ahead with extra vesicle repair. You could see both the injuries from behind the bladder. The ureter was disconnected from the bladder. The sine qua non of, or the most important step in any fistula repair is to freshen the margins, because the margins are necrotic or fibrotic, and if you just excise and if you don't excise, there's every chance that it can fail. So we did a posterior repair, and the basis of any fistula surgery is close the vault transversely, whereas you close the bladder vertically. And here we also had to do a ureteric reimplant. And when we do a repair, it's a suprapubic catheter it could be a debatable this one, whether you can put a large bore catheter per urethra or insert a suprapubic tube. But in this patient, because she has already had a leak and she was 2 weeks prior to she had undergone a major surgery, we decided to put a SPC also in this patient.
So the point here is, after over 250 gynec fistula experience, most of them open before we move to the robot. The problem in gynec fistulas is reaching the fistula. It's deep in the pelvis. It is a field that has been operated upon recently, or in the previous era operated upon 3 to 6 months prior with diversion. The problem in treating them is to reach them. The robot looks below up, especially with 30-degree up, as compared to open surgery where you have to bivalve the bladder. So the robot is an extraordinary help in treating gynec fistulas. Now I'll go back to the three gynecologists on the panel and ask them, would they want to do it early or would they want to do it late? Starting with Dr. Parimala Devi, then Dr. Usha, and then Dr. Rubina.
It is always better we do the early repair, but unless there is some inflammation, there is already an attempt of repair, there is some inflammation, you would like to wait for some time. But earlier the repair tissues are more healthy, the success also is better. That will be my opinion.
I feel delayed repair is always better. One, because if it is very small injuries, conservative approach might close it up. And a better track is formed, so there is lesser inflammation, lesser infection under which you are operating. So tissue planes also can be dissected better. I mean, of course, there are pros and cons of both of it, but I would prefer delayed repair. Of course, for the patient, it would be a little more cumbersome to manage with the catheter for a longer while, would mean more morbidity, but the outcomes and the success rates are better when done delayed.
Dr. Rubina.
Unless it's a sub-centimeter fistula where we have decided not to operate and we think it will heal with the catheter, always early. Earlier teaching was late, wait for it to heal, but with the robot technology, always early repair is the best.
Dr. Karthik, if you're called on table. if you're called on table, would you repair it or you would defer the repair?
Basically, ureteric injuries following inner hysterectomy are usually thermal injuries. I wouldn't have stented itself in the first place. If I said that there was a rent in the ureter, it is always safer to reimplant the ureter rather than do a primary closure of the rent and put a stent. That is one. Second,
yeah, go ahead.
And early detected rent in the bladder is always closed primarily rather than late. So the basis of this is early detection during the intraop period. And if a urologist is called intraoperatively, I think the primary repair is the best repair.
So in the era prior to the robot, late repair was preferred, as Dr. Usha said. But with the robot coming in, we are able to repair it early, diverting it upstairs with PCNs or leaving the patient in a diaper. The emotional scarring will never go away, especially if the lady is in the active period of her life. So if possible, early repair, and if you are technically capable. The other part is large hospitals like ours with collaborative practice allows the urologist to be informed the previous day if you anticipate injury. So that brings us to the next question, again in sequence to the three gynecologists, starting with Dr. Rubina and Dr. Usha and Dr. Parimala Devi. What would you plan or what would you do with such injuries?
So one, with the robot, the magnification itself shows me beautifully the ureter, the peristalsis. Second, I can put in an ICG, see the ureter with the Firefly. Third is, if I'm anticipating injury, I will stent prior to the procedure and then dock and go ahead.
Dr. Usha.
So my preparation would start pre-op in correct patient selection and then properly diagnosing the patient, starting with pre-op imaging itself. Now when we, especially these kind of cases would be in severe endometriosis that we're seeing every day these days. So proper imaging prior itself. We do a combination of ultrasound and MR imaging. We put in rectal contrast and we do MR. And we know where the disease is and if there is ureter involvement or bladder involvement, so I have the urology team involved prior itself. And we have the ICG installed. So we are able to delineate. Suppose on table, if we find that there is a frozen pelvis, I would better delineate the ureter or do ureterolysis, respect the vascular supply to the ureter. According to that, I dissect out the bladder, mobilize it, and then do the surgery.
Dr. Parimala Devi.
Once we know the diagnosis and what is the intensity of the fibroid, whatever the tumor we are operating and the hydroureter, whatever we have diagnosed and come to a conclusion, I would like to start, because I have started my robotics and all recently. I would like to do the stenting. Even though Rubina will be telling, don't want, I will be pestering her many times when I take the help to do the stenting and all. And depending on that, and also the ICG which has helped now, may be the one thing I would like to take the precautions.
In large centers like ours, ICG has become the norm. We have, urology has added a lot of procedural value to the gynecologist by becoming the team that does ICG, but I see in the next 2 years gynecologists doing it themselves. One last question to the three gynecologists. Would you add to the consent counseling that the possibility of ureteric injury exists? And in such cases, inform the urologist prior? Thank you for what would constitute a collaborative urogynec practice. So the urologist and the gynecologist should meet more often on coffee and help the patient who comes to them in trust for a better quality of outcome. Thanks for your time. Thank you.
Anybody has any questions for the doctors? If anyone has questions, you may raise your hand. We'll pass on the mic to you. Okay. Thank you, Dr. Mohan and the panelists. Moving on to our next case. The topic is navigating complexity with robotic precision, green lights and red lights. To moderate this discussion, I would like to invite on stage Dr. Divya Kateva, Consultant Obstetrics and Gynecology. Joining her are our panelists, Dr. Gayatri Dinesh Kamath, Additional Director, Gynecology, Dr. Santosh Krishnamurthy, Additional Director in HOD Radiology, Dr. Rahul Kanaka, Additional Director, Surgical Oncology and Robotic Surgery, Dr. Nagarjun BR, HOD Consultant Pathologist, Dr. Shubha Charita, Consultant Anesthesiologist. Over to Dr. Divya.
Good morning, everyone. I welcome my panelists here for this session. So we're going to talk about robotics in gynecology. To save time, we'll straight away move with our cases. Our first case is a 60-year-old woman who came in from Kolkata. She came in with complaints of postmenopausal bleeding. She had already undergone twice attempted hysteroscopy polypectomy, and both times the procedure had failed. On ultrasound, she did have a large endometrial polyp with a vascular pedicle. The patient's preference was very clear. She wanted only one procedure, so one and done. Dr. Gayatri, when you met this patient in your OPD and she was so clear as to what she wanted, what did you offer her?
Yeah, this lady was very keen that she has a single surgery. She had she had visited places in the past where a biopsy was attempted and the tissue was insufficient. In fact, there was a huge polyp and she was very keen to have a single procedure. With that in mind, considering she was 60-year-old, there was a high suspicion of malignancy. So I told her if she needed a single procedure, the best option would be to consider a sentinel lymph node biopsy, and then if it turns out to be a benign, just get away with a hysterectomy. The other options would be to do a total robotic hysterectomy and a bilateral salpingo-oophorectomy, look at the frozen, and then look at a retroperitoneal lymph node dissection. And I told her the evidence would be for a hysteroscopic polypectomy, and then do the second step, but she was vehement, and then she chose the single-step procedure. So I did explain to her as to how we put the ICG. We inject it at the cervix and look at the striking lymph node, and that would be the sentinel lymph node which would be sent for a biopsy. And she chose that option.
Right. Thank you, ma'am. So she chose the option, and that is how this patient underwent a robotic hysterectomy, wherein first the SLNB was performed and sent for frozen, and then the hysterectomy was done. The SLNB came out to be negative for any kind of malignancy. So, Dr. Rahul, what is the current evidence regarding the role of SLNB in endometrial cancers, and also where we don't have a definite biopsy, but there is a strong suspicion of malignancy?
Yeah, so doing sentinel lymph node biopsy is a minimally invasive kind of procedure. When we were earlier doing a bilateral pelvic lymph node dissection, we used to have a lot of complications in the form of lymphocyl lymphedema formation as high as 40%. With sentinel lymph node biopsy, we are able to identify the most significant node, which is the sentinel node, which is the first draining lymph node of the uterine cancer, which is usually located at the obturator level. So if we dissect that only lymph node without disturbing the other lymphatic pathway, the side effects related to the lymphedema and lymphocyl formation can be avoided. Thereby, post-op recovery becomes very faster, and any adjourned form of treatment, if we are deciding after the surgery, we will be able to do it. And since we have a very good pathology support here, with the sentinel lymph node biopsy, they can even detect isolated tumor cells. Isolated tumor cells, micrometastasis and macrometastasis. So the accuracy is very high as 97%.
Right, thank you, sir. So, sir, as you rightly said, the pathologist plays a very important role in how we take care of our patients intraoperatively. Dr. Nagarjun, so much we depend on frozen sections and what comes out of the lab waiting inside the OT. What do you think are the policies, and how much can the frozen and the definitive report at the end of the week change?
So coming to the nodal sentinel node staging on frozen section. So once the node is sampled, we take multiple sections and take imprints as well to make sure that we are not missing out the smallest of small foci that is there in the node. But sometimes what happens is that very rare scenarios where in frozen we may call it up as a negative, and when we take further deeper sections, we may start seeing some small ITCs or micromets that are showcased in the final histopath sections. This happens due to frozen is a rapid technique and we are racing against time. So we take 1 or 2 sections, and sometimes when histopath, what happens is that we have a well-fixed tissue and we are having the opportunity to take multiple sections. So this kind of situations are rarely encountered but not very common. This happens only when the lesion is a micromet or a ITC. A macromet, most of the times we are diagnosing it on frozen section itself. Yeah.
Right. Thank you, sir. And you're obviously giving a great support to the surgeons in the OT. Moving on to the next case. This is hysterectomy in a young nulliparous woman. So she was 35 years old who had been suffering with severe dysmenorrhea and menorrhagia for years. She'd been refractory to non-surgical treatment and high-risk factors. Apart from the high BMI of 36, she was suffering from multiple drug allergies. You can see the list on the screen, which included commonly used gynec drugs like progesterone, tranexamic acid. What confused her scenario further was the ultrasound, which showed evidence of deep infiltrating endometriosis, and the MRI showed no evidence of any endometrial foci. Dr. Gayatri, when you're usually not in favor of hysterectomy for such young patients, what made you offer it in this case? And also, what extra precautions or procedures should we follow while we offer hysterectomy to such young women?
Yeah, this was a real challenging case. She was too young for a hysterectomy, and the way she was distraught with her, quality of life got us really worked up. She was referred primarily for a hysterectomy because no hospital was willing to take her with her high BMI and the multiple drug allergies she had. So initially, I just said, you're not fit for a haircut as well, just like how Dr. Murli said. But then we tried to give her some GnRH antagonists to help her overcome her pain, but she had allergies to that as well. And then our physician refused fitness initially, but eventually we did have to succumb to her request of a hysterectomy because her quality of life was really miserable. She could not take any painkillers, and then she had deep infiltrating endometriosis is what we thought, and then multiple fibroids, so we decided we would go ahead. And considering this young age, we do take precautions, we involve multidisciplinary team, we take second opinions, we try to convince, we have a counselor, and with all this, we went ahead, going ahead with the hysterectomy.
Right, ma'am. So to begin with, Dr. Shubha, when you saw this patient for the pre-anesthesia checkup and the multiple risk factors that she came in with, how did you plan her intraoperative and post-operative care, and what challenges did you face?
First thing, while history-wise, as you said, she gave with multiple drug allergies. The patient was also meticulous enough to note down all the drugs she has used in the past and she was not allergic to, including anesthesia medications and analgesics. That made us easy to plan her procedure with whatever she has already been exposed to, rather than introducing a new drug into her system. With her history, along with drug allergy, she also had a BMI of 34 to 35. She was nearly morbidly obese, and also since it was a hysterectomy with steep Trendelenburg and a pneumoperitoneum, we also anticipated the challenges with ventilation. So I was privileged to have my lead, Dr. Murli sir, for this case to start with. So to start with, we avoided any drugs she had not taken previously. We kept all the medications, including medications for anaphylactic reactions, difficult airway trolley, and invasive lines. We were well equipped, well geared, and once we stabilized the patient, we intubated with vecuronium and sevoflurane induction, which she had taken in the past. So all invasive lines. She was also to mention that she was high risk for difficult cannulation also, so we put in an intravenous line and took a strict DVT prophylaxis with intermittent Flotron pump. So post-operatively, she came out very well. We could extubate her on table. The cerebral edema was minimal. She was out of anesthesia without any event. Only event we saw in the post-op was she was allergic to the adhesive, which we had put in for the central line, which was superficial adhesive. So that we recognized it earlier. We could treat it with just superficial ointment, and patient went home well, uneventful. And her pain was very well controlled because she was not allergic to fentanyl.
Yeah, thank you. I think the credit goes to you. Santosh sir, many a times we see the MRI and ultrasound reports not matching. So if you can walk us through the MRI briefly and tell us what made you think that the MRI had absolutely no evidence of endometriosis.
So I think one of the important things for investigation of endometriosis is MRI. MRI is now considered as good as the ultrasound for deep infiltrating endometriosis. Of course, endometriosis in ultrasound we can make out very small deposits. Sometimes on MR it's very difficult to make out, but we have now developed certain sequences with very high resolution in our 3T MRI. So here any stage of blood can be made out on MRI. So MRI would detect in fact all stages of hemoglobin, whether it is acute or chronic hemosiderin or anything. So this patient has had some dark hypointensities which was posterior to the uterus on the MRI, which didn't show any evidence of hemosiderin or anything. So that made me think that there is no hemorrhage or hemosiderin. In endometriosis, that's the classical sign. Patient keeps bleeding repeatedly, so they would have some amount of hemosiderin at any point of time.
So you were spot on with your diagnosis. So Dr. Gayatri, if you can take us through the OT findings with respect to her symptoms.
So her consenting was taken for a hysterectomy and a bilateral salpingo-oophorectomy if we found endometriosis. But Dr. Santosh was right, there was no evidence of endometriosis at all. It was basically a dumbbell-size shaped uterus with fibroids present anteriorly and posteriorly, and probably it was torting every time during periods. And along with that, she had adhesions in the posterior pouch of Douglas. So we did go ahead with the hysterectomy, and then we did the contained in-bag morcellation. And with that, the surgery went off very well, and her symptoms were relieved. And as Dr. Shubha said, she recovered on the next post-operative day, and then she walked about, and she's happy with her outcomes.
Right, thank you, ma'am. So due to lack of time, we'll move on to our third case. Our third case is of, again, a lady who came in with supposed bleeding. And she had endometrial hyperplasia with atypia. So Dr. Gayatri, how did you counsel her for surgery?
Yeah, just like the first case, we did give her all the options. We actually told her to go ahead with a sentinel lymph node biopsy, but she was very vehement in denying that she had malignancy because she had biopsies in 2 places. We did explain to her that there's a higher chance of picking up malignancy, but she chose the option of doing a total robotic hysterectomy and a bilateral salpingo-oophorectomy. And later, as an afterthought, they decided to go ahead with a frozen section. And that's what we performed.
So in this case, the frozen did come out to be positive for malignancy. Dr. Rahul, when you're called in, once the hysterectomy is done with a positive frozen and you have to go ahead with pelvic node dissection, what challenges do you face and how does robotic help you in a scenario like this?
So with pelvic lymph node dissection, as earlier we were doing, but with the sentinel lymph node dissection, the number of side effects will reduce. But when we have a situation where sentinel lymph node cannot be performed because of hysterectomy done already, we proceed with bilateral pelvic lymph node dissection. The main complication related to PLND would be lymphocyl formation and lymphedema of the both lower limbs post-surgery. And sometimes, since we are operating around the major blood vessels, there is a risk of injury to the blood vessels and also the important nerve which goes around that, which is the genitofemoral nerve. We tend to injure that because it may be involved in the lymph nodes sometimes. So we always try to avoid PLND as much as possible for the uterus confined disease. But when there is absolute indication, still PLND is a indicated procedure. And if at all our sentinel lymph node biopsy fails, which can happen in about 10 to 20% of cases, we still have to proceed with PLND.
Thank you, sir. Dr. Nagarajan, this patient did come up with endometrial carcinoma. So between Dr. Rahul and Dr. Nagaraj, if you can let us know what further investigations we do in terms of the molecular classification and how does it help us to treat the patient better?
Yeah. Once in histopathology, we are labeling it as an endometrioid adenocarcinoma or a serous carcinoma. The next step of investigation is immunohistochemistry, because this has a tumor prognostic markers that will determine the further therapeutic management. So the first thing that we look, the clinician request is for MSI immunohistochemistry, pole mutation, and P53 mutational status, because these are very important that they are going to determine the further line of management, whether to continue the treatment or discontinue it. So these are P53 and MSI are immunohistochemistry based testing modalities, and pole mutation is a molecular based testing where we do through NGS or the Sanger sequencing method. Apart from this, we look for the ER and PR status, and if it's a serous carcinoma and endometrium, even HER2 as a prognostic and a therapeutic role in management.
Right. Thank you, sir. With this, we finish our 3 cases. Any questions from the audience? Right. Ma'am, any closing comments?
So I think for a gynecologist to be happy, they need a robo, a multidisciplinary team, and a friendly anesthetist. And then life is quite cool. Thank you.
Thank you.
Thank you, Dr. Divya and the panelists. We will take a break from the panel discussions, and we will now move on to What's New Innovation Capsules, a series of rapid-fire expert talks highlighting the latest developments in robotic surgery. For our first innovation capsule is by Dr. Punyashri, Associate Consultant. I'm sorry.
So the topic for today is techniques for difficult tissue extraction in gynecological surgeries. So this is the evolution of surgical techniques that we have had, from open to laparoscopy to robotics. We till date do all of this and tailor make it to the patient's and the disease status. So this was the incision I used to plan and draw. I'm an artist too, so I used to love doing this on the patient. And this is the vision that I used to get after opening up the patient. And this is how I closed her up, and she used to come 2 weeks later with this kind of a scar. But this is what we see outside, right? So, but what's happening inside is this. So when I met Mohan sir and Rubina ma'am, they introduced me to minimal invasive gynac surgeries. And this was a picture taken 8 years ago, and you can see my little hand being proudly holding the huge uterus, and there you go, the specimen is already in my hand. Am I really proud of this? And now that I'm not sure, because thanks to the surgeons, I am really not proud of this picture anymore. So introducing to MIGS,
it's redefining surgical care in modern gynecology, and the primary goal being to achieve better outcomes and while significantly reducing the pain, visible scarring, and overall recovery time. And this is a paradigm shift in surgical approaches that we can see in the last 2 decades. And so when MIGS is becoming so popular, we need to know why the specimen retrieval matters, and that's what I'm going to talk about today. So by opening, the specimen already was in my hand, but now with minimal invasive, it's going to be cruel if we give a huge incision just to remove the specimen out. So it is a critical step in minimal invasive surgeries. It impacts the operative time, it impacts the complications, cost messes, and oncological safety. So the challenges being that we do minimal invasive surgeries for large uteruses. The largest that we have removed is a 2.8 kilos uterus minimal invasive technique. Multiple fibroids, large ovarian cysts, deep infiltrating adeno and endometriosis. And we usually get patients with morbid obesities and narrow vaginal canal and had prior previous surgeries. So these are the kind of surgeries that we've done for huge uteruses and endometriosis and ovarian masses. So the evolution also changed for the specimen retrieval. For open surgeries, it was really easy. Then we had the vaginal extraction of the specimens. We had the power morcellator coming up. Then came the FDA that one saying that no more specimen retrieval without containing them. Why was this brought up is because initially they thought that the incidence of a sarcoma in a fibroid uterus operated for a fibroid uterus was 1 in 10,000. But currently, if we see that, it is 1 in 200 to 1 in 2,000. So the sarcoma chances are quite high. So the FDA came up with a warning in 2014 saying that no specimen has to be extracted without containing them. So that's the phase when the contained morcellation started, and we also have natural orifice specimen extraction techniques. So how to decide which technique to adopt to get the specimen out? So it depends on whether the disease is benign or malignant. Is intact retrieval really required? Vaginal access is feasible or not? And also depends on the specimen size, and all these will help us in selecting the retrieval method. So the classification of retrieval methods are the natural orifice techniques through the vagina, and abdominal techniques wherein you could give a minimal laparotomy incision or extend the port site, and fragmentation, which can be done vaginally, manually, or using a power morcellator. So the most common retrieval technique after TLH is the natural, the vaginal technique by Y-valving, coring, wedge resection, or enucleation. And whenever there's a difficulty extracting vaginally, we usually, the tips are that there should be adequate traction, sequential debulking, use good grip equipments, and posterior colpotomy extension. This is where if you want the uterus to be intact, you can always give a posterior colpotomy and extract the specimen through these, especially when you're doing a sentinel lymph node dissection where you do not want to do the hysterectomy before doing the sentinel lymph node. So that's when you can use these techniques. It avoids incision, it avoids scars, it is less painful, and port site hernias are also reduced. There, of course, are the abdominal methods of extraction wherein you could give incisions, and especially useful for giant specimens and suspected malignancies. And the port site extension is the most common that we do. Very simple. Maybe we can extend the port by another 1.5 to 2 centimeter and retrieve it in a bag. So there are certain instruments that are available, like the Lexus Retractor Gel Point Mini, which help in reducing the contamination and also facilitate the extraction easily. So there are retrieval bags like this, like the Easy Catch, prevents spillage. And this is how we put the specimen into the bag and then do morcellation either by power morcellation or open technique. So the exact technique is which we have adopted recently, and it's called the extracorporeal C-incision tissue excision, wherein we again bag it and we do something called the apple peeling technique. So this is how it is. Traction, counter traction is given, and the specimen is Can you please play this video? So we have put in the Alexis retractor. The specimen is in the bag and being taken out of the retractor, and with the traction in the right direction, only a C-shaped incision is made on the same side every time we pull the specimen out. So that's how you get a long length of specimen, and it's all intact. And it's not like we're getting it out piecemeal. So this is a very quicker method compared to the power morcellation technique as well. So we can do this procedure abdominally or vaginally also, wherein the same Alexis retractor is put through the vagina. This is a power morcellation, wherein we put the MorSafe bag, which has a tail and a head end. Through the tail, we put the camera, and through the head end, through the neck, we put the morcellator and do the morcellation inside the bag and remove the bag later. In gynec oncology, intact specimen retrievals is very important wherever possible. Avoid tumor ruptures and use retrieval bags regularly. So the emerging technologies are, there are smart retrieval bags, there are robotic assisted extraction methods that are being, that's going to come, and magnetic assisted retrieval bag, wherein there would be magnets which will actually hold on to the instrument, so there's no leakage of the specimen or the gas, and single port surgeries as well. So the key take-home message is that patient safety is utmost important. Do the containment wherever possible and avoid uncontained morcellation. Tailor the retrieval technique to each patient based on the disease and also the size of the specimen. Thank you.
Our next speaker is Dr. Nagendra Tripathi, consultant urology, uro-oncology, andrology, and kidney transplant, and he would be presenting on the topic Seeing Beyond Pressure Curves. Please welcome Dr. Nagendra Tripathi.
Thank you, Ms. Jessica. Good morning, everyone. Today my topic is video aerodynamic study. So, it's not moving. Okay. Sorry. Yeah. So this is our aerodynamic suite in Fortis, Bangalore. So the main thing to see is how is the C-arm aligned to the patient. So video aerodynamics is not routinely for everyone. It has specific indications where we need more than what a aerodynamic can give us. So these are some of the indications for video aerodynamics, especially the neurogenic bladders. This is where the EAU guidelines gives a strong recommendation for a video aerodynamics. So these are the different things which you can know from a video aerodynamics, like the bladder morphology, trabeculations, bladder neck competence, neurogenic detrusor overactivity, reduced compliance, onset of VUR, detrusor pressure at onset of VUR, and also the detrusor sphincter dyssynergesia, bladder neck, whether it's opening or not, the urethral configuration, and residual urine. So the critical conceptual shift in video aerodynamics is we no longer say that the patient had VUR. With the aerodynamics, you can actually pinpoint and say that the patient had VUR at this bladder filling, like 100 ml or 500 ml, at what level of bladder filling and at what pressure the VUR of the bladder, the VUR is starting. So that gives you a difference. I'll come to that. That shows that even though many patients have VUR, they are totally different the way they are. So these are three different pictures. They might look almost similar at the outset, but in the first picture you can see that the bladder is very small and the VUR has already started. So this is typically a low compliant bladder, and that is because of that the VUR has started. The second one, you can see that there is a flow in the urethra, and then you can see that there is a reflex, and the period is 90. So this particular patient, the problem is at the bladder neck, not at the bladder, but it's at the bladder neck. He is straining against obstruction, and that's the reason he is having a VUR. The third patient, you can see that there is no urethral contrast. This is a filling phase, and the period is only 14, but there is VUR. So this patient has a problem at the VUJ. The reflex is starting at a very low pressure. So there are three different patients. One has a problem in the bladder who needs augmentation cystoplasty. The other one has a problem at the outlet, which needs correction of the outlet. The third one has a problem at the VUJ itself. So that is what you can know from a video urodynamics more than this is what exactly it adds to a regular urodynamics. So the regular pressure flow study, it says that there is a high period, there is a low Qmax, and there is obstruction. The video adds where the actual obstruction is, and also the site and the mechanism of obstruction. So they are the similar uroflow curve, but then different video urodynamic findings and then the different diagnosis there. So one is the failure of funneling or defect at the bladder neck. So basically a primary bladder neck obstruction presents it that way. Then there is, I will be showing the pictures for this. Then there is bladder neck is open, but there is narrowing at the external sphincter, a typical detrusor sphincter dyssynergesia. Then there is a fixed urethral narrowing, probably an anatomical urethral obstruction. There is a low period, low pore flow, and an open outlet, showing that it is a detrusor underactivity. And then there is a post-sling patient with a fixed narrowing at the mid-urethral level. So you can conclude that it is because of the sling, the tight sling. So the most common indications for video urodynamics is actually the neurourology. You can follow up, to be honest, all the neurourology patients should undergo a video UDS when possible. So these are the different things which you can see when you do a video urodynamics, like the neurogenic detrusor overactivity, detrusor sphincter dyssynergesia, assessment of bladder compliance and high pressure storage, VUR during filling or widening, and post-reconstructive assessment. Then it is also indicated in young men with LUTS and suspected functional bladder outlet obstruction to differentiate between dysfunctional widening or primary bladder neck obstruction or underactivity. It's also indicated in complex widening female dysfunctions like bladder neck obstruction, mid-urethral obstruction, dysfunctional widening, post-anti-incontinence surgery, detrusor underactivity, and also in complex reconstructed urinary tracts like augmentation cystoplasty, bladder neck reconstruction, artificial sphincter insertion, and previous pelvic or outlet surgery, and persistent unexplained LUTS even after intervention. So the conventional UDS tells us basically the video UDS adds anatomy to the physiology of the conventional UDS. So the conventional UDS tells us about the pressures, about how the bladder is behaving, but the video urodynamics tells us where exactly is the problem happening. If there is an outlet obstruction, then where exactly the obstruction is happening. If there is a VUR, then at what point exactly the VUR is starting and why is it starting. So you can see here, this is a female patient, 35-year-old, a totally closed bladder neck, compared to another 23-year-old female patient wherein there is a open bladder neck, but then at the level of the sphincter there is a cutoff. So this shows that this is a detrusor sphincter dyssynergesia, whereas the previous one is actually a primary bladder neck obstruction. So even here you can see the pDET while filling is only 20, but then the reflux has already started. So, and you can also see that the bladder capacity is not that great. It's not fully filled. So basically this is a pop-off mechanism wherein the urine is entering the kidney and the ureter even before the bladder pressure. So, thank you.
Thank you, Doctor. Moving on to our next presentation, the topic is elegant solution for urinary incontinence, and to speak on this, I would like to invite on stage Dr. Basavaraj Neelagar, Additional Director, Urology, Uro-Oncology, Urogynecology, Andrology, Kidney Transplant and Robotic Surgery. Please welcome Dr. Basavaraj.
Morning, everyone. Last evening we had a well-attended workshop on the same sacral neuromodulation. For those of you who missed it, I'll be just giving a bird's eye view about this innovative therapy. So what is sacral neuromodulation? It is a proven minimally invasive tertiary therapy for refractory lower urinary tract and bowel dysfunction. It is nothing but a pacemaker for the bladder. So there is a neuromodulator which is connected to a lead next to the S3 nerve. That's the target nerve we will be interested in. And the patient will not have anything outside. Everything will be under the skin. And this therapy is like a fit and forget therapy that works for about 12 to 15 years at least. That's how the device looks on the X-ray. So what are the core clinical indications? One is the overactive bladder, which may be refractory overactive bladder with incontinence, or dry overactive bladder, that is just frequency urgency syndrome, and non-obstructive urinary retention, which is hypocontractile bladder, diabetic cystopathy, and Fowler syndrome, that is overactive urethral sphincter, especially in women, and fecal incontinence of any etiology, be it idiopathic, neurogenic, post-surgical, post-obstetric injuries. So the brief video about the mechanism of action.
Medtronic sacral neuromodulation delivers electrical stimulation to a sacral nerve via an implanted neurostimulator. The neurostimulator provides an electrical charge to an area near the sacral nerve, resulting in altered neural activity. This stimulation likely depolarizes the nerve, causing an action potential that propagates impulses along the axon as if the neuron naturally fired an action potential. As a result, it is thought that abnormal sensory input from the bladder is modulated. OAB patients with sacral neuromodulation exhibit patterns of brain activation similar to that of patients with normal function when compared with OAB patients without sacral neuromodulation. These effects are observed in areas of the brain involving sensation, awareness, urge, and timing of urination. This
So it mainly affects the afferent pathway modulation. Whenever there are abnormal signals being carried from the bladder or the pelvic organs to the brain, the neuromodulator modulates all the abnormal signals and sends in normalized signals. That's how it works. The afferent pathway is not affected. So what are the inclusion criteria? Mainly it is refractory overactive bladder, not responding to standard medical therapy in the form of anticholinergics or beta-adrenergic drugs, failed or couldn't tolerate the side effect of these medicines. Nearly 90% of the people will not be able to continue this therapy because of the intolerant side effects. For hypocontractile bladder, bladder pressure should be minimum of 15 centimeters of water on urodynamic study, and PVR must be less than 400 ml. For the diagnostic evaluation is simple, 3 to 7 days of bladder diary, urodynamics in case of a diabetic cystopathy or hypocontractile bladder, cystoscopy in selected cases. So it is a two-stage surgical procedure. In stage 1, it's the trial phase. It's a daycare procedure, takes about 1 to 1.5 hours. We place the lead and connect to an external nerve stimulator, and patient goes home on the same day and maintains the bladder area again for the next 3 to 14 days. If there is at least 50% improvement, it is defined as successful, and we can go for the stage 2 permanent implant, again, which is a daycare procedure. After that, patient will be on long-term care. Suppose there is not much improvement, or patient is not happy with the relief it is providing, so we just take out the lead and patient can try the alternate therapies. So what are the clinical efficacy and success rates? Robust long-term outcomes of about 80% sustained symptom reduction rate over a period of 5 years. So comparing it to the other therapy option available in the same category, that is intravesical Botox injection, primary mechanism for SNM, it is continuous nerve modulation, whereas for Botox, it is detrusor muscle paralysis. Test phase is available for SNM, but there is no testing for the Botox. Once the injection is given, we have to wait till the 6 months or 9 months till the effect of the Botox is gone. Catheterization risk 0% in SNM, it is 10% in Botox therapy. Risk of VTA is only 10% in SNM, whereas it is 24% in intravesical Botox. Duration of effect 10 to 15 years, that is long-term device, and intravesical Botox 6 to 9 months, and repeat injections are essential. Also, the SNM therapy helps in treating the concurrent bowel disturbances like chronic constipation, fecal incontinence, which is seen in about 65% of the people with overactive bladder. Multidisciplinary referral, many specialties come across these patients with urinary symptoms. So globally, about 80 to 85% of the SNM procedures are being conducted by urologists, 15 to 20% of the procedures by colorectal surgeons, less than 1% by neurosurgeons. Early referral is important so that the treatment can be initiated early and the irreversible bladder changes can be prevented. Also, anybody who is on anticholinergic medicines for more than 3 months, they tend to have cognitive impairment, and risk of dementia increases by 46%. And if the medical therapy is continued for 2 years, the risk of dementia increases up to 54%. So that's why early referral is important. Primary care physicians come across these patients. They should, instead of putting them on long-term medical therapy, better to provide them that this option is available. Gynecologists, they can evaluate the pelvic floor, rule out the prolapse, and send the suitable patients for functional storage disorders. Colorectal surgeons, general surgeons, they will come across patients with fecal incontinence and double incontinence. Neurologists and neurosurgeons, they identify the patients with neurogenic bladder and bowel, and they can send the suitable patients. Thank you.
Thank you, Dr. Basaraj. For the next topic, I would like to invite on stage Dr. Mohan Keshamurthy, Principal Director, Renal Sciences. He would be talking on Urolift, innovative solution bridging medical and surgical management of BPH. Over to Dr. Mohan.
Good morning once again. Urolift is an innovative technique for low volume BPH, especially for those in whom sexual function preservation is essential. One of the reasons why alternative therapies are necessary for BPH is medication do not provide long-term solution, although it does provide an interim bridge for most patients with troublesome symptoms of benign prostatic hypertrophy. Many of them would discontinue therapy because of the side effects and would not seek definitive therapy because of the fear of the complications or side effects of TURP. So Urolift is a very simple mechanical system. The benign prostatic hypertrophy obstruction of the urinary flow is a mechanical problem. This is the only mechanical solution for what is obviously a mechanical problem. It can be performed effectively by putting across what I call as rubber bands or termed as pillars. So you just push the tissue away. If the road in front of your house is encroached by a fruit seller and by a vegetable seller, you just push them back onto the footpath to keep the road open for your vehicle to exit from your house. So it's basically widening the road, widening the prostatic urethra using mechanical rubber bands. And that's how it looks before and after. So this is an actual procedure. So you can, we start off with a cystoscopy, which is routine for any definitive procedure of benign prostatic hypertrophy. So here you can see obstructive lateral lobes, that's a verumontanum, marking the distal limit of the prostatic urethra. Once you have done that, you use a customized cystoscope to deliver the pillars. We usually deliver pillars at 2 o'clock, at 9 o'clock, and an additional pillar at 5 or 7 o'clock to create a Mercedes-Benz kind of eccentric expansion of the prostatic urethra. If you put it at 3 and 9 o'clock symmetrically, you will get a fish mouth effect, which should be avoided. The idea at all points in time is to open up the bladder neck portion of the prostatic urethral obstruction. So this is the first pillar being placed. So what we do is, as I said, the first pillar we usually place at 2 o'clock, and here we push forward till you see the white band, and then we use the customized cutter, and then you go back into the prostatic, go back into the bladder. You can sequentially place multiple pillars, and at all points in time, opening up the bladder neck is the point of interest. So there is extensive clinical evidence. Obviously, it's only about 2% as compared to a bipolar TUR, and maybe about 20% as compared to a laser TUR in terms of completed volumes with significant length of follow-up, which is either 5 or 10 years. But it is clear that the RCTs say that the results in terms of uroflow and symptom relief is comparable to the gold standard, which even today is a bipolar TURP. The obvious advantages: no retrograde ejaculation, so obviously sexual function preserving. Younger patient, a patient who intends to be sexually active, this would be the technique of choice. It's also a daycare procedure for those who are high risk for anesthesia. My colleague Dr. Karthik is an expert in perineal block to do it under local anesthesia. And it is also an extremely interesting technique if you look at the possibilities of what is not possible with the other techniques, which is rapid recovery, daycare procedure, minimally invasive, no need to stop anticoagulants. You can restart blood thinners right after the procedure, has the lowest indwelling catheter rate of all more than 1 million procedure-based BPH solutions. And as I said again, it is durable in symptom, in relief of symptoms, and can be performed under local anesthesia. So for those who are younger, with below 60 grams of prostate size, it can be done till 100 grams, but it becomes more expensive because you'll need up to 5 to 6 pillars. Only 2% of our experience over 300 cases has been with more than 4 pillars. We generally put between 3 and 4 pillars where it is a cost-effective solution. We are the center of Urolift education for the whole of South Asia, where we periodically conduct colleagues who are interested, conduct continuing medical education programs for colleagues who are interested to enter this new endeavor in solving what is a growing phenomena with increased life expectancy, not just in our country, but across the world. Thank you for your patience.
Thank you, Dr. Mohan. Moving on to our next topic, JOGO, integrating technology into continence care. And to speak on this, I would like to invite on stage Dr. Karthik Rao, Additional Director, Urology, Uro-Oncology, Andrology, Kidney Transplant and Robotic Surgery.
Thank you for this opportunity. Good morning, one and all. So I'll be talking about JOGO. So what is JOGO therapy? It's a kind of physiotherapy which involves biofeedback also. Now, why biofeedback? Recently we had the opening of our incontinence clinic, and a patient put us in quite an embarrassing situation because he wanted to see a video how Kegels is done. Now, how can you show a video to a patient to contract his pelvic muscles without somebody undressing? So it's a very embarrassing question which was asked, and it can only be shown to an individual patient on himself or herself how a Kegel's exercise can be done. But do we have something where the patient can know whether he's contracting the right muscles or relaxing the right muscles? That is what is Jogo therapy. It's a non-invasive electromyogram biofeedback based physiotherapy. It addresses a core clinical problem which I just said, and traditional physiotherapy of biofeedback involved only vaginal cones or verbal cueing, and it's difficult for patients to adhere. So Jogo completely replaces this guesswork, and there is something called as neuroplasticity, which is an add-on to the existing pelvic health system pathways. So how does it work? Surface electrodes are placed around the region of interest. Real-time feedback is displayed to the patient in the form of curves. When we ask them to contract the muscle, the graph will show whether they are contracting it adequately and with what power. And the other way around is also true when the patient has a voiding dysfunction, whether he is relaxing the pelvic muscles adequately or not. This reinforces the brain-muscle connection, and over time this improves the voluntary control over urination, continence, as well as urinary flow in case of voiding dysfunctions. Who should be referred? Incontinence, whether it's stress or urge incontinence, a voiding dysfunction, usually seen in young people where they have difficulty initiating or completely emptying their bladder, and it's basically because of wrong toilet training and poor coordination of the pelvic floor and sphincter relaxation coordinated with the bladder contraction. Sexual dysfunction, especially with severe dyspareunia patients, can also benefit from a biofeedback Jogo therapy. So it's useful in complex situations where the pelvic floor needs to be trained, and where patients have struggled with conventional physiotherapy. So to say it is an adjunct to a broader pelvic health pathway, it will not replace completely either a medical or a pure surgical therapy whenever it is indicated. So this is a very short presentation. The protocol involves assessment by a trained physiotherapist. Each protocol is individualized to the patient, and the length of the course is usually weekly once for 8 weeks, where the patient comes to the hospital to see the physiotherapist and see the improvement how much he has had. And each session is supervised, but the patient commitment to the full course is key to the success of this therapy. Both Jogo as well as the conventional pelvic floor physiotherapy, the goal is the same, but the roads are different. Here in the Jogo, the patient is involved, and because of the biofeedback, he is more motivated to do it correctly and for a longer period of time. So it directly addresses the can't find the muscle barrier, which the patients mostly tell us which muscle to contract, doctor, during Kegels. So to conclude, it's a non-invasive biofeedback therapy. It's indicated in various urinary incontinence, voiding dysfunctions as well as sexual dysfunctions. It works by reinforcing the brain-muscle neural pathways over an 8 to 12 week period, and it is best suited in patients who have struggled to engage with or adhere to conventional physiotherapy. We have utilized Jogo in various situations, in mixed incontinence, post-radical prostatectomy incontinence, voiding dysfunctions in very young males, and are found to have a significant effect with this therapy. Because it's non-invasive, most of the patients agree to this form of JOGO therapy. Thank you.
Thank you, Dr. Karthik. To take us through the upcoming sessions, I'd like to invite on stage Dr. Prakriti, attending consultant, gynec oncology, to take over as the MC. Thank you so much.
Thank you, Jessica. A very good morning, one and all. We now have Mr. Abhilash Sarangi, Director Marketing, Intuitive India, who will be speaking on transforming surgery, one patient at a time.
Good morning, everyone. My name is Abhilash Sarangi, and I'm the Marketing Director for Intuitive Surgical, the makers of Da Vinci Robotic Assisted System. It is my distinct privilege to be here. Just a small story before I get started. We first met Dr. Mohan maybe a month and a half back, and he shared his vision for what this event was going to be. And at that time, it seemed highly aspirational, highly ambitious. But I was just talking to Dr. Mohan before I came on stage. If there's one person who could pull off this vision and get this kind of an event set up, it is Dr. Mohan. So congratulations, Dr. Mohan. We are honored to be here, and we are honored to participate in this event. So over the next 20 minutes or so, I want to make 3 simple messages and elaborate on those for this audience here. The first is that robotic-assisted surgery with Da Vinci is widely adopted, and we'll share some adoption trends for robotic-assisted surgery across specialties, both globally and here in India. The second message is that this adoption globally has been built on a robust foundation of data and evidence, and we'll talk about some of that. And finally, towards the end of my talk today, we'll talk about where we see the future of robotic-assisted surgery with Da Vinci going, and what kind of a transformative role AI will play in surgery going forward. At Intuitive, we like to start with our why. Why do we do what we do, right? So for 30 years now, we have focused on advancing care in one area, and that is minimally invasive surgery with robotic-assisted technologies. As an organization, we are not in multiple verticals, orthopedics, spine, neuro, none of that. So we've had our engineering teams, our R&D teams get laser focused on developing technologies, hard, complex technologies to advance minimally invasive surgery. And that, over the last 30 years, has led us to innovate in multiple generations. Several of you in this room are aware of many of these generations so far. We are excited to be bringing the Da Vinci 5, our latest multi-port robotic-assisted surgery platform, to India later this year. So in these 30 years, across the world, in over 70 countries, more than 20 million patients have been treated with Da Vinci robotic systems. And this has been performed by over 100,000 surgeons around the world. Out of these 20 million, 3 million were just in the last year, which shows the growing adoption and demand for these technologies, not just in the developed world, but also in the developing world. To put that in perspective for this room, about every 10 seconds today, a surgeon somewhere in the world starts a procedure on the Da Vinci robotic system. This is an interesting statistic. If you go back to even pre-COVID, 2019, and this is data from the US, laparoscopic, open, and Da Vinci surgery across a range of really high volume procedures. Da Vinci was the third of 3 modalities. Post-COVID, post-hospitals beginning to realize that being operationally efficient was important, sending patients home soon and faster, with faster recovery was important. You began to see an upturn in Da Vinci adoption in the US. Today, Da Vinci for these procedures is close to 50%. More than half or close to half of the procedures are done with Da Vinci in the US. And we are on a similar journey here in India as well. We have over 250 Da Vinci systems across India, and these are not just in the big metropolitan cities, but also in tier 2, tier 3 cities in India today. Close to 200,000 patients today have been treated with Da Vinci robotic surgery. 200,000 patients and their families have been able to benefit from this technology. 45 plus procedure types have gotten indication clearance, and this covers all the way from head and neck to cardiothoracic, general and gastrointestinal surgery, gynecology, urology. So across the board, we've seen adoption across all of these specialties. And finally, in India, we have over 1,300 active Da Vinci surgeons, and this is growing every month. So that brings me to the end of my first message, that Da Vinci surgery is widely adopted both in India as well as in both globally as well as in India. The second message that I started with was all of this has been built on robust clinical evidence. So I'll share one example with you. This is the COMPARE study, a large retrospective meta-analysis, as you can see, covering over 1 million patients each in the 3 arms, open, laparoscopic, and Da Vinci. And the studies that were taken in, about 180 plus publications, span 7 different types of procedures and over 22 countries. So it's a large meta-analysis. And what this found is that across 6 of the 8 outcomes measured, so you can see the outcomes there, conversions, transfusions, complications, mortality, readmissions, across most of these, Da Vinci, across this meta-analysis, was found to have better outcomes versus both laparoscopic and open surgery. The only place where it fell short was in terms of time that it takes. But as as centers start doing more procedures and they get that operational efficiency, we've seen these gaps shorten as well. But from a patient's perspective, it is clear to see that Da Vinci surgery offers better outcomes than lap and open at a global level. And what do these mean for hospitals in India? If all of these robotic surgeries that were done in India had been done laparoscopically, patients would have needed to stay in the hospital close to 20,000 more days. Beds that could have been spent to treat other patients. If those same cases had been done open, there would have been 56,000 bed days that potentially could have been saved, but you had a bed staying because they had to undergo open surgery. Thanks to the leadership of surgeons like Dr. Mohan and others around the country, we've also seen evidence local from India with Indian patients go up over the years. Today we have over 800 peer-reviewed scientific articles on the efficacy of Da Vinci platforms. More than 20,000 patients have been covered in these studies. If you look around, the Da Vinci platform is probably one of the most widely studied medical devices on the planet. And this adoption that we saw globally has been based off of the robust evidence that you all have helped us collect. The one thing though, which we acknowledge, is that to build a robotic surgery program, the kind especially that Dr. Mohan has built here, it takes more than just a robot. A robot is not enough. They need an ecosystem of areas which can help hospitals build and sustain multi-specialty programs. And what constitutes that ecosystem? First is advanced technologies, of course, not just instruments, not just the robot, but also data-based support. How can surgeons understand how they're performing better and then use every surgery as an opportunity to learn and find those marginal gains and get better? The second is training. We have developed over the last 30 years very deep training curriculum for surgeons to handhold them through their learning curve with robotic surgery. We have a number of different courses. We have platforms for surgeons to connect interoperatively with one another and tap into the collective expertise of the entire 100,000 plus strong community of Da Vinci surgeons worldwide. And finally, for hospital administrators, as you're thinking about the program and taking a programmatic view to developing robotic surgery, there are a whole host of solutions and analytics insights that we can provide to hospital owners, which help them understand where are the gaps, what specialties can we bring in, how can we run the program more efficiently so that it becomes more economically viable. This is what we call the intuitive ecosystem, and any hospital that buys a Da Vinci instantly taps into the power of this ecosystem. So, my third message, which was around the future of surgery and what kind of role AI will play. This is something that is very important to us, right? As you know, we invest quite a bit into R&D and looking at horizon technologies. With AI, right, there is a lot of noise. But what our teams are super focused on is how do you make it helpful to a surgeon at the moment when the surgeon needs that help. And that's been a big guiding principle in terms of how we think about AI. The other part of it is technology. What kind of technology infrastructure is required to support these AI solutions? So we are pleased to launch the Da Vinci 5. I'll show a small video and then we'll walk through a hypothetical example of how AI can actually help a surgeon inside the OR. Okay, we'll move ahead. I think there seems to be some technical issue with the video. But the one thing with the Da Vinci 5 that I want to highlight before we get into AI is with robotic-assisted surgery, what surgeons missed when they moved from laparoscopic to robotic is the feeling of touch, the haptic feedback of tissue, which is very important in surgery. It's taken us 30 years to build that technology, and finally with the Da Vinci 5, we've brought that. So the instruments on the Da Vinci 5 have the feeling of force. So surgeons would be able to feel tension on tissue, but it doesn't just stop with feeling. They will also be able to visually see the amount of forces that they're applying on tissues, and they'll be able to go back, get that data, and analyze the kind of forces that they're applying on tissue. And what we are beginning to see is even experienced surgeons, when they operate with the feeling of haptic, are able to perform gentler surgery with lesser force on tissue with the Da Vinci 5. The Da Vinci 5 has been powered with a microprocessor from NVIDIA, which is 10,000 times more capable than the current generation, which is the XI. So it's really been designed to be a technology infrastructure which can house a number of AI, machine learning, and software-led solutions on it. So it has the horsepower to continue to house the next decade of software-led innovations. And that's really important for us, right? Because this then becomes a platform on which we can continue to innovate. So the Da Vinci 5 today has a bunch of peri-operative solutions before the surgery and after the surgery, which helps surgeons understand their surgery a little better. I like to use the analogy of cricket here, right? So contrast a batsman 30 years back versus a batsman today. 30 years back, when they would get out and go back to the pavilion, the coach would tell them subjectively, hey, I think you struggled against the outswinging ball. This is how your footwork should have been. Today, when they go back to the pavilion after getting out, they have so much video, data, analytics, which shows them exactly what was their wrist position, what was their footwork, where did they struggle. And that then helps them to go back to the nets the following day and practice that specific delivery. With the Da Vinci 5, we have tried to create an environment similar for surgeons, where after every surgery, a surgeon would go back to the OPD, pull out an application on their phone, and they'd be able to see exactly what they did in that surgery, what were the areas in which they were really good, what are the areas in which there's some room for improvement, and then, similar to net practice, they go back to an integrated simulator where they can get into a virtual reality environment and practice those specific skills so that each surgery becomes a learning opportunity. And that has been unlocked now with the power of software on Da Vinci 5. So my last few slides, I'll take you a little further into the future. Imagine you're stepping into an OR of the future, right? And this is a hypothetical example, but it'll give you some sense of how we believe AI is going to come and help surgeons in the operative room. So imagine this is a patient. Right? You're walking in. This is a patient who has Crohn's disease and needs to undergo a right hemicolectomy. The Da Vinci, let's say, is connected to the EMR, so it knows that this patient has Crohn's disease and is at increased risk for bowel perforation. Now, as the surgeon sits on the console, the system flags to the surgeon that this patient has Crohn's disease, increased risk of bowel perforation. During the colon mobilization step, that is when this risk is increased. So we'll need to be more careful during that step of this procedure for this patient. Now, the surgeon sits and starts operating. Because the system has machine vision and it's able to identify anatomy in real time, when the surgeon gets to the colon mobilization step, the system is able to identify, you're at this step, here is the anatomy. Now, because the Da Vinci 5 also measures forces, what it can suggest to the surgeon is, when you're mobilizing the colon or when you're handling this tissue, let's have a force upper limit of 2 newtons, which means beyond that, even if a surgeon tries to engage the tissue with more force, the system will not let the surgeon engage with more force. Think of this like you're driving on a highway and you have a speed limit of 100 kilometers. You set the top speed, you press the accelerator even after 100, the car doesn't let you go beyond 100. What does it do? It helps you do safer surgery and avoids unintended complications. Think of a new surgeon, a young surgeon who's still in their learning curve, sitting and having access to safety mechanisms like this. It is not doing the surgery for the surgeon, but it's allowing the surgeon to focus on the more important parts of the surgery, but by allowing for additional safety measures. We see AI truly as a co-pilot for the surgeon, right? Which is there, analyzing, reading the signals, showing what the surgeon cannot see with their naked eye, and helping the surgeon make better decisions. There is a human element to the surgery which we don't believe will ever be taken away. We are decades, if not centuries, away from fully automated surgery, but there are small things which we believe AI can help the surgeon do better each time they're in the OR, minimize unintended risks, all with the goal of better patient care for patients. Imagine the other thing, right? If I'm a surgeon operating in a rural part of India and I don't have access to expertise here, what surgical AI can do is review all of the existing literature about that particular patient, analyze what other surgeons, experienced surgeons for that condition have done, and can potentially begin to suggest things that the surgeon should do. You could have things like no-fly zones. Let's say there's an important structure. Put a no-fly zone so no instrument can inadvertently go and impinge on that tissue. And so that is truly how we see AI helping surgical care. I will close now with the same 3 messages that I opened with. Da Vinci robotic surgery today is widely adopted across the world thanks to the efforts of surgeons like Dr. Mohan and others in this room and outside. The second, it has been built on a strong foundation over 30 years, over 50,000 clinical studies of clinical data, and that is something which has taken decades to develop. And the third is, we believe from this foundation of adoption and data, we can begin to harness the power of AI to really shape the future of surgery, all with the goal of improving patient outcomes. With that, I'll bring this to a close. Thank you so much.
Thank you, Mr. Abhilash. I would request Mr. Vishnu Panigrahi, sir, Group Head and Medical Strategy and Operations, Fortis Healthcare, Dr. Shakir Tabrez, Director, Uro-Oncology, Urology, Renal Transplant and Robotic Surgery, Fortis Hospital, Bangalore, and Mr. Praveen Wali, Facility Director at Fortis Cunningham Road, to felicitate Mr. Abhilash. So, please.
You're there? Without stealing your thunder, a couple of things. So first of all, I'd like to say we just completed a decade since we started getting the Da Vinci here. I'd like to first pay respect to Mr. Subramaniam, who was from the city, who started the journey before we got the robots. I'm just giving some history here. And we have stuck to a thing as a partner. But what I'd like to put the monkey on his back is that when the DB5 docks in India, they dock in Fortis. I had told this earlier also. I'm reiterating in a Bhari Sabha. And so there are a lot of witnesses here. I'm not putting you at risk. Okay? And we have lived up to the expectations, because whatever we had committed for 5 that time, we took 4 immediately. And Banarkata was one of the first 4 to get it. They started out very well, much better than Mohali. Mohali picked up later. But I think so, Fortis, we are very fortunate to have a good partnership with you all. The other thing I would like to say is that, Mohan, is that while we talk about this, I think the outcomes part is something that I've been discussing with him. I put Gaurav in our team to sort of interact with them. So I think so, we must have the outcomes part properly structured, like we are now doing our clinical outcomes publishing for CAD, 1-year kidney transplant, our ERCP. So on the robotic surgery, whether it is gynec robotic, uro robotic, the GI robotic, so pick up that. I think so, Gaurav is in touch with you. And this is something that we need to close. And I'd like to just share that we have published our clinical outcomes report every year. This year's one is ready. The board meeting is on 6th. Once that is done, we'll put it up in the public domain. The next year's clinical report will have a huge part on robotics. So if we have the outcomes part, that can also be plugged in. So thank you very much.
Thank you so much, Dr. Vishnu. Thank you.
Delegates. I would now like to welcome Dr. Sidling Ladde, Associate Consultant Urology, Uro-Oncology and Andrology, to deliver a talk on elegant solutions for overactive bladder.
A very good morning to everyone. I would thank Mohan sir for giving me the opportunity to present today. My topic for today is the overactive bladder. I'll just briefly give an introduction and run through the slides. Okay. Overactive bladder, as per the International Continence Society, it is recognized as a symptom syndrome suggestive of a lower urinary tract dysfunction. So it is defined as urgency without urge incontinence, usually associated with the frequency and nocturia, provided there is no infection or any other obvious pathology which is giving rise to these symptoms. So what happens in overactive bladder is initially when the bladder fills, the detrusor muscle is supposed to relax. In OAB, the detrusor muscle will start to function hyperactively, and suddenly there will be a surge of contraction which leads to the symptoms and sometimes incontinence. So the overall global prevalence of overactive bladder is about 20%, more commonly seen in women than men. When it comes to the Asian population, it's about 53% of the women are found to have this wet OAB. I'll tell you what wet OAB is about. So OAB involves a complex pathophysiology of which is given by the integrative hypothesis, which involves three domains, which is urothelial dysfunction, nerve abnormality, and the detrusor dysfunction. All three collectively give rise to the symptoms of OAB. The comorbidities which are usually associated with this is most commonly the diabetes, obesity, cardiac problems or neurological problems, and sometimes UTIs. All this make the OAB difficult to treat. Both the males and females share a common risk factors. Again, here, as the age increases, there's a risk of OAB. BMI, increased BMI is known to affect the OAB, previous surgeries, medications, and prostate-related conditions like BPH. Categorically, we put OAB into three categories. One is a wet OAB, which is associated with a urinary leak, what we call as incontinence, and a dry OAB, which is the symptoms without having an incontinence, and a mixed, which is a combination of both. So why we need to treat OAB is because it impacts the quality of life, be it a physical limitation of activities or it leads to the low self-esteem, and socially the person gets affected because of the symptoms, and there'll be occupational attrition, and it also affects the intimacy. So how we move about diagnosing and managing the OABs, I put it particularly into the three categories. First is a symptom assessment to see what exactly the OAB constitutes of, and it has to be differentiated from the stress incontinence. Next is doing a physical examination and a neurological examination to rule out any other conditions which is contributing to the OAB, and along with the ruling out of prolapse. Third is the bare minimum is evaluating with a bladder diary and a urine analysis to rule out infection. The high-end investigations in the form of a cystoscopy, upper tract imaging, or a urodynamic study is restricted to those cases when the first line and the second line management fails. So these are the guidelines which I just explained. So this is a flowchart of a treatment approach. So after a clinical diagnosis and confirmation, first we offer a first-line treatment, which is a behavioral and lifestyle modifications. Fluid restrictions, caffeine reduction, smoking cessation, and a weight loss becomes an integral part. And along with that, the guidelines say that we need to encourage on biofeedback, bladder training, pelvic floor muscle exercises, which is Kegel's exercise. After this, the second line treatment comes into the picture. If there is a failed first line, then it is a second line, which is a pharmacological treatment, mainly by two group of drugs. One is anticholinergics and other thing is beta-3 agonists. If the second line fails, then we move into the third line treatment options, which is Botox injection or a neurostimulatory approaches. If everything else fails, the last comes the surgical approach, which is augmentation cystoplasty. Again, the treatment approach. So when it comes to giving the medications, we categorically put into two categories. One is anticholinergics. This is the first commonly used one. And the other one is a non-anticholinergics, which is a beta-3 agonist. So they mainly target the cholinergic receptors of the bladder wall, that is M3 receptors, and also the adrenergic receptors, which is a beta-3 receptors. So this is evolution of anticholinergic medications, how it started with oxybutynin, and then currently most commonly used one is solifenacin and tolterodine. So this is just a brief summary of an anticholinergic group of drugs. And the important adverse effects associated with this is a dry mouth and constipation, cognitive impairment. So what are the therapeutic challenges associated with the first line anticholinergics? It is of a long duration, and also the cognitive impairment is one of the issue, and poor patient compliance because they won't be able to tolerate these medications. So then came the beta-3 agonist, which is a mirabegron, which targets the beta-3 receptors of the bladder and relaxes the smooth muscles of the bladder. Again, this is the history of how the mirabegron was initially came into the trials, and then finally it came into the market in India in 2017. The important adverse effects are hypertension and increased heart rate, which has to be cautionally prescribed in these individuals. So when the monotherapy of anticholinergics or a beta-3 agonist fails, the combination is the current preferred option. So there are different trials which suggest the efficacy of a combination treatment. One is the Synergy and the Symphony study. Despite the first line and the second line medications, there are few subsets of patients who tend to continue to have the symptoms, so that we put it as a refractory OAB. So the treatment options for refractory OAB is one is botulinum toxin instillation, sacral neuromodulation, or a P10s. I'll just give you a history of a Botox. So historically, it was used first for the strabismus condition, and then again over the period of time, it has come into the usage for the hyperactivity of the bladder. So Botox basically, after instillation, it prevents the acetylcholinesterase release and causes a smooth relaxation of the bladder muscle. So it is indicated in those patients where the first line, second line treatment has failed, and the main contraindication is they should not be having active UTI, and they should be willing to do a self-catheterization. The second treatment option is a sacral neuromodulation, where it is a minimally invasive technique, safe and efficacious, where an implant is placed in the sacral bone. It it modulates the nerve reflexes. It's FDA approved, and it has got a 92% success rate. The other option is a percutaneous tibial nerve stimulation, where the tibial nerve is stimulated with a peripheral needle, and it's performed weekly for 12 weeks. It's FDA approved. When everything fails, there are three surgical options. One is a detrusor myomectomy, which is where we give an incision over the bladder and expand the capacity of the bladder. The other option is augmentation cystoplasty, where the bowel is detached and it is placed on the bladder so that the capacity of the bladder is increased. Despite these surgical options have got a high risk, these are the treatment options for a refractory OAB. So to conclude, OAB is quite prevalent and underdetected and underreported condition. So the first line is always the behavioral and lifestyle modifications. If that doesn't work, then we go for the medications. Even if that becomes non-responsive, we have 3 other options. One is a Botox, neuromodulation, and the surgical therapies. Thank you.
Thank you for that insightful talk, Doctor. It's now time to move on to the interactive and intellectual discussions on difficult cases in urology. To moderate the first clinical session, I would like to welcome Dr. Shakir Tabrez, Director Urology, Uro-Oncology, Urogynecology, Renal Transplant and Robotic Surgery, Fortis Hospitals. As panelists, I would like to welcome Dr. Karthik Rao, the Additional Director, Urology, Uro-Oncology, Urogynecology, Renal Transplant and Robotic Surgery, Fortis Hospitals. Dr. Santosh Krishnamurthy, HOD and Consultant Radiologist, Fortis Hospitals, Bangalore. Dr. Akhila L., Senior Histopathologist, Agilus Diagnostics, Fortis Hospital, Bangalore. Dr. Chandra Teja Reddy, Consultant Nuclear Medicine, Fortis Hospital, Bangalore.
Good afternoon, everyone. Welcome to another, hopefully, interesting case discussion. So the next 15 minutes, we hope to take you through a walk into the minds of a urologist, a radiologist, a pathologist, and a nuclear medicine specialist on how this disease can be treated. This is cancer prostate. Cancer prostate, one of the commonest, the top 3 cancers in men. The question is not, can we treat it? The challenge is diagnosing the right patient at the right time and offering the right treatment. With India diagnosing more than 50,000 cases of cancer prostate every year and only rising, it is imperative that this challenge is addressed. So this is the specialties, working on one patient, fortunate enough to have colleagues as esteemed, as wonderful, who we can keep talking to, interacting, and help every patient. So this is our patient. He's a 64-year-old. During his routine health checkup, he has no symptoms. Another fallacy is cancer has to have symptoms, not at all. So asymptomatic PSA sent as part of executive health checkup. He has hypertension, no diabetes. His father, so family history is there. He was diagnosed at age 70, non-smoker. On digital rectal examination, there was a firm nodule palpable in the peripheral zone. It's about 1.5 centimeter. And he has mild LUTs or lower urinary tract symptoms. Can we have Dr. Karthik tell us our steps? So we've seen him in OP, he comes with this. Take us through your thinking.
So basically we have a patient coming with LUTs of very mild IPSS score of 6, but then we have on examination firm nodule which is peripheral, which is in the right peripheral zone. So basically, what is the PSA, sir? I would ask for a PSA.
So this is the PSA. The total PSA is 8.6. So let's go through this without going on to the next. Can you just tell the audience, after seeing this as a total PSA, the thoughts which go?
After seeing this total PSA, I would like to do a prostate biopsy, but before that I would like to know where to target the biopsy. So I would like a multi-parametric.
Sorry to interrupt you, just a quick question. A quick note on a total PSA of 8.6, that gray zone between 4 and 10. Just give us a second thought on what else we see on screen, please.
So basically, in the Indian population, we say we keep a top cutoff limit of 4. If it's 8.6, between 4 to 10, the PSA could be raised because of multiple factors, not cancer alone. It could be prostatitis, it could be a recent instrumentation, digital rectal examination per se doesn't elevate it to a significant extent, but between 4 to 10 is what we call as the gray zone, and this percentage free PSA is one which helps us to decide whether we need to further investigate this patient or wait and watch with antibiotics for a week, for 2 weeks or so, and then repeat a PSA to see if it's gone down. It's a cutoff value of the percentage free PSA is around 20%, and if it's less than 20%, then this patient would definitely require further investigations before we say that it's not cancer and it's prostatitis.
So just reiterating what Dr. Karthik has just said, the gray zone is 4 to 10. I've had a lot of patients come to us with a PSA of 8, walking like they've walked in front of a firing squad, like they're facing death sentence. It's on us to talk to them, compassionate, tell them that it's not just this. There have been higher PSAs which have ended up as just infection or prostatitis, not necessarily malignant. But this is an arrow which points us in a direction. And the direction would be, like Dr. Karthik just mentioned, and as you can see, anything less than 25%, the chances of malignancy in that prostate keeps rising. And if it's 0 to 10%, it's every 2 patients, 1 will be malignant. So with this, we go on to a MP MRI, that is the imaging in the CA prostate. And to explain this multiplanar parametric MRI, we have our specialist, Dr. Santosh, to tell us, please.
So when we look at prostate, we will be, I would be wanting if it's, it's better if it's done on a 3 Tesla machine where we have better resolution. We also can, differentiate the transition zones and the peripheral zones better. So once we decide that, we will do a CA, this one, we have high resolution sequences in all the 3 planes. Most, lesions in the peripheral zone would look dark on T2, and the transition zone would, what we call it as an erased charcoal appearance. So based on the morphology of the lesions in the peripheral zone, 1 and 2 are generally normal, 3 is kind of indeterminate, and the 4 and 5 generally we classify, going towards higher incidence of malignancy. What we do on the 3 is to administer contrast. If it enhances, then the lesion would get upgraded to 4. If it remains, if it doesn't enhance, then it would still remain 3. So for the transition zone, we use what we call as the diffusion weighted sequences. If it's dark on T2 and if it's bright on the diffusion weighted, more likely it is malignancy. If it's not, if it doesn't become bright on diffusion weighted, more likely it is just a benign prostatic nodule. So that's how we classify based on the PIRATS 1, 2, 3, 4, 5. 3 I said is like indeterminate.
Thank you, sir. So again, just to reiterate what you have said, that's the suspicion scale.
So again, just to be the T2 weighted is like the zonal anatomy and the capsular integrity. The diffusion weighted is more like a functional imaging without giving contrast. It indicates the cellularity of the lesion. More the cellularity of the lesion, the darker the lesion appears on the diffusion and becomes brighter on what we call it as the diffusion image sequences. Again, higher the tumor grade, the higher the enhancement on the contrast when we give contrast. So that is one of the diffusion and the contrast would indicate functional imaging. It's more like a functional imaging, whereas the regular T1 and T2 is more like an anatomical imaging for the prostate.
Right, thank you. So, Dr. Karthik, it's a PIRATS 5. It's in the right mid to apex peripheral zone, 1.4 centimeters. There's no extra prostatic extension on imaging. So, how do we go forward? Would you go directly, since you know on an MRI where it is, do you go directly for a truss or would you go for a fusion?
Basically, the fusion is like a GPS which tells us where to target. Multiple studies have shown the efficacy of MR targeted biopsy rather than a blind biopsy. So I would go in with a MR fusion biopsy, whether it's a transrectal or a transperineal route. If the coagulation parameters are normal on an OPD basis, even a transrectal route would be fine with a single dose of antibiotic.
Okay. So these are the differences between a truss-guided biopsy, which has been the standard of care all these years, but now with an MR-guided biopsy, we know exactly where to target. So any lesion which is a possible malignancy is not missed. So with this, it was blind. With the truss, it was 12-core, blind within quotes, because yes, the ultrasound showed us, but it doesn't exactly locate the lesion. With an MR fusion, we can see significantly high detection of clinically significant cancer. One more important point, if you see on the second graph that you see, the level of clinically insignificant cancer detected drops with an MR fusion. So this is another positive point. So this improves by 40% relative to systemic sampling alone, and it reduces detection, which means we don't want to overtreat clinically insignificant disease, which is also not emphasized enough. For this patient, we did a fusion targeting confirmed at the site where the digital rectal examination showed us the disease. So to talk about the pathology and what we found, or what Gleason's actually means, we hear this term so often, but how is it interpreted? Dr. Akila, please.
So, Gleason score is something which we use for grading prostatic acinar adenocarcinomas. So, in the top two panels, you can see Gleason score 3, which shows well-formed glands. They are lined by epithelial cells which show atypia with nuclear enlargement, hyperchromasia with prominent nucleoli. So they are all back-to-back glands and they are lined by atypical cells, but you can still see the lumen in all of them. So that is Gleason score 3. Next two panels, third and fourth, they are Gleason score 4. So here what we see is back-to-back fused glands where the lumen formation is not as well developed as in grade 3. So these are all grade 4. They are all various patterns of grade 4. And in grade 5, we don't see lumen formation at all. They are like solid nests, sheets of cells, individual cells infiltrating into the stroma, presence of necrosis. All these things points towards Gleason score 5. So we can also further categorize them into grade groups. So these are all the various grade groups that we have. So grade group 1 is Gleason score 3 plus 3, which is 6. Grade group 2 is 3 plus 4, 7. And grade group 3 is 4 plus 3, 7. And 4 is 4 plus 4 and 5 plus 3. Then grade group 5 are 5 plus 4, 4 plus 5 and 5 plus 5. So these are the various grade groups. So there is no need to tell that higher the Gleason score, it is
as
more.
It is, madam. So that is here. So the higher the grade group, the chances of it. So this patient was, again, back to Dr. Karthik, was 3 plus 4, which is 7, which is grade group 2, in 3 of the 4 targeted cores from the exactly where the lesion was. So the maximum core involvement was 45%. So this is the risk category for this patient. So this falls into the favorable intermediate organ confined. Yes, please. So talk us through it. What next?
In any cancer, we do 3 things. One is diagnose, second is stage, and then finally only treat. So we have diagnosed the cancer. Now we know probably it's localized and organ confined, but whether it is spread to other or not would be with another modality of investigation. Right now, even the guidelines say you have to go ahead with PSMA PET CT.
So can we have Dr. Reddy talk us through the PSMA PET, its importance in this case and otherwise?
Going strictly by the guidelines, this case comes under favorable intermediate risk, but both NCCN as well as our SNMMI guidelines say the role of PSMA PET CT actually starts from unfavorable intermediate and high risk cases where it is very much appropriate. But we are routinely doing staging for all prostate cancer cases, and we have seen few cases where even low risk case also we could identify some bone mets also.
Right.
So going strictly by the guidelines, it's actually in the unfavorable intermediate risk and high risk groups. And in case if MR is equivocal and clinically it's highly suspicious of prostate cancer, still it has a role. Focal increased tracer uptake is more favoring towards malignancy. And the other indications like guiding biopsy and response assessment, as well as if at all patient is being considered later parts of the disease process, like for PSMA therapy, we have to prove that all the lesions are PSMA fit. So these are all the indications for PSMA fit.
Okay. And we had a talk with Dr. Santosh yesterday who, that's an hour-long debate, I think, when it comes to is PSMA really necessary when we have a good MP-MRI reading?
No, I would say, I mean, for the local extent, I mean, PET is obviously a system, you know, you can see spread to other areas also. When it comes to the local anatomy and spread, for example, involvement of seminal vesicles or rectum or any other thing, I think MR really scores over PET in that sense. Of course, when you have a distance metastasis and all that, of course, PET is better.
Better that way. Yeah. Thank you.
Like the same thing. So for the local staging, definitely there is no debate on that. MR is far more scores over PSMA PET CT. But for the evaluation of pelvic nodal mets and distal mets, it has a good value. And coming to positive predictive value and negative predictive value, if PET is showing positivity, there is high chance that it is positive. But if it is negative, still it can be positive because of the limitations of the PET resolution. So anything less than 5 mm, 6 mm, PET, it is hard to detect. Yeah.
Thank you. So the patient has said, doctor, enough tests done. Please treat me. Dr. Karthik, please treat him.
So favorable grade group, localized CA prostate. Right now, I don't think there is much of a debate going ahead with a robotic radical prostatectomy. In this patient, we can attempt what is called as a nerve sparing, and so this was a patient, the same patient who's had a ejection fraction of 23%, and obviously Dr. Murli sir was involved in this case. We used the posterior approach where we go ahead and dissect the seminal vesicles and the vas. We develop the plane posteriorly between the prostate and the rectum. We drop the bladder, and the dexterity with which the instruments move, you can see it's as you're operating with your hands but inside the abdomen. So the bladder neck is open, both the anterior and posteriorly. The previously dissected vas and seminal vesicles are delivered. This is the pedicles being ligated and cut.
So as we go ahead, the idea is to preserve the nerves. Essentially, one of the biggest advantage of doing this procedure, not just removing the cancer, but going ahead and preserving continence and potency, which is...
So basically you can see a good length of urethra which was being preserved. That is the single most important determining factor for the continence. The nerves sparing helps in continence as well as potency. But I think most of us would agree that the length of the urethra which we have preserved is the most important aspect of preserving continence here. So this is what we call as a Rocco stitch, where we reconstruct the posterior aspect of the bladder so that the anastomosis is not under tension. And then it's a straightforward end-to-end uretrovesical anastomosis. You can see that the bladder neck is, the bladder neck is quite small, so patient would be having a very good result in the post-op.
Apologies, but this buzzer is quite scary when we view it from here, so I think we'll bring this to a close. The idea is, having all the experts on the panel, we haven't had the time we would normally have, but this is to encapsulate and take you through a walk through our minds, and this is how we help a patient in the end where there is cancer out of his system, yet we preserve his erection and his continence, and there's a lot of counseling which happens pre and post-op. So there is significant difference in continence and potency recovery after robotic prostatectomy. So this is what the plan was, and that was the surgery. Thank you very much for your patient listening. Thank you for all the panelists for your time.
Thank you, doctors. For the next case discussion, I would like to welcome Dr. Prem Kumar K, Additional Director, Urology, Uro-Oncology, Urogynecology, Renal Transplant and Robotic Surgery, Fortis Hospitals, to moderate the session. As panelists, I would request Dr. Santosh Krishnamurthy, sir, to please join us again. And Dr. Basuraj Nilagar, Additional Director, Urology, Uro-Oncology, Renal Transplant, Robotic Surgery, Fortis Hospitals, Bangalore. And Dr. Nagarjun, Oncopathologist, Agilis Diagnostics, Bangalore.
Good afternoon, everyone. Dr. Shakir covered the most important surgery, which usually was the reason for why robotic came into vogue, and partial nephrectomies and kidney surgery are second in line for robotic surgeries. So we'll discuss in brief about a case so that we can get a proper picture about why partial nephrectomy requires a robot. So, we'll go about with a patient who comes to our OPD. Imagine this is a patient of 32-year-old female who comes asymptomatic and has a health checkup and gets to know that there is a 5 centimeter mass in the kidney on the left side. I would like to ask Dr. Basuraj, because this is a clinical setup and a patient coming asymptomatic with an ultrasound report of 5 centimeter mass in the left kidney, what next would be your process?
That's the most common presentation these days, that is incidentaloma. So next since it's a bigger tumor and in a young woman, it's better to get a next line of investigation, that is a CT with a contrast.
Okay. So like say prostate, say renal masses, they are all asymptomatic, and here we have a CT scan done and it shows a lower polar left kidney with a cystic lesion measuring about 4 to 5 centimeters, and so it has a calcified wall is the report given, and here is the CT findings.
Okay, so here you are seeing coronal sections of the CT, which shows a lower polar and interpolar mass extending up to the hilum, well-defined mass, peripherally calcified. We call it as a purely cystic if it is containing at least 75% of the cyst, and otherwise it's a solid mass. So this is more like a cystic mass with a solid component. So you can see the enhancing solid components along the lower part of the mass. So based on the Bosniak classification, that is one which we look at, how we classify based on the Bosniak, it would fit into a Bosniak 4, which has up to a 90% chance of a malignancy. The second one which we also look at is the renal nephrometry score.
Yes.
Based on the size of the lesion. The acronym is actually called renal. R is the radius of the lesion, whether then the E is the exophytic or endophytic lesions. N is the nearness to the collecting system. E is E and L. L is the pole also. So based on that, I think it would fit into some nephrometry would fit into something like about 10 maybe. That defines the complexity of the lesion. 0 to 4 is low complexity. 4 to 8 is medium complexity, and more than 8 is generally a high complexity lesion. So these two actually we define when we look at it. Of course, if we have an arterial phase and a venous phase, we also look for if there is any venous thrombosis or any arterial involvement or arterial supply, number of arteries, all those kind of things, which should help in the, in your surgery for a partial nephrectomy.
Okay. So this is a fair enough investigation for us to decide whether it's a malignancy or not. But usually we perform FDG PET to just have additional information regarding the malignant component and how to plan for the procedures. Now, Dr. Basuraj, you got this CT, contrast CT and a PET CT done. What would be your approach after this?
So this tumor being a 5 centimeter tumor, almost endophytic and near to the hilum, it's a highly complex tumor with a nephrometry score of 10. So it helps in predicting the possible complications after the surgery. Actually, this patient was evaluated elsewhere and she was offered radical nephrectomy straight away.
Yes.
But they are not willing for the radical nephrectomy, so they wanted to preserve the kidney, so they came to us for a second opinion. We explained the risks. This particular cases where the renal nephrometry score is high, they carry fourfold higher risk of converting to a radical nephrectomy, other bleeding complications. So after explaining the risk, we took up the patient for surgery. Partial nephrectomy was attempted in this case.
So you would probably attempt the partial nephrectomy, and if technically or clinically indicated, we change to
yes,
radical nephrectomy. And that was a decision made, and I think this was just an additional investigation which was done intraoperatively. Get a retrograde pyelogram, and you can see the whole tumor almost abutting the calyx, just very close to the hilum, and a lot of vessels there near the renal hilum. Like we discussed, I think Dr. Basuraj has decided for going ahead with the partial nephrectomy. If not, then go ahead with the radical.
So robot-assisted left partial nephrectomy, as usual, we mobilize the colon, we identify the ureter, go to the hilar dissection, identify the renal artery and the vein. We take control of the hilum, we loop the vein. We don't usually clamp the vein. Only the artery is clamped. Both the artery and vein are taken control first, and then we expose the tumor, do an intraoperative drop-down probe ultrasound to identify the margins and the exact site of the tumor.
It's a very important tool for us to have a partial nephrectomy, intraoperative ultrasound, to know the depth and surface anatomy of the tumor.
Picture-in-picture mode is there, so it helps us in correctly identifying the tumor because it's an endophytic tumor. So we're clamping the artery with the bulldog clamps. And that now the tumor is being, and the idea was to open the cortex of the kidney and then enucleate the tumor and then close it back. So we almost reached the surface of the tumor now from the lower pole.
No.
Video.
Video is not yet over. Wait. Video. Play the video. These are small segmental vessels which are coming out from the lower pole of the kidney.
Small arteries were clipped during the partial nephrectomy. So as you can appreciate, it is very close to the main renal artery and vein and also the pelvic calyceal system.
So if it is not in the proper lower polar, if the nephrometry score is on a higher side, I think it is very difficult for us to dissect, because the hilum is involved here with the calyceal opening of the callus, opening of the, you can see the ureter.
So rhinorrhaphy was done, and then we released the clamp. There was a small bleeder. We took control of the bleed, and the rhinorrhaphy was done in 2 layers. The pelvic calyceal system was also repaired separately. We could say almost half of the kidney. So 1.5 kidneys is better than just 1 kidney.
Yes. So this is quite a complex surgery compared to a polar tumor, where hilum is not at all touched.
And then we use SURGFlow hemostatic agent. It helps us in controlling the bleeding. Also, we use a bolster to stop the bleeding.
Okay,
So that's the
this completes
final
the
picture. That's how we we could achieve what we wanted to achieve with the partial nephrectomy.
yeah. So post partial nephrectomy, this is the histopathology. I would like Dr. Nagarjun to comment on the report.
So, the specimen which was sent for histopathology revealed a morphology of a clear cell renal cell neoplasm. So, if you see the terminology that we have used, that we are not sure whether it's a clear cell renal cell carcinoma. And considering the description that we have mentioned, that we are seeing some pseudomatous calcification, which is not a regular finding in a clear cell RCC, that gives me a soft pointer telling that this could be some other genetically defined entity. So that is why one of the characteristic finding of the somoma bodies are generally seen as TFE3 rearranged renal cell carcinoma. So that is the reason we have considered two differentials in this entity. Apart from this, we look for certain other prognostic parameters on morphology, that is the sarcomatoid features and the rhabdoid features and necrosis. These are very important for us to define the prognosis of the patient. And necrosis also, when we have a cutoff of around more than 50%, it's a very poor prognostic parameter. These are the main important points that we look in histopathology findings. So in this case, we just call it as a clear cell renal cell neoplasm. Considering these two differentials, immunohistochemistry was advised to look up for the definitive diagnosis. So on performing immunohistochemistry, we could completely rule out clear cell renal cell carcinoma because it was negative for CA9 and CD10. So these are two important markers which will support us for clear cell renal cell carcinoma. Since that being negative, and if you see TFE3 is one of a marker which supports a molecular defined entity of TFE3 rearranged RCC. So being strong positive, this was supporting a renal tumor of TFE3 rearranged RCC. At this immunohistochemistry, this was a diagnosis. We wanted to confirm it by FISH or RT-PCR study to look for the translocation partner. So one of the important take-home messages, considering the patient age is very young, around 32 years, our job doesn't end at just diagnosing the entity, but had this been a clear cell renal cell carcinoma, our next job is to advise the patient to go for genetic germline testing so that we identify patients who are carrying these germline testing, and we could screen the entire family members before the tumor, the patient present at a later stage.
Yeah, so RCC was confirmed with IHC, and the patient was, post-operative patient was uneventful, and for the lack of time, we are closing it here. But there's a test at the end. Patient was discharged uneventfully, recovery post-op. Post-op day, patient came with little giddiness, and we found there was a aneurysmal lesion with some bleed there, and we had to have a CT angio done, and angioembolization was done. And I think, and this is the embol. You can see the bleed at the lower pole of the remaining kidney, and that embolization has closed the bleed. Yeah, that's all. Thank you for the discussion. Thank you.
Thank you.
Thank you, doctors, for that educational session. For the third case discussion, I would like to welcome Dr. Manjunath S., Additional Director, Department of Nephrology, Fortis Hospitals, Bangalore, to moderate the session. And to chair the session, I would like to call upon Dr. Mohan Keshavmurthy, Sir, Principal Director, Renal Sciences, Fortis Hospitals, Dr. Manjunath Dosetti, Nephrologist and Transplant Physician, Medical Director, Chirayu Hospital, Kalburgi, Dr. Mahesh E., Director, Ramaya Institute of Nephro-Urosciences, Bengaluru, Dr. Ravindra Madraki, Nephrologist and Transplant Physician, Medical Director, Yashoda Institute of Medical Sciences and Research Center, Vijaypura.
Good afternoon, everyone, and welcome to today's CME program. As you all know, I welcome all the panelists and the speaker. As you all know, any renal transplant carries some risk, and the risk multiplies when there are associated immunological issues like blood group barrier as well as ABO incompatibility, and if there are any HLA sensitization with high antibody titers that can make the transplant challenging. At the same time, the surgical challenges like multiple vessels or previous surgeries and patient with obstructive uropathy or bladder dysfunction makes the surgery very risky, and the immunological as well as the surgical factors has an important impact on the outcome. And the outcome depends on the collective effort of a surgeon and the transplant team as well, and at the same time anesthetist managing the cases and also the ICU team. With this, we'll have two the immunologically challenging as well as surgically challenging cases for today's discussion.
Okay. Good afternoon, everyone. So we have two cases for presentation. Okay. So case one, so this is a 62-year-old gentleman who is known case of diabetes, hypertension, and ISD. Is a known case of CKD on maintenance hemodialysis with the dialysis vintage of 2 months. Blood group was O positive. Donor being his wife, 55-year-old lady with no comorbidities, blood group of A positive. And pre-transplant immunological workup, CDC, DSA, and flow cross match was negative. And pre-transplant ABO titer anti-A IgG was 1:256. Okay, so we started on desensitization protocol. On day -14, injection rituximab was administered. On day 7, tacrolimus and MMF was started. The patient was subjected for 2 sessions of immunoabsorption and 3 sessions of Plex, following which she was taken up for transplant. Prior transplant, her anti-A IgG was 1:4. So intraoperative course, it was uneventful. The patient was taken up for robotic assisted transplant. On day 1, the patient was hemodynamically stable and breast diuresis noted. On day 1, there was decrease in urine output and oliguria noted, and there was increase in creatinine, and Doppler showed mild increase in resistivity index. So clinically suspected to have acute rejection bar 18 bar any vascular event. So coming to laboratory findings, there was decrease in hemoglobin, increase in LDH, decrease in serum haptoglobin, peripheral smear showing cystocytes of greater than 3%, and thrombocytopenia. And patient's anti-A IgG was 1:2, probably due to immunological sync phenomenon, and repeat DSA cross-match was negative. So patient was percutaneous plug graft biopsy was done, and ATG, MMF, and steroids were continued for this patient. There was a gradual increase in serum creatinine, and patient required dialysis. But throughout the course, patient was hemodynamically stable, and there was no evidence of infections. So this was the biopsy of the patient. 16 glomeruli obtained, and out of which the sample showed 30% of cortical necrosis. In the glomeruli, the capillaries was obliterated due to thrombus, and focal segmental glomerulitis evident, and no crescents. Tubulitis, severe degree of ATN noted, and no cytoplasmic isometric vacuolations, no tubulitis, no interstitial hemorrhage. And the immunohistochemistry showed C4D positivity. So this was the impression, TMA with patchy acute cortical necrosis, ATN severe degree. So we managed the case with 5 sessions of Plex followed by IVIG, and rituximab was administered. So during this course, patient was continued with broad spectrum antibiotics, antifungal and antiviral. So patient required hemodialysis for next 2 weeks. Following this, there was a gradual improvement. So patient was hemodynamically stable, and he was discharged with serum creatinine of 1.8, and no further complications of infections noted.
Basically, this is a gentleman who came from North India, from a remote place, with a wife being a donor. And when we evaluated, it was a different blood group, donor being A, and the recipient was O, that is ABO incompatible transplant. And in such situations,
I want to ask the panelist, Dr. Mahesh, sir, to how to proceed with this.
What was the subgroup? A2, right? Okay. That is the advantage. No? Patients A2, they are less immunogenic compared to other blood group.
Yes, I think here is a double challenge because wife to husband and ABO incompatible, both histocompatibility mismatch and ABO incompatible, and a diabetic recipient. I was really feared when rituximab 500 mg was given, but post of day 1 only he rejected TMA. Really, with so much low titer, developing a TMA is a big challenge for a nephrologist, and to answer to the relatives is a big this one. Whatever the best prepared patient from immunological point of view by immunosuppression, but still I was worried that this patient may develop infection post-op by seeing the immunosuppression, but he rejected. This is what we nephrologists have a challenge, and day 1 means even neurologist will be called upon because first 24 to 48 hours there will be always the surgical issues come upon, but the Doppler helped us and a biopsy which categorically helped because before patient developing severe thrombocytopenia he was in biopsy, and that give the clear picture and we will be able to answer to the family and do the best to the patient. And really, because first day 1 with so much severe ABMR very difficult to recover, but luckily has recovered partially. Any comment?
Whether donor-specific antibodies was repeat cross-match was done. Because at this low titer level, it's very unusual for an ABO incompatible to reject.
The titer initially, the anti-A was 1:256.
Yeah.
And we had done immunoadsorption plus plasmapheresis with rituximab. We never expected a rejection in this case. We were surprised to see a post-transplant TMA in this case. And even the DSA was repeated, it was negative. It was totally the ABO incompatible, like ABO incompatible rejection rather than the HLA related one. Next case.
Okay.
We'll go with the next case.
So coming to the case 2. So this is a patient from East Africa. She is a 34-year-old lady. So she is basically has come for second transplant. So basic disease was CIN, we don't know. And she had underwent her first transplant 15 years back, and that graft lasted for 5 years. And later there was a graft failure, probably due to rejection, records was not found. And she was on dialysis since past 10 years. Her blood group was B positive. So donor was her sister, her blood group being O positive with no comorbs. Her CT renal angiogram showed 2 arteries in the left side and 3 renal arteries on the right side. Bilateral single renal vein and single ureter. So our HLA typing 6/12 match was seen, and CTC was negative, but DSA class 1 and class 2 was positive. So this patient was subjected for desensitization protocol. She was administered rituximab and later subjected to 5 sessions of, she was started on immunosuppression, TAC-MF of prednisolone, and later subjected to 5 sessions of Plex on alternate days from day 16 to day 8, and repeat DSA was done, and class 2 was positive. So again, she was subjected for 3 sessions of immunoadsorption using anti-HLA filter, and a repeat DSA was done, it was negative, and flow cytometry was negative. Then she was taken for robotic assisted renal transplant, and this diuresis noted, patient was hemodynamically stable, and Doppler showed mild increase in RI. So this was her creatinine trend, and post-operative day 1 DSA was negative. So day 1, okay, so there was a slight increase in creatinine noted from day 2 to day 3. Hence, patient was subject for 1 session of Plex and graft biopsy was done. So graft biopsy showed ATN with mild degree and no other abnormality seen. So further session of Plex was withheld and creatinine was monitored, urine output and creatinine was monitored. So gradually over a period of 2 to 3 weeks, patient creatinine came down and patient improved. Patient was hemodynamically stable. So our last consultation on 25th of June 2026, patient did well and creatinine was 1.08.
This is to Sir Mohan sir. This is a second transplant. Basically, patient has come for a second transplant, and he had a HLA sensitization. We did a desensitization. What are the surgical challenges in a second transplant with the 2 arteries on one side and the 3 on the other side?
So I have the privilege of having done similar cases with both Dr. Manjunath and Dr. Mahesh, but with open technique, where it was a challenge. But with the robotic technique, multiple arteries, back table work is very easy to do. In the era where we did open surgery, this would have been a significant surgical challenge. Having both the immunological challenge and the surgical challenge would have put both the donor and recipient at great risk. However, in the modern era, except the nephrologist like you sitting with us at the robotic console, no tachycardia for the anesthetist, no tachycardia for the patient, no tachycardia for the nephrologist. So basically the robot has made this surgical technique much easier and much vividly visible even for the nephrologist who has an independent monitor to see. But I wouldn't take this chance with open surgery. Although I have done it in the past, the risk would have been greater. So the robot, the technology has modified treatment to a safe zone more than the technique. We have done the same technique for 30 years, over 3,000 transplants, but what has changed is a robot. So I won't take the surgical risk at all into consideration. It's only the immunological risk, because in today's era with the Da Vinci Xi, surgical challenges have virtually disappeared.
Regarding the anti-HLA positive, what is your take, whether it's a expected one, and what would be your way of taking up the case?
It would be interesting to see what would have been the HLA class 2, which was showing about MFI of 3,800. It was against which specific HLA-D antigen, and whether the donor had that antigen. So whether that it was...
It's the second
single
sister
antigen
was
beat.
was
Single
a donor.
antigen beat.
And this patient had a positive for HLA class 1 and class 2 also, with a significant high titers. DRD, that was
single antigen beat.
HLA-A and HLA-DR, both which are significant, which were significant.
No, but whether those specific antigens were present in the donor.
It was, SAB was done and it was present in the donor.
Okay. Those antigens were present in the donor. Okay.
And initially, they had some financial constraint, and we had given a plasma as a first line of therapy, but the titers remained high. Then we were forced to use immunoadsorption, then followed by the transplant. Next.
Actually, it's very difficult to remove DR and TQ with plasmapheresis. They are bit resistant, right?
Bit resistant.
And in my experience, with respect to class 1, I will go up to 3,000 MFI. With class 2, I will go up to 4,500 MFI. Below that, you can safely do the transplantation.
This is our the ABO incompatible transplant data in the last 2 years. And you can see we have done the transplant across different blood groups with different titers, as high as 256 and 1,024, and we were able to get a good graft outcome. The next slide. And these are the few other difficult cases what we had. One was the elderly donor, the 71-year-old father who donated the kidney to the 30-year-old son. The second was elderly recipient, 74-year-old lady who got kidney from her son with a bilateral two renal arteries. And we had a few pediatric cases. One was a FSGS recurrence, where we could modify the immunosuppression, and his creatinine is 0.9 and urine PCR is 0.5. The other boy, last one, the 4-year-old boy, received kidney from a 50-year-old grandmother, and now the post-transplant creatinine is 1.1. He required a corrective surgery before going for a transplant. And we had a few ABO incompatible as well as with the vascular access issues. One guy with where they were, it was difficult to find where to do the anastomosis. That was a challenging case for the surgeon. And that patient is doing well with 1.1 creatinine even after 2.5 years of transplant. And we had a couple of infective cases, HIV as well as donor being positive for hepatitis B. And in HIV, as we all think, it's difficult, but it is doable. though there is a immune dysfunction as well as high risk of rejection and high risk of infections, especially the fungal infection, parasitic infection, and the flare of the tuberculosis. Definitely with screening and with the help of ID, we can do the transplant in infective cases. And regarding the last one, hepatitis B donor, usually when the donor is positive, we try to avoid them. But here we were able to give the antiviral drug to the donor and at the same time giving a hyperimmune globulin to the recipient and do the transplant. And both are doing well. Even after 2 years, his heart creatinine is 0.8. We had a very good outcome with respect to the graft. Thank you.
Yes, congratulations for so many complicated diseases to the whole transplant team. But one query is, sir, for you, with second case, because previous transplant and now donor with multiple arteries. Like you have to place in the left side, where all commonly we do on the right side. And left side, is it like selection of the side of the donor and...
Interesting point. I'll just take 30 seconds to answer. The robot has 30-degree up. So doing it on the left side is effortless because it's a mirror image. So you have to do the reverse of the open image. So with 30-degree up, it overcomes the human difficulty of doing left to right, right to left. So that's something possible in a future meeting. We can show a video. We have done 3 such cases where a mirror image with 30-degree, the entire anastomosis is done 30-degree up. So we'll put it up. If you invite me to Kalburgi or to Bijapur or to North Karnataka, I will demonstrate 30-degree up robotic transplant. Thank you. Thank you for your time.
Thank you, all the experts.
Thank you, doctors, for that very rich educational session. We'll now move on to short innovative capsule session. Starting off with precision transplant immunology, the talk will be delivered by Dr. Suneet Kaur, Director, Laboratory Services and Technical Lead, Agilis Diagnostics.
Hi, good afternoon, everyone. Welcome back again to SURGX 2026. So I'll not take much of your time. So today the topic for me is precision immunology. So just a brief thing, why renal transplant and what's the advantage? We all know that we are staying in a times where for all the end-stage renal diseases, renal transplant has become the go-to. And with the excellent surgical team which we have here in BG, I feel that sometimes I never knew it was such a, it has given such excellent results for the patients. It's very meaningful because it saves a lot of effort from the patients from undergoing hemodialysis day in and day out. In fact, if you see in the long run, saves a lot of financial, it's a benefit actually for the patients rather than a loss. And, but the only problem we have seen in our country is that most of the times we deal with living donor transplants and rather than diseased donor. So the most important thing in any renal transplant program is to ensure the longevity of the graft. So we want our patients who leave from here to have a good quality of life later. Maybe they should go back and join their usual workforce from where they come. And the evidence, our entire approach towards transplant should be more of evidence-based rather than intuition-based that this patient might do well and this might not. So what are the options available as of now to ensure that we have safe transplants and all the transplants, what we are doing, whatever the immunological workup we do for our patients is suitable for them. So pre-immunological transplant workup is actually not to reject any patient. We should always remember when we do a workup for a patient, we are in fact not rejecting any case. We are just trying to immunologically risk stratify these cases. So except a CDC, which is actually till now considered a contraindication if comes positive. All others are just to risk stratify the patients, identify if there are any preformed antibodies in any patient, route a patient for a paired kidney transplant or a desensitization protocol, and of course, if a patient we feel should not undergo a transplant, even if that is obvious, to inform the patient. So what should be the workup in these cases? So there are some guidelines given by a group called as a STAR group of transplant. They have given some guidelines initially to actually take a proper history from the patients to, in fact, put them into a low-risk category or a high-risk category, so that we can plan a proper investigation for them and to plan a treatment for them. So the first history what should be taken is whether this patient is a first transplant or a second transplant. We all in this room know the second transplant cases are actually put always under a high-risk category. Then besides that, a sensitizing episode. A sensitizing episode can be in a form of a pregnancy. Pregnancy is actually a sensitizing event. You know, whenever a woman gets pregnant, actually she's getting sensitized to the husband's HLA antigens. What about blood transfusion? It's a sensitizing episode. So we should be very, very careful that wherever blood banks are available, please always ask them for leukodepleted products. You know, the more irradiated the product is there, RBC, because we know that most of our patients, they would have been undergoing dialysis before. So a lot of awareness should be given about leukodepleted blood products, so that, you know, we at least let them have the minimum sensitization available. Husband to wife, as I told you, pregnancy is a sensitizing event. So if husband is a donor, again there is an issue. Child to mother, there is a problem. So how the workup should start for us? The first thing is to do a HLA typing, which should always be high resolution, preferably. But if you don't have a facility, a low and an intermediate resolution can be there. Just to show you how do we screen patients for antibodies, please do a mixed antibody screening, whatever option you are having available. At least a mixed antibody screening, which is very cheap and highly affordable, or a PRA. As far as the cross matches are concerned, a CDC, you know, is a gold standard before, but many institutes have given up doing CDC and calling it as a golden history. But still, I think in our workplace and in Karnataka, CDC is still followed. Flow cross match, better, more sensitive, less subjectivity. Lysate-based cross match has its own drawbacks. People want to actually move away from that. Virtual cross match, very good. You can, in fact, instead of mixing all the blood and everything, you can have a high resolution typing, preferably a 11 loci from a donor, and see the recipient sample for antibodies and mix the two, match the two of them. So like that, you can even have a database from all your patients who are coming to you. You can maintain a database from them with the help of a single antigen bead, which is the star of the show. You can have a database, do a quarterly or a 6-monthly single antigen bead for all your patients, keep a database, and whenever you are getting donors, maybe from the disease donor list or from the donors who want to give it for their relatives, you can keep mix matching also, and you know, you can even start a paired kidney transplant program in your own units. Just to go quickly, there are sometimes the non-HLA antibodies are also there which interfere, like the MICA antibody and the AECA ATIR. You can pick them up on a mixed antibody screening. The risk stratification, how do? We go for high immunological risk and the low risk patients, but the preferred guidelines are please do a CDC, flow and a single antigen bead for all the patients who come for the immunological, the workup. But if it's a low immunological risk, no previous history of transplant, no prior sensitization, you can just do a CDC and flow and a mixed antibody screen. If anything is picked up on that, please do a single antigen bead, because I feel saving money prior to the transplant is of no use if he has to pay with his life or maybe a sepsis episode because of heavy immunosuppression later. This is just to classify the PRA less than 10% goes into a low risk, a moderate risk is 10 to 79%, more than 79% push it to a high risk. This is for a deceased donor. I'm the short of time, so I'll just go through the things very quickly. Globally, this is, I think, what we should be able to follow as a country as we progress. We should have some standard guidelines for a workup. We can do a 11 loci. In fact, in our lab also, as of now, we are doing a 6 loci, but we are planning to, from next month, to move on to a 11 loci as per the international guidelines. You should do an antibody testing on 2 separate episodes, one episode just 3 months before the transplant and one before. Interims, any sensitizing event if a patient is having, please do testing for the patient. So in our unit, we are always doing a proper workup. We do a CDC flow, lysate-based cross-match, and whenever anything flags positive, we are doing a single antigen bead. And based on the single antigen bead, our nephrologists are planning plasmapheresis or a plex, and only if everything turns out to be negative, they are moving ahead with the transplant. This is one of the approaches I can show you is a Delhi-based approach they are using. They are doing only a flow cross-match and the antibody screening. They have actually given up with the CDC as well. And they use antibody screening for all their cases. And if anything flags positive, they are doing a single antigen bead. So we can tailor-made our approach, as you see that it's an era of precision medicine. We have precision oncology, we have precision medicine dictating how we should behave for all our cases. So there is no a single fit which can, it's okay for all. We have to tailor-make our risk assessments, we have to tailor-make our treatments based on individual patient needs to ensure that all our patients do well. So this is just a quick look that better matching improves outcome. Otherwise, the patient has more chances of dying of sepsis if we give too much immunosuppression. The MFI, the single antigen bead, whatever reports it is giving, if it is less than 1,500, patients do well. More than 3,000 or 4,000, a lot of high risk is there. So key takeaways is that we should always tailor-made our treatment, our risk profiling, our investigation based on the need of the patient. Low resolution can mislead. Please move to high resolution. MFIs do predict the outcomes of the patient, specifically if the patient has a donor-specific antibody. If you cannot understand it is an HLA antibody, move beyond that. There can be a non-HLA antibody as well. And please make sure that the lab you send should have an NABL accreditation, should have a solid workup, should do proper quality controls. Thank you so much for your time and patience. Thank you so much.
Thank you, ma'am. I now call upon Dr. Santosh Krishnamurthy, consultant and HOD radiologist, Fortis Hospital, Bangalore, to deliver a talk on 3 Tesla MP-MRI prostate with PIRAT scoring.
So I'll be very brief. This is the same talk which I spoke yesterday. So I think many of you may have heard about this yesterday. I'll just screen through the slides. We now are familiar with the prostate PIRAT system, why MRI has to be done, how it is graded. So we'll just run through the slides once again. Okay, so we'll just go through the slides once again. PSA testing is usually insufficient. Trust biopsies often are, can miss lesions between 30 to 40% of the time. So the next option is to do a multiparametric prostate MRI. I won't go through these trials, which have now confirmed that, the way to go forward is the MR fusion biopsy to, accurately diagnose clinically significant prostate cancer. So and this is the evolution of the pyrites. We are now in the version 2.1. So we basically do a 3T MR imaging, which is faster. There's no need for an endorectal coil. Obviously, the conspicuity and the quality of the lesions are best seen on MR. So this is what earlier we used to do on a blind biopsy or basically a segmental biopsy. Now we use the MR for a localization of the lesion in the biopsy. So we classify the risk stratification to low risk, intermediate, and high risk. Based on the low risk intermediate, then the appropriate treatment is guided. This is how it is done in our place. So we do a multiparametric MR, which takes about 20-30 minutes, then is moved to we classify based on the pyrite scoring, and the radiology reporting happens. With the radiologist and the urologist, the MR ultrasound fusion is done, which takes another about 30 minutes. We now know that it is most of this one is done, the fusion biopsy is done on a outpatient setting. So we do a 39 sector classification, which is 36, which is intraglandular, 2 seminal vesicles, and 1 membranous urethra. So when we do the reporting also, we classify based on that, saying that, okay, there is a lesion in the right lobe, let's say mid-prostate, posterior sector as a posterior sector lesion. So the urologist, while doing a fusion biopsy, also is familiar with where the lesion is. This is the same thing. So this is also, we also calculate the PSA density. So this is an example where it was just about 0.09. Anything density of more than 0.2 is clinically significant. This is a normal anatomy of the prostate, where you see the dark transition zone and the bright peripheral zone. So just like in any other lesion, in any other places, for example, in brain or elsewhere, on a T2, the lesions pathology would look bright, but however, here because the peripheral zone is bright, the tumor would look dark. So this is the arrow which is showing that, showing the dark lesion on the T2. The central image is the diffusion weighted image. So the lesion looks actually bright on diffusion. And the third image on the other side is the ADC, where the lesion looks dark again, indicating it's a strong indication of a cancer. So this is the normal, how the cancer and the normal anatomy in the cancer looks. So this is in the transition zone. Like I said earlier, tumors are seen what are classically described as erased charcoal appearance. They are blurred T2, dark images. This is based on the appearance on the T2, the ADC, and the diffusion. They classified as 3, 4, and 5. 3 is intermediate, where the T2, on the T2 it is dark, but however on the diffusion it is not so bright. So we classify it as 3. Then based on if it is bright on diffusion, it is classified as 4 or 5. So this we have gone through earlier. So I think we gave a checklist. I think this is I'll just finish with this one case. This is a lesion with a dark lesion which is seen in the left peripheral zone, which is bright, which is also dark on the ADC. We calculate the ADC as 0.59. Anything less than 0.8 is generally significant. So we also calculate the ADC, indicating it's a significant cancer. We also do the image on the left, also the zoomed image on the left also shows extraprostatic extension. We also do what is called as prostate perfusion studies. The central image shows that we have done a prostate perfusion. There's an increased uptake and a washout, indicating that it's a tumor. I think that's all. I think we have seen the other slides. Just a last one. I think we have discussed all this earlier. Only the last one is, suppose there are multiple lesions, then how do you classify? What is the index lesion? If there are multiple lesions, the lesion with the highest pyramid score, then there's a tie, then you look at the extraprostatic extension. Again, if there is a tie, then you look at the largest lesion, so that would be the index lesion. So one study which we have now, one of our students who is doing that is, these are preliminary data. We have done about 112 fusion biopsies, out of which the sensitivity is about 91 and specificity again about 91%. So general preliminary data about that. Thank you.
Thank you, sir. Next, I call upon stage Dr. Prajvit K.J. Rai, consultant and lead neuro and vascular interventional radiology, talking about IR enhances robotic surgery outcomes.
Good afternoon, everyone. Okay, good afternoon, everyone. I thank Mohan sir and entire SURGX 2026 team for giving me this opportunity to talk about neuro and vascular interventional radiology and how it can benefit for patients' outcome after robotic surgeries. Now, talking about interventional radiology, this is a minimally invasive specialty where we deal with multiple procedures under image guidance, which will help us to deliver the treatment with a pinhole-sized incision. Faster recovery, no blood loss, no scar is what we always talk about when it comes to intervention radiology. And we are in a conference which is filled with minimal invasive treatments, and I'm happy that we also contribute significantly for that. The specialty started way back in 1923. Now we are in 2026, and at 2020s itself, robotic integration has happened even in intervention radiology. And we perform various spectrum of procedures, starting from mechanical thrombectomy for stroke, carotid stenting, from aortic stent graft, embolizations, and peripheral angioplasties. Now, what is the importance of neuro and vascular intervention radiology? Now, when integrate with the robotic surgeons, we can give better outcome to the patient, post-procedural outcome. Now, what are the way we can contribute? One is improved preoperative planning. Now, so for example, in this, what we are seeing is we are seeing the DSA with 3D angiography, which will define the vessels well for a surgeon to operate on it, and also we can help in preoperative tumor localization. So if you see in these images, we can see a breast lesion which is marked with the wire, and surgeon can easily operate, and very tiny lung lesions, if it is not able to be visualized very easily, we can inject dye there or localize with the wire, and we can help the surgeon to operate it better. We can optimize the patients for surgery. For example, in this case, the patient, you can see the first image, the liver remnant volume, if the surgeon is not happy with, we can do portal vein embolization, increase the segment of the liver so that the surgeon can operate better. If there is the complete cutoff, if the complete blockage in the blood vessel, if there is any bypass has to be done, or the peripheral blood flow is less, if you want to establish a blood flow, we can open up the vessel and we can optimize the patients this way. Also, we can help in intraoperative navigation. What do you mean by intraoperative navigation? When the surgeon has opened the abdomen, want to do an ultrasound, intraop ultrasound we can do, or intraop CT we can do, and help to identify the structure that needs to be targeted and help the navigation as well. Now, hybrid procedures are nothing but when the surgery, if there is a lot of blood loss, we can do pre-op embolization. So, for example, also if there are multiple lesions in the liver, we want to resect one half of the liver and there is a lesion in other half, we can ablate that lesion. Also, if there is in this case, what we can see, there is large lesion, vascular lesion, we can devascularize it by embolizing it and make the surgical field with less blood loss. Also, we can treat the lesion so that we can buy time for the surgeons to plan their treatment, get the transplant liver, and so on. Also, the most important part where we come into picture is managing the surgical complications. Now, for example, we have very advanced robotic surgery team in our hospital, and whenever there is any issues in between, you don't have to open the patient and re-explore and do things. We can offer treatments like this where we can see there was a pseudoaneurysm which was embolized. The first picture is the post-embolization, the last picture is the pre-embolization. We selectively block only the vessel that is leaking. Similarly, this is a hepatic artery pseudoaneurysm because of the drain catheter which was kept, which eroded the vessel. We don't block it these days. We reconstruct it. We place the stent graft, reconstruct it. Similarly, this is a gastroduodenal artery stump pseudoaneurysm. We reconstruct it. We don't block it anymore. And sometimes there will be the lymphatic leak. Tiny lymphatic duct is leaked. We enter inside and block it. Again, we don't have to explore always. So if there is any bleeding, for example, bleeding, urinary bladder bleeding, uterine bleeding, anywhere, we can do pre-op embolizations or post-pressure embolizations. If post-surgery patient develop DVT, we do catheter-directed thrombolysis. And we enhance the precision of the treatment by doing biopsies and giving the accurate diagnosis by various methods, CT guided, ultrasound guided, sometimes fluoroscopic guided, forceps biopsies also we offer. Now also, some patients, when the surgery is not possible or surgery is not an option, for example, small child, infant, when we can't offer surgery, we can do just with a tiny hole, we can treat the lesion and cure the cyst. Or we don't have to always open the lung and remove the part of the lung, we can just do an embolization and treat the pulmonary AVM. So nothing is possible without a good team, and I'm very proud to say that we have one of the best neuro and vascular intervention radiology team with 2 board certified intervention radiologists helping our robotic surgery to be the best in the country. Thank you.
Thank you, sir. I now call upon stage Dr. Chandra Teja Reddy to talk on theranostics, our consultant nuclear medicine, Fortis Hospital, Bangalore.
Good afternoon, everyone. At the outset, I would like to express my sincere thanks to Mohan Keshavamurthy sir and the entire team of SURGX for giving me this opportunity. So today my talk is regarding the theranostics. So in simpler words, in theranostics, we'll be injecting the same pharmaceutical both for diagnostic and therapeutic purposes. Diagnosis is with a radioligand that releases gamma rays, which assists us in imaging, whereas therapy is with a therapeutic radionuclide, which emits beta rays like lutetium-177 or yttrium-90, or which emit alpha rays like actinium-225. So since we are targeting the same receptor again, so the therapeutic radiopharmaceutical will reach the tumor cells and deliver localized radiation, not harming the healthy tissues. So if at all the scan is negative, we will be the first people to say this patient will not be benefited with the radionuclide therapy as the radiopharmaceutical is not reaching the tumor tissue. So multiple theranostic pairs are available. Some of them are FDA approved, and some of them are in the investigational stage. I will take you through the most important pairs of them. So though the word theranostics is relatively coined new, the practice is there since decades. So in thyroid cancer, routinely we do iodine-131 whole body scan after total thyroidectomy and assess the disease burden and treat with radioiodine therapy accordingly. So this is one representative case where after post 2 doses of iodine-131 therapy in a patient with lung cancer, we see a complete response. nothing new has happened in the way we treat thyroid cancer with radioactive iodine therapy, but the response rates, what we observe in high volume metastatic disease is very less. So in AIMS, as part of my DM thesis, we have done a pilot study in 50 patients where we have randomized 25 patients and treated with radioactive iodine therapy plus lenvatinib combination and the others with radioiodine therapy alone. What we have observed is a difference of 30%, like 54.5% objective response rate compared with only 24% in the radioiodine group. And the progression-free survival is also like 36 months versus 24 months. So few cases where it showed a good partial response after radioiodine plus lenvatinib therapy. So coming to the novel theranostics like PRRT, PSMA therapy and FAPI theranostics, first I'll take you through the neuroendocrine tumor. So it all started with this landmark NETTER-1 trial where the PRRT has shown a progression-free survival of, median progression-free survival of 28 months versus 8 months. And there is an objective response rate of 18% versus only 3% with sandostatin alone. So with this success, the group has this time included the grade 3 tumors also with Ki-67 of 55%, and the similar success rate of 43% was achieved in the dotatate plus sandostatin versus only 9.3% in the sandostatin group, and the same median progression-free survival is 22.8 months versus only 8.5 months in the sandostatin group. So there is one more trial called COMPETE trial where it their randomization happened between PRRT versus everolimus, and the same, so PRRT showed a good response rate compared to the everolimus. So there is no doubt in the metastatic neuroendocrine tumor setting, PRRT scores over any other drugs. So few representative images where in this case of metastatic duodenal NET, post 4 cycles of luteation, we see very good partial response. And this is a very high tumor burden. After 6 cycles, we also showed a very good response. So there's one more novel indication coming up. If at all patient is inoperable, so we can try as a neoadjuvant setting. Here in this case, the pancreatic NET is very close to the celiac vessel branches. So the surgeon wanted us to do neoadjuvant PRRT. And post neoadjuvant PRRT, we can see the celiac vessels are free, and surgery has been attempted, and the patient is in remission now. So next, coming to the prostate cancer. So the main role comes in castration-resistant prostate cancer, where FDA approved many treatment options are available. One of it is PSMA. So thanks to this VISION trial, where it showed a good response as well as good improvement in the median overall survival, like I think 15 months versus 11 months. So one more trial has been recently published, PSMA-4, where in the pre-docetaxel setting, PSMA therapy was attempted with a good objective response rate, 41.9% versus 12.6%, and with a good median radiographic progression-free survival. So these are the NCCN guidelines. Initially, it was there only in the post-ARP and post-docetaxel setting, and recently it was approved in the pre-docetaxel setting. So one more therapy we can do is the combination with enzalutamide. Obviously, the responses will be better. So we recently started attempting PSMA therapy in hormone-sensitive prostate cancer setting. There is one initially upfront PSMA trial was done where the PSMA is combined with the docetaxel versus only docetaxel alone. Undetectable PSA at 48 weeks is 41 versus 16%. And then PSMA addition trial with updated results, it was shown that the PSMA reduced the risk of progression or death by almost 33%, and like 2 days before it is FDA approved in the hormone-sensitive prostate cancer setting. So multiple PSMA trials are there in the pipeline, like combining with pembrolizumab PRINCE trial and olaparib LUPAP trial. So we are all waiting for these results. And these are few representative images of PSMA therapy. And like, you know, all FAPI picked up in a rapid pace in diagnostic setting, where it is showing, even in FDG negative setting, FAPI is showing positive in most of the things. Unfortunately, therapy is not picking up at the same pace because the molecule is not getting localized, not showing good enough retention in the tumor cell. But recently, the cyclic peptide as well as dimers are being used for therapeutic purpose, and we are seeing good responses with them. Hopefully, we'll see it in the near future. So coming to the last part, alpha therapy. So theoretically, alpha particle scores significantly over beta particle because of the high linear energy transfer and good amount of radiation given to the tumor cell. Unfortunately, it is not able to pick up in the clinical practice because there is supply issues. So though there is so much of demand, hardly supply is there, and actinium-225 the cost is almost 3 to 4 times higher than the lutetium therapies. So one representative image where we have shown good response with actinium-225 dotatate. Initially we tried of lutetium dotatate with partial response, but after 9 cycles of actinium dotatate, we can see a very good partial response in NET. So this is my team at the Nuclear Medicine Department at Fortis. Thank you.
Thank you, Doctor. We now have a talk by Dr. Nandini S. on HCV duo. We can all disperse for lunch after this talk. Please stay in the hall. Thank you.
Very good afternoon, everyone. I am literally what stands between you and lunch. I'll try to keep it short and to the point. Can we have the slides on the screen? Yes. So what I'm going to be talking about today is the current status of testing for HCV that we have and what can be improved upon that. So the topic really is titled, is HCV antibody testing enough? So I'll just start off with a quick case scenario of a 52-year-old male who's about to undergo, let's say, laparoscopic surgery for a change. We have been talking about robotic surgeries all day. And the HCV antibody screen came out as non-reactive. And so they decide to go ahead with the surgery. But later on, he develops some fever, jaundice, 18 days post-op. And there is, unfortunately, HCV RNA detected on the acute hepatitis profiling. So the consequences of such a situation would be that we already have exposed this surgical team to this patient, and even though this is a curable disease, the delay in initiation of therapy has already happened. Similarly, in a much more difficult situation like a hemodialysis setting, let's say you have a patient who's been transferred from another center, undergoes a screen and is negative, and he undergoes the dialysis also. But by the time the next screen is done, he is detected to be antibody positive, and the RNA is already elevated by this time. So, now this index patient has already exposed the other patients who are undergoing dialysis over there, and you find that 3 or 4 other cases are there. Both of these are hypothetical, but entirely possible cases. The problem in both these cases happens because of this very long window that you see after exposure. The RNA may rise as early as 2 weeks. However, the antibodies can take up to 8 to 12 weeks, that is day 70 for the antibodies to appear. There is a significant window here that is not bridged by the anti-HCV testing alone. And that is one of the reasons why there is a huge diagnostic gap. So for, let's say there are 71 million cases of chronic HCV in year 2017. This is a little dated data, but only 20% of those who are actually infected have been diagnosed with the infection because of this problem of testing that we have. So the bottleneck is really diagnosis, and for an infection that is currently curable with a 2-drug regimen of directly acting antivirals, this is quite criminal. So the reasons why this diagnostic gap exists, one of course is we discussed about the window period, and then you have immunosuppressed patients, especially patients in the dialysis settings who have a high prevalence of this infection on the one hand, and also a delayed development or no development of antibodies at all on the other hand. And antibody testing alone may not be able to distinguish if it is a past infection. Even those who have been cured of the disease can continue to have antibodies for life. So just detecting the antibodies is not going to tell us if this is a resolved infection versus an ongoing infection. And testing RNA is of course what is recommended in most of the guidelines, but this can be expensive, and that can be a limiting factor because not everybody will have access to RNA testing. I believe a lot of the dialysis centers also don't have access to RNA testing every quarterly when they do that. So we don't have a lot of large-scale Indian data, but This is one study that was done in Chennai in a small setup of dialysis center in a medical college, which showed very high prevalence of HCV. And the bigger problem was that 89% of the high viral load cases were actually missed by testing the antibody alone. And therefore, this is a classic CDC algorithm which basically advocates for HCV antibody as the screening test. If it is non-reactive, you stop right there. If it is reactive, then you recheck with the HCV RNA. But the problem with this algorithm is that there are only 2 steps, and there is a significant number of patients that you will miss if you're going to leave patients who are negative as non-reactive. So, and now we have a precedent of HIV. HIV also had only antibody testing till about 10 years ago, but we have added the P24 antigen to the testing algorithms in most cases. Even the NACO currently recommends, at least for blood banks and high-risk screening centers, that you use a 4th-generation assay. So what's a 4th-generation assay? You have an antigen plus antibody test that we do for HIV. And HCV has a similar logic. So there is an antigen that is first started to rise along with the RNA, and then you have the antibodies arising much later. In fact, it's even worse than HIV because at least in HIV you have a 4-week window. Here you have an 8 to 12-week window. So why don't we do the same for HCV is the question that we'll be talking about. So the science of combined testing for antigen plus antibody is what we'll be talking about in the next couple of slides. So if we are doing antibody alone screen, we are not looking for the core antigen. So similar to the P24 of HIV, the HCV core antigen is a nucleocapsid antigen which is present in actively replicating HCV virus. And the practical advantage is that this is an immunoassay. It is not a PCR assay. You don't need a PCR setup. You don't need to do real-time machines and all that. You can just do it on the same equipment that many of us will already have that runs the HCV antibody test. So it's an immunoassay. It's less complicated. And the window period coverage compared to antibody for the antigen test is at least 20 to 23 days earlier. So you are significantly bridging that window period with a rather cheaper immunoassay method rather than a HCV RNA. And the HCV antigen correlates quite well with the viral replication and with the RNA test as well. And both of these, EASL and WHO in their latest guidelines do advocate for HCV antigen testing as an alternative to HCV RNA wherever it is not available. So that is the summary of guidelines. The EASL 2020 and the WHO 2022 recommend to use either HCV antigen or HCV RNA to demonstrate active replication. The US guideline, the ASLD, currently doesn't have antigen. That may be a regulatory bottleneck because antigen test was not yet available over there. But the vast majority of guidelines where it is available do advocate for RNA, the HCV antigen. The problem here again is that you use it as a confirmative test is what the guidelines recommend. But why don't we actually use it at the screening itself, right? Just like we do for HIV. And that is what is being proposed by this combination of antigen and antibody test, which is a test which is called Alexis Duo, HCV Duo, which is offered by the COBAS. So even though the earliest marker is HCV RNA, which is detectable from day 12 post-exposure, the combined antibody reduces the window period to 20 to 23 days compared to an antibody-only test. And this is a single specimen. There's no need to do a secondary test to confirm. There's no need to prick the patient a second time, expose all those that are drawing the blood also to a potentially infected patient. In a single specimen, in one go, in 27 minutes, you will have both the results of HCV antigen as well as antibody. So this is what we call as a 5th generation assay for HCV as far as HCV goes. It is an antigen plus antibody test in a single blood draw on the same platform. And you'll end up with basically 4 kinds of actionable results. If you have a result which is both antigen and antibody negative, it is a good rule-out test for ruling out infection in most cases, except the very high-risk groups in certain cases. If you have an antibody only, which is antigen negative, it is more likely that it is a past exposure and there is no current active replication happening. Antigen alone positive definitely is where it's really, really useful. You have picked up the case in the early window period itself. And if both are positive, it is a chronic active infection. So this is an interpretation that you can actually do by doing a combination testing with both antigen and antibody for HCV. The sensitivity specificity across a lot of the peer-reviewed literature that are cited here is very high, is about 99.6% sensitive, 100% genotype coverage, and quite highly specific. And the predictive value, which I was talking about, is also very high, especially if both the antibody and antigen are positive, very high positive predictive value, and both antigen antibody being negative has very high negative predictive value. In the hemodialysis setting, as I mentioned, which is a special case because if you see, compared to the normal population, the prevalence is much higher in the hemodialysis setting. So it's a double jeopardy issue. And it has been shown in various studies that, again, in this setting also, where you have such a high prevalence of about 80x times the normal population, using this test as a negative predictive value and positive predictive value has been useful. So this is the algorithm that is being proposed. So we do a HCV duo, which is an antigen-antibody combination test, and if it is negative, it is a good rule-out test. If it is positive, you will actually get the result as HCV antigen positive, antibody negative. This is also an advantage over many of the available 4th generation HIV assays, which will not tell you that. It will only say that it is positive, and you have to assume that it's either the P24 antigen or the antibodies. And if that is positive, you can just go ahead and treat. You don't really need to do a lot of HCV RNA in most of the cases. And high-risk groups like hemodialysis, HIV positive, transplant recipients, other immunosuppressed patients, the combination testing is really more recommended compared to an antibody-only test. So the key takeaways from this talk is that antibody-only testing has a fundamental biological issue. There is a blind spot that you will be missing. And adding a core antigen will close this window by at least 20 to 23 days. And using a combination is really what is recommended even by the guidelines currently. And we are not really ahead of the guidelines. We are actually in line with the guidelines if we do this dual testing. And the parallel that we like to draw is that with the 4th generation HIV. In high-risk settings, the combined testing should be the standard and not an exception. And in fact, if you have a test that is available that can actually look at both antigen and antibody in one go, costs remaining more or less similar, and it's a simple immunoassay, it's really a no-brainer that you go with such a test rather than doing an antibody plus an RNA assay. So those are my references. Done. So we can take any questions if any of you have. Okay, thank you. Thank you so much.
Thank you so much, Doctor. We can all now disperse for lunch. We are done with the morning session of our talks, and we'll all meet back in the same hall at 2:30 p.m. Thank you.
I know this is a Sunday afternoon and at time many of us might feel a little sleepy, but we will do our best to keep you engaged as we take you through the fast evolving world of robotic cardiac surgery. For nearly a century, the median sternotomy has been the golden standard approach to cardiac surgery. Today, the paradigm is changing and we are witnessing an exciting journey in robotic cardiac surgery. Today, we have Dr. Sudarshan, Director of Minimally Invasive Cardiac Surgery and Robotic Surgery, Fortis, Bangalore, to take us through this journey of robotic cardiac surgery in this session of Beyond Sternotomy, the Robotic Revolution in Cardiac Surgery. Welcome Dr. Sudarshan on stage. So we are privileged to have a multidisciplinary panel with Dr. Murli Chakravarti, Senior Director of Anesthesia, Fortis, Bangalore, Dr. Rehan, Lead Consultant Cardiac Surgeon, Robotic Surgery from Apollo, Chennai, Dr. Chetan, Senior Consultant Cardiologist, each of them bringing a unique perspective to this exciting field and to explore on how robotics is reshaping patient selection, hybrid workflows and future standard of care in cardiac surgery beyond the open chest approach. Over to you, Dr. Sudarshan.
A very good afternoon to you all. I think everybody has settled down after the lunch session. Now, this being a robotic meeting, you must be wondering what cardiac surgery is doing here. Now, one small trivia is robotic surgery started for the cardiac work way back in 1990s. Somewhere down the line, the laparoscopic general surgery and urology have taken over, and then it's a reinvention of robotic cardiac surgery in the last 5 to 7 years. So just a brief introduction of what we do, what sort of surgery we do. So I'll present in a form of a case presentation of 2 cases which we have done in the past, how robotic surgery has given an advantage for these patients. So the first patient was a very old lady, 82-year-old, which on first instance you would think that it's inoperable. She was having very bad difficulty in breathing with repeated admissions, repeated hospitalization for dyspnea of acute pulmonary edema, requiring NIV. And on echocardiogram, she was found to have a very severe mitral valve disease with a stenosis and regurgitant lesion. So, and she was already on maximum medication. There was no other options available. Her angiogram was normal. So, what next? So, the options available were either we go for a transcatheter mitral valve, which is the intervention way of doing it, or you put a medical management for a lifelong, or can we offer any surgical option for these patients? In the past, we would have done an open surgery when this was not, MICS and robotic was not available. And in the last 15 years, we have evolved to do a minimal invasive. And now, can robotic give an added advantage? So this is how the traditional heart surgery is being done. Now, because of this frail patients, 82-year-old female, they are osteoporotic bone, they do not heal well. And why robotic for this patient? What advantages to this robotic gives is minimal pain, and the blood loss is much lesser in these patients. The sternotomy takes a long healing time. It takes around 2 to 3 months time for them to heal completely, to allow them to get back to work. And sternum wound complications for those who are uncontrolled diabetes and elderly patients, and cosmetically unappealing for somebody in younger generations. For all these reasons, robotic holds a very good advantage. Now this is how the 3 different consoles you must have seen from morning. On the left is the console where the surgeon sits and operates. On the middle is the patient cart which sits next to the patient, which passes all the instrument through a small 8mm incision. On to the right is a vision card where everybody else in the operating room can see what is happening. So this is a brief picture as to what robotic surgery or maybe robotic heart surgery involves. Now for these patients, for this lady, we offered a robotic mitral valve replacement. So this is how the patient's port placement is being done. You would see that in the center there's a utility port and 3 other ports are being utilized. Why robotic? Again, I told you this is what we have done. Can the video play? Yeah, so this is a short video of what we did for this patient. And 82-year-old female, we place the port placement. And for all these intracardiac procedures, we put the patient on heart-lung machine to stop the heart and do the procedures. So instead of opening the chest, we utilize the groin vessels, femoral artery and femoral vein. and we take the patient on heart-lung machine, we stop the heart, we open the heart chambers, and you could see how the robotic instruments can work in a small, closed, confined space. The advantage and beauty is that very little movement is required at the chest wall. We can look at the back of the heart. The mitral valve is located at the back of the heart, and the robotic gives an advantage to look at the mitral valve at much more precision. We can take all the sutures at more precision. We can be ambidextrous. We can place all the sutures all across with a very little movement at the chest wall. And the bedside assistant plays a very important role. Fortunate to have a very good bedside assistant who can manage all the sutures at the bedside. And at the end, we tie this valve in position by using a suture fastener, which is called a core knot, which is a boon for the robotic heart surgeries. As you would see that this knot are in place, the mitral valve is completely replaced, and we close the heart chamber and we take the patient off the bypass. So even the small sutures can be very well managed through the robotic, which was slightly difficult for a minimal invasive approach. And at the end, all this is the incision at the end. And most of these patients are taken off the ventilator in the operating table. And this patient was walked in ICU after 6 hours, did not receive any blood transfusion. The blood loss was hardly minimal. And with the excellent the post-operative ERAS protocol, post-operative pain control, they do not require any more analgesic than what we used to give earlier. And with less tissue cut, the wound complications are much minimal. And patient was discharged on 4th day after surgery and back to work on 2 weeks. Believe me, this was an 82-year-old with back to work with minimal pain, mobilizing well, and she came to follow up after 2 months with no problem whatsoever regarding lung problems, and she was very little medications. Now another set of patients, second patient, who was a very young professional, completely asymptomatic, came for routine health check. She had a very vague dyspepsia. She went to a medical gastroenterologist, Dr. Ravindra diagnosed. He did a the endoscopy, and on endoscopy he found a tumor in the heart. So we did a echocardiogram and it showed a large left atrial mass. So that needed early surgery. Now imagine a young professional, if you offer a sternotomy, the patient has to be off work for 2 months' time. Can we do something else? They are completely asymptomatic. The first question they ask is, how will the surgery benefit me? Again, for this patient, this was what we have done. So you could see that the robotic goes very close to the tumor mass. We have entered the left atrium. We have gone dissecting the mass from the atrial attachment. We could not do it much earlier without the robot because we used to excise the complete septum and replace with the patch. But now with the aid of this robotic precision and the magnification, we can go right across into the chamber, separate it from the heart septum and remove the mass completely in toto with very little morbidity to the patients. And again, this was the left atrium which is open, atrium is retracted, very fine scissors dissecting it, the mass from the atrial septal tissue, and with no trauma to the surrounding structures. And this is taken off in the bag. The patient was extubated and was discharged on second post-operative day. So these are what the robotic technology for the cardiac surgery also been benefiting the patients. How it different from conventional heart surgery? Conventional, as you know, we used to make a large midline incision. The robotic will make a small 8 to 12 millimeter incision. That's how the advantage in respect to the pain and the post-operative recovery. We do not divide any bone. We go utilize intercostal space, and that's how the patient's pain and other the complications are minimized. And most of the patients are discharged on 3rd and 4th as opposed to 7th or 6th or 7th post-operative day, and they are get back to work. And younger patient, it offers an excellent cosmetic results. And the frequently asked questions, many of these patients come and they ask is, who can undergo the robotic heart surgery? Is it for all comers? Well, the answer to that is, even now we do a right selection of the patients. Only on right selection we can offer a good, excellent advantage. At least we can offer the robotic for at least 60 to 70% of the patients who come in for heart surgery. So it is not for all comers at this point. We have to select the right patient for the optimal outcome. And is it safe? Yes, definitely safe. It offers the safety of the conventional heart surgery and it offers the precision of the minimal invasive heart surgery. So it's a mixture of both. The patient recovers much faster. And contrary to the popular belief, it will not replace the surgeon. The surgeon still controls the robot. He sits at the console, monitors the movements at the patient bedside, and it is the long-term results are as equivalent to an open surgery. So it is not inferior. It is definitely superior with respect to the preventing the complications. And again, it is not for everybody who can undergo. So our experience at Fortis hospitals, as you know, robotic heart surgery is catching in the last 5 years. Even in India, less than 0.5% of the surgeries, heart surgeries, is being done robotically. And we have, in the last 10 years, we have been doing MICS. In the last 250 cases, we have done robotic heart surgery for these patients. We have a very dedicated robotic cardiac surgery team, and it's a teamwork. It's not a single surgeon. And robotic involves a surgeon, requires an experienced bedside, requires an anesthetist, perfusionist, scrub nurse, technician. Everybody has to be on the same page. So we have a very well-established robotic steering committee has helped us to enable a very good robotic cardiac surgery team. And as I said, it's a multidisciplinary team. A patient going to the post-operative patient with minimal pain, our physios mobilize the patient and help the patient to get back to work much easier. And our results are almost equivalent or better than the international what claimed for. So the take-home message, robotic heart surgery is not very far. We are doing it, and it has been catching up in the last 5 years. It's modern, precise, and patient-friendly. It definitely causes faster recovery without compromising the patient results. And it has got better outcomes with lesser complications. And thank you very much. And if somebody wants a heart surgery being done robotically, kindly contact a person who is actually skillful for it. So the combination of things is you have to select the right patient, you have to select the right procedure, and also the right team for the optimized results. Thank you very much.
Thank you, Dr. Sudarshan, for a wonderful talk. We move on to the panel discussion. My first question is to Dr. Chetan, the interventional cardiologist. How essential are preoperative imaging like CT, angio, in deciding which patients are suitable for robotic surgery, and how do they help you in making a decision which patient to refer to robotics or minimally invasive or conventional surgery or angioplasty?
Yeah, both CT coronary angiogram, both CT angiogram and 3D echo are very vital in assessing the patients, and because robotic surgery will need very stringent criteria when we assess through the CT and 3D echocardiogram. With respect to CT angiogram, initially, if the patient is planned for a robotic CABG, we see the course of the LAD. If it is intramyocardial course, and if it is a little bit deep, then the patient is not suitable for robotic surgery. And we see the LAD quality and the vessel size also. If at all the left anterior descending part in the distal part, if it is heavily calcified, if it is small caliber vessel, and there is a diffuse disease, so those patients cannot go for robotic surgery. So we need a LAD of at least 1.5 to 2 millimeters, and it should be quite healthy, and it should have a superficial course. And with respect to CT angiogram also sheds light with respect to the lima, which is the main artery which we are going to use in that. So lima, the size should be at least 2 millimeters. It should not be tortuous, and it should be of good quality. So that is there. And subclavian artery stenosis and all we can find through CT coronary angiogram. And with respect to the ascending aorta and arch of aorta, we usually see for any aneurysms, dissections, and any atheromas in those places, because during the procedure we do endoclamping and all, so that is the place wherein the endoclamping is done. And as we go down the descending aorta into the peripheral arteries, so the size of the iliofemoral arteries are quite important. So the size should be more than around 6 millimeters. So that is the consensus which is there. Anything less than that, it becomes very much difficult for us to artery and veins.
Okay. So pre-op imaging is very crucial in sending a patient for robotic surgery. My next question is to Dr. Murli Chakravarti, sir. How is the anesthetic management different for robotic surgery compared to conventional sternotomy surgeries? And how do you manage the complications or the problems associated with one lung ventilation during the surgery?
Yes, you actually partly answered. One lung ventilation is a must for minimal invasive cardiac surgery. It is not required for sternotomy. And also doing one lung ventilation itself is matured over time. The tube can slip after positioning. All that should not happen. There are some surgeries where the surgeon will say, oh, it's okay, you ventilate both lungs, I'll manage. But cardiac surgery where minimal invasive, where lungs cannot come into the field, that is one very important thing. Second thing is, in minimal invasive cardiac surgery, we have to do transesophageal echo. If for some reason patient cannot get transesophageal echo, we perhaps not do the minimal invasive. Because the patient's, every step of the cardiac surgeon, the cannula that he inserts in the femoral artery, into the right atrium through the femoral vein, guide wires, all that is monitored by the anesthesiologist who is seeing that. And also, a patient who has got calcification of the femoral artery, as Chetan was mentioning, then you have to be very, very careful, because in minimal access, you don't see the complication. Like in sternotomy, if there is an injury to the aorta, you will immediately start seeing the blood. If retroperitoneal aorta in the abdomen gets dissected and the cannula goes out of the aorta, once they go on bypass, the patient will exsanguinate into himself. So these are some of the problems. And it is, although the pain is generally less, thoracotomy pains are more than sternotomy pains because it moves with every respiration. So we have to give excellent pain relief from the word go. At our unit, we have a mandate that all the patients get erector spinae block. And Dr. Rehan was saying that that is a common practice even in Apollo Chennai. So we have to give excellent pain relief. Our pain relief usually does not include sedative medicines like morphine, fentanyl. It only usually is a block, nerve block. And many of you will be surprised that like thoracic cavity is like an onion. There are layers after layers, and each layer encompasses a nerve. So you can give nerve blocks many, on the transverse process between the inner intercostal and the pleura. We can deposit local anesthetic. We can give a rectus sheath block. We can give a posterior intercostal block, SAP, serratus anterior plane block, like that. Erector spinae block, I call it as a block panacea block. So these are some of the things. And the most important thing is, most of the times, like I mentioned in my lecture also, that this robotic surgery is so interesting to see, look at. At that time, we should not be neglecting the patient monitoring. So one has to be all the time monitoring the patient.
Thank you, sir. My next question is to Dr. Rehan. Is robotics a luxury tier for a select few patients, or is it the inevitable definitive standard of care for all, especially with more and more patients presenting for redo valve surgeries and redo bypass surgeries?
So I think robotics is going to be the standard of care. That's what I think, not just for valve surgeries. I think it will also be for coronary artery surgery. Today, rightly pointed out, it's where you go and get it done. In the right center, you can get a multi-vessel total arterial bypass through a robotic approach. So why would you want to get a sternotomy if you can get this done with the same long-term outcomes as open sternotomy? Number one. I think for structural heart, it is now the gold standard for mitral valve surgery. All mitral valve surgery should be done. But I think there is no role, absolutely no role for open sternotomy in mitral valve surgery. It should go to either MICS or preferentially robotic surgery. It's not a luxury anymore. When you look at it from a point of view of economics also, as time will think, people will get to understand that even though you have initial investment into infrastructure, the cost saving with the average length of stay being brought down will be huge, and return to work being faster will make the difference.
My next question is to Dr. Sudarshan. What is your threshold for aborting the robotic approach and conversion to median sternotomy, especially in the event of hemodynamic instability?
Well, the standard for any conversion from minimal invasive to open holds good for all. If the procedure is not going safely as predicted, or you encounter any complication which cannot handle minimal invasive or robotically, you have to convert. Well, conversion is not a complication. You don't call it as a setback. It's just one of the side effects, or probably for the patient safety we are doing it. Many a times, even after careful patient selection, which we think can be done robotically,
we do come across. The chance of conversion is less than 1%. But in these less than 1%, whenever we come across hemodynamic instability, like after we doing the procedure, the patient has got some electrical abnormality, like ventricular arrhythmias, dangerous ventricular arrhythmias, or any bleeding which cannot be controlled. Sometimes when you redo cases, you're not exposing the heart. So these are the points where you have to convert early. And the gold standard is convert early than late without causing any patient problems. So the bottom line still remains patient safety rather than the procedure.
Thank you. My question to Dr. Chetan, what are the current guidelines for hybrid cardiology or robotic cardiac surgery programs, especially the timing of angioplasty and robotic bypass surgery?
Yeah, I think in hybrid coronary revascularization, there is a prerequisite wherein they'll do a lima to a lady. And the prerequisite is the LAD has to be graftable. Okay, it has to be graftable, and it is not suitable or amenable for PTCA. So that is the most important thing. And the non-LAD lesions have to be PTCable. So we should be able to do PTCA to non-LAD lesions like RC and LCX. But the most important factor determining the thing is, I think it's a hard team discussion. Okay, we have to do an angiogram and we have to decide beforehand what is the line of management, establish the timelines. Usually how we in acute coronary syndromes, the patient is having angina, the patient is having hemodynamic instability. We revascularize the artery through stenting first. And then after the patient becomes stable, then we do a staged, we'll ask the surgeon to do a staged bypass surgery. But usually how it goes is we ask the surgeons to do the CABG first. And then in patients with stable ischemic heart disease, patient is stable, we ask the surgeons to go first, and afterwards we try to stage the PTCA later. So that is the modality we follow. Yeah.
So at both here and at Chennai Apollo, our policy for hybrid is we do the Lima LAD, and we might even do the left system, and we leave the right for the cardiologist to stent for the stentable right. So it's usually 48 hours after surgery. If we are sure there's no bleeding, everything is good. Patients anyway loaded with antiplatelets even after surgery. So we take them into the cath lab. The advantage is you can shoot your Lima and shoot your other graft. You're now convinced that your other two grafts are flowing, and then you do the PCI to the RCA instead of using a vein graft.
Thank you. Thank you, esteemed panelists, for your valuable opinions. So beyond sternotomy, robotics is set to become the default platform for cardiac surgery, delivering superior precision, ergonomics that standardize outcome and shorten the learning curves. Thank you, everyone. Thank you, sir.
Thank you, Dr. Geeta, for moderating such a wonderful session. Next, we move on to the minimal access segments. To moderate this session, I would like to call upon Dr. Shashikiran BD, Consultant Surgical Gastroenterology from Fortis Bannerghatta Road. The first case is about challenges in pancreatic surgery. I would like to call upon the panelists. Dr. Ravindra, Director, Department of Medical Gastroenterology, Fortis Hospital, BG Road. Dr. Anil Kushtagi, Additional Director, Internal Medicine, Fortis Hospital, Bannerghatta Road. Dr. Sanjeev Shetty, Consultant Surgical Gastroenterology, Fortis Hospital, BG Road. Dr. Ravi Kirti M, Senior Consultant in Internal Medicine from Fortis Hospital. Dr. Balakrishna, Consultant Surgical Gastroenterology from Manipal Hospital. And Dr. Rajesh B. M, Consultant Surgical Gastroenterology from Fortis Hospital.
Good evening, everyone. Let us try to understand why robotic surgery would be required in pancreatic diseases as such, and whether we have any advantage of robotics over laparoscopic procedures. Laparoscopy has been kind of understood as a standard of care for any diseases related to the pancreas as such. So robotics has come up in a big way over these 10 years. Let us try to understand, is there any difference? Do we have any advantage if we use robotics over laparoscopy in the coming slides? So why does it matter? So why should we be considering robotic surgery in pancreatic malignancies? So pancreatic operations are some of the hardest abdominal surgeries to perform. So robotic technology is spreading fast, and an honest look at limits, benefits, and how our different specialties can work better in understanding the management of pancreatic malignancies. So first and foremost, the thought that comes to our mind is, whenever we talk of robotic surgery, we always talk about cost, more cost than an open or a laparoscopic surgery. However, that gap between the cost is narrowing as the number of cases we do increases, and with fewer complications, the number of readmissions also tend to decrease. In that way, if we calculate the overall length of stay, sometimes we can achieve the results as the same as we achieve with laparoscopic procedures. So how we got here? So initially it was open surgeries. In the year 2003, first robotic Whipples was done. So in the year 2024, so many advances are happening in the robotic field. So claimed advantages of robotic platform, as we have been discussing since morning. So we have a very high 3D vision. So we have 7 degrees of freedom. It's like wrist of a human being moving inside the patient's abdomen via minimal access approach. So what makes it hard? So let us try to understand what are the challenges in dealing with pancreatic malignancies. So most important thing is we are working right next to major blood vessels whenever we are doing Whipples, pancreatic malignancies, or any, and distal pancreatectomies. So the main veins being the SMV, the portal vein, bead splenic vein. So and reconnecting the pancreas to the bowel, so that is called the Achilles heel. So high precision is required. So the ductal mucosa anastomosis needs to be very precise while doing it to prevent any post-operative pancreatic fistulas. So why is it a high-stake surgery? So the morbidity rate is very high post-pancreatic surgeries, and the mortality rate is 1 to 6%. So we don't have any chances of any error being done these kind of surgeries. That's why robotic surgery may be considered, and sometimes may be considered superior to laparoscopic procedures whenever we do pancreatic surgeries. So this is a short video of Whipples being performed. So initially, as can be seen, so we are cauterizing the duodenum. So this is the gastroduodenal artery being dissected. As we can see, we are using scissors, but because of that vision, we can easily dissect even around the artery also without much hindrance. So this is gastroduodenal artery being clipped and ligated. So then we are dividing the stomach. So now we are creating a tunnel along the inferior aspect of the pancreas. So we can see the portal vein. So, and we are dissecting just above the portal vein. You can see the precision with which we are doing. So the portal vein is just behind, and we are dissecting along the neck of the pancreas without much difficulty because of that vision. So now we are doing the uncinate process. This is also a very important step. So as we can see, portal vein is just next to the specimen that's being dissected. So with robotic system and with good sealing capacity, we can achieve it with much less blood loss. So the specimen is out now. So then coming to the reconstruction part. So reconstruction needs to be very precise to prevent any post-operative complications like post-operative pancreatic fistula. So first we are doing a hepatocystectomy. As can be seen, I am using my left hand to do that suturing technique. So with laparoscopy, using a left hand is very, very difficult, and to reach that angle with right hand is very difficult. So with robot, we can use left hand, and we can steadily use our left hand. This is hepatocystectomy that is being reconstructed. So the visibility is into 10 times. So that's why we can easily see the duct is not that much dilated as can be seen if it were to be seen via laparoscopy. So with robotics, that magnification is giving us that advantage. So that placement of sutures is precise here. So this is hepatocystectomy completed. So then comes pancreaticogynostomy. So this is the most important step in doing a Whipples procedure. This needs to be very precise, and most of the times pancreatic duct is not very dilated, and some patients have soft pancreas. So in these conditions, the precision with which we do anastomosis becomes very important. pancreatitis, then we are doing a gastrojejunostomy. This is a simple technique. So coming to the learning curve, so everybody talks about doing Whipple's procedure, but we need to understand as to when we are eligible or capable of doing a robotic Whipple's. So different studies give us different levels of understanding. So in some cases it is 46 cases, in some studies it's 20, in some cases it's 27, in some cases it's been as high as 250 cases. So coming to our panel, so I would like to ask Dr. Sanjeev. So even a dedicated high volume center needs roughly 5 years to accumulate 250 cases. So is this threshold realistically achievable in our setup, especially in Bangalore, where the number of cases we do is kind of less as compared to other centers?
Yes, sir. So as you said, it's a bit unrealistic to expect the number 250, especially since robotic adoption is not so common, and the number of reference centers which are doing robotic pancreatic surgery is very less in our country. So, and it also depends on the laparoscopic experience of the surgeon also. So that might help to flatten the curve a bit, because the first 40 to 50 cases will go in docking and optimization of ergonomics, etc., etc. And probably more than 100 cases, the oncological outcomes will improve, and other complications like pancreatic fistula and bleeding, etc., also will come down.
True. So as he was explaining, Whipple's is purely surgery of experience. So the platform definitely helps us, that being robotic. Having said this, experience also matters. So we have different number of cases stating that this is the minimal threshold that is required. So eventually at some point of time, sometimes it is around 50 cases that's been established. So then coming to Dr. Rajesh. So should robotic pancreatectomy be restricted to surgeons with prior laparoscopic pancreatic experience, given data suggesting that it shortens the course? As we were telling, so people who have done more number, like 100 number of Whipple's cases laparoscopically, so they tend to adapt to robotic system in a much easier way as when compared to people who have not done much of laparoscopic procedures. So what's your thought on this, sir?
Even though the earlier prior laparoscopic experience, especially the advanced laparoscopic experience, shortens the learning curve in a robotic procedure, but consensus and guidelines say that it need not be mandatory that the surgeon should have operated advanced laparoscopically. He can even straight away go into robotic with minimal knowledge of minimal access surgery under proctorship and guidelines.
True. So basically, no one would directly embark on doing a robotic Whipple's to start with. So if we are doing a robotic surgery, if we are starting the robotic program, so initially we would have done so many cholecystectomies, so many hernia surgeries, so many colorectal surgeries, then only we will be embarking on doing a robotic Whipple's. So, Dr. Balakrishna, so what is the ethical cost of learning curve cases themselves, and how should programs disclose that to the patient? Because if I do a robotic Whipple's for the first time, obviously if we see from patient's perspective, so that will be my first case, even if I had done so many laparoscopic procedures. So how do we go about reading that path?
This is where the institute itself comes into the picture. The institute should ensure adequate training protocols for the surgeons. Initially, the surgeon should pick easy cases in which there is not much vascular involvement and such things. And for the first few cases, a proctor or a mentor should monitor the cases. Yesterday we had a very good debate between robotic cholecystectomy and lab cholecystectomy. So there is no right or wrong procedure here. So we need to adapt to the newer developments. We can't say I'll not do a robotic cholecystectomy. Without doing a robotic cholecystectomy, you can't venture directly into doing robotic pancreatic procedures. So what the institute needs to ensure is the surgeon is adequately trained, proctored, there is a good informed consent that is taken, and there is transparent documentation. So all these things should be taken care before venturing into complex robotic procedures.
True that, sir. Sir, Ravindra, sir. So we have been talking about so much about robotic Whipple's procedure for periampullary malignancies. Sir, do we have any endoscopic ways of managing very early low-grade tumors in the ampullary region?
No, I think as surgeons are going from open to laparoscopy to robotic, we have made it no surgery. That is, when they have an ampullary tumor, now we can do an ampulectomy. Means we cannot replace surgery, but very early tumor, if there is a small tumor in the ampulla, where periampullary carcinoma is done by either open surgery or a laparoscopic surgery or a robotic surgery. But if it's a T1 lesion which is close to the ampulla, we do what is known as an endoscopic ultrasound. We'll see to it that the muscularis propria layer is not, if it is involved, then we send them for surgery. If it is muscularis propria is not involved, then endoscopic ampulectomy can completely cure off his carcinoma. Provided PET scan is done, there is no lymph node, and then the muscularis propria layer is not involved. No surgery, only endoscopic procedure, T1 lesions.
Sir, if a patient presents to you with jaundice and with a diagnosis of periampullary carcinoma, so when do you refer this patient to a surgical gastroenterologist or you refer it to a medical gastroenterologist? So what is your take on this?
Okay, I think we need to assess the patient, whether the patient has got associated cholangitis or not. We need to look at the liver functions. So look at the bilirubin. If the bilirubin is more than 15 and the patient is clinically unstable, probably the medical management is going to be the better option. Then you can refer the patient to the medical gastroenterologist. If the patient is tumor is operable and the bilirubin is less than 15, probably we can send it to the surgical procedures.
Sir, sometimes patients with pancreatic malignancies present to clinics with new onset diabetes. So many patients in their 40s and 50s would present to the clinic with diabetes. So do you consider? So when do you consider that this patient could be malignancy? The patient doesn't have any family history of diabetes. He's fit and fine. At 50 years, he comes to the clinic and says that he has got diabetes, and you make a diagnosis of diabetes. So do you suspect pancreatic malignancies? Because sometimes pancreatic malignancy, the first sign could be a new onset diabetes. So how do you go about in these kind of patients, sir?
Usually the presentation will be that they come with high sugars first.
Yes, sir.
So what we need to do is again find out whether the head of the pancreas was involved, was it surgically removed, or how much part of the pancreas which was removed. That needs to be found out. Second thing is we'll try to look for the other blood markers like C-peptide and serum insulin levels also. If they are on the higher side, then we can go for a medical management. If it is on the lower side, then we have to go in for a insulin therapy. But basically, pancreatic surgery, it would be a regular management where, depending on the C-peptide and insulin, a combination or a oral hypoglycemic agent or with the associated insulin therapy would be an option.
Thanks.
So,
the most important reason as to why the robotic surgery is used for pancreatic malignancy is its less incidence of conversion. Is its less incidence of conversion to open surgery. So Whipple's is one such procedure wherein many a times it will be required for us to convert the procedure to open surgery. So as when we are doing with it robotically, the odds ratio of us converting is almost less than half of what would be done with laparoscopic procedures. So to put it in a nutshell, so operative time is a bit more for robotic surgeries, but blood loss, conversion rate, the incidence of pancreatic fistula, robotic surgery tends to fare better than laparoscopic procedures. The lymph node yield is also better with robotic procedures. So blood loss trade-off, the operative time is in the initial stages because docking and all these things takes a bit more time. So the time is not significantly longer than laparoscopic procedures, but it is significant. But it is but the blood loss is less as when compared to in laparoscopic procedures. So then coming to robotic distal pancreatectomy, so I'll keep it very brief. So tumors in distal body and tail of pancreas. So I have a very short video. So I hope yesterday also I showed this video. So basically we open up the gastropolic ligament. So then we start dissection along the splenic artery. So we are clearing lymph nodes of the artery. So we are clearing the lymph nodes of the artery. So with robotics, as can be seen, we can see the layer between the artery and the lymph node. So with this vision, so even if we don't have a tactile feedback, the dissection becomes easier. And we can see even the smallest of the smallest blood vessels. So this is the splenic artery that's being dissected. So then we clip it off. You can fast forward. So then we go along the inferior aspect of the pancreas. So this is the splenic vein that's being isolated. So vein dissection is very difficult because even the minutest of the injury will cause a lot of hemorrhage. So with robotic systems, with the visibility, so it's kind of an easier thing to do. we are clipping the splenic vein. So then we dissect pancreas along the retroperitoneum, along with the spleen, the specimen is taken out. So I just want to show the dissection of the vessels here. So the main advantage of robotics in distal pancreatectomy as when compared to laparoscopic is the preservation of spleen. So whenever we'll have to preserve the spleen, individual arteries, pancreas from the splenic artery and veins need to be ligated, saving the splenic artery and vein. So in this case, because of that vision, so we will be able to save splenic artery and splenic vein. So the incidence of spleen preservation is better with robotic procedures. So this is a trial, it's an RCT trial showing the advantage of minimal invasive pancreatic surgeries versus open surgeries. So to summarize, so operative time favors laparoscopy, but blood loss, conversion to open, splenic preservation favors robotic surgery. Post-op complications slightly favors robotic. 30-day mortality is obviously favors robotic, but cost-wise, robotic is higher. So the question is open. So what do we do? So when should a physician or a gastroenterologist refer a patient with a pancreatic mass for surgical evaluation? We have discussed about this. How can our specialties communicate better across a patient's journey before and after surgery? So at Fortis, we have a multidisciplinary team approach. So whenever a patient with cancer comes to us, we involve the medical gastroenterologist, medical oncologist, the surgical oncologist. So we all take a call and what needs to be done for the patient, accordingly we manage the patient. So what would reassure you about a hospital's robotic program before you refer someone there? So for the referring physicians, as I told you, we have a multidisciplinary team approach, a good ICU backup. So any kind of patient, whatever might be the general condition of the patient, can be managed at Fortis Hospital. What's one thing you're taking away from tonight's discussion? Probably we can boast for the fact that robotic surgery is the future. Robotic pancreatic surgeries definitely have an upper hand as when compared to laparoscopic or open procedures. Thank you. Thanks.
Thank you, Dr. Shashi Kiran, sir, for beautifully moderating that session. Thank you, all panelists. We move on to the second case under the minimal access surgery segment. I'd like to call upon Dr. Saurabh Mishra, Director, Minimal Access GI, Bariatric and Robotic Surgery, to moderate this session. The panelists are Dr. Murli Chakravarti, sir, anesthetist, surgical intensive care, Director and of Clinical Affairs, Dr. Richa Mishra, Consultant, Department of Minimal Access, GI and Bariatric Surgery, Ms. Shalini Arvind, Chief Dietitian, Fortis Banarghatta Road, Dr. Shalini Joshi, Cluster Head, Bloom Metabolic Clinic under Fortis. The topic would be robotic OAGB for metabolic syndrome.
Good evening, everyone, and welcome, panelists. So, bariatric surgery is never an individual endeavor. Although the instruments do the job, but as we see the journey of our patients, we find that there are a lot of crossroads at which we would stand and we would not know what to do next. In a real life scenario, so we're going to put you into a real life scenario and stop at these junctures and ask these esteemed panelists what they would do in these conditions. So we have Dr. Murli Chakravarti, who is the Director and Lead Department of Anesthesiology. Dr. Shalini Joshi, she is the Senior Consultant in the Internal Medicine, and she is a bariatric physician. She's been trained in Cleveland Clinic. Dr. Richa Mishra, she is the Consultant, Department of Minimal Access Surgery, and Shalini, who is the Chief Dietitian at a hospital. So we jump straight to the case. Now this is a pleasant gentleman who is basically a psychiatrist from Kenya, and I'm presenting it with his permission. So he came to us. He was 52 kg. He was 52 BMI, and he had diabetes, hypertension, obstructive sleep apnea, hyperlipidemia, you name, and he has it. Is non-smoker and non-alcohol, family, siblings, and of normal weight. So basically, we all know that the treatment of obesity falls into three categories. One is lifestyle, diet and exercise, drugs, and surgery. The first question goes to Dr. Shalini Joshi. If this patient comes to your clinic, what would you advise immediately?
Hello, can you hear me? So you mentioned the gentleman over there, 52
BMI.
52 BMI. So this gentleman is 50-year-old, is class 3 obesity with a 52 BMI, diabetic, dyslipidemia, high blood pressure. So in this case, we are not simply going for the weight loss. No, we have to work towards a therapy which will increase his quality of life, his longevity, will cause remission of his diabetes, high blood pressure. So for that, I would like to do a comprehensive evaluation first ruling out any secondary cause of obesity. And then definitely see what is the eating pattern, behavior, because sometimes if the baseline behavior patterns, depression, anxiety, they are not addressed, people gain the weight back even after metabolic surgery. In this particular case, definitely lifestyle intervention would not be sufficient. He would definitely benefit from surgery, especially the OA gastric bypass. Because he would have a fantastic remission of diabetes, and which is not even weight dependent. It just.
So wouldn't you try the latest GLP drugs?
There is a role of GLP. That's what I was yesterday mentioning. It is not like lifestyle intervention versus metabolic surgery versus GLP. I think it's a continuum, and I think we should look at it in this way. Definitely fundamental lifestyle management. Nutrition, intervention definitely needed. Yes, there's a role of GLP-1 if you want to optimize the patient, get his blood sugar under control pre-op. Ideally would be 7%, but if it's really necessary, 8% we can manage. So definitely optimize the patient diabetes, which will give better operative results. Managing obstructive sleep apnea. Some observational studies.
Definitely.
So yes, there is a role of GLP-1 before surgery as well.
So definitely, it is the drugs and the lifestyle not going to be sufficient for
it
him.
It will not be sufficient in this particular gentleman.
So Dr. Shalini, Dr. Shalini, would you, if the patient walks into your clinic and he asks for a dietary advice that I would want to be on diet and try to control this, would it be sufficient? What you would advise, and what time would you send the patient to a bariatric physician or surgeon?
Okay, thank you for the question, sir. So a patient like this with such a morbid obesity when walks in, so we take a lot of time to understand what's his 24-hour dietary recall, food frequency, to understand what kind of pattern he has been having. So the diet which will be given to a patient like this definitely will be low carbohydrate, low fat, high fiber, high protein, something which keeps him satiated for a long time, something which takes care of his blood sugar levels, sodium levels, his hyperlipidemia has to come down, and it has to suit his lifestyle because he's a psychiatrist, probably must be spending a lot of time at the desk. So options which is given to him has to be something which is flexible. And we have to, surgery like this, being restrictive and malabsorptive in nature, we have to build up the nutrition status of a patient so that he can retain this status post-surgery also. And the diet which will be given, the time period in which we put the patient, because you asked me how much time we'll take for sending such a patient to you, minimum of 1 month for the regular diet, 1,200 calorie and the appropriate protein diet. So much time we need. This gives the confidence to the patient, to the surgeon and the dietitian that this patient is going to be compliant or not. Because many times out of josh, out of enthusiasm they come, but when it comes to the actual reality, it shows up, are they going to be compliant or not? Because many times we have been able to find out those red flags which we could tell to the surgeon if you should go ahead or not. So at least 1 month for the diet and 15 days for pre-surgical liquid diet, because it helps in reducing the size of the liver, gives access to the doctor as well.
Thank you. So now let me tell you that this patient had undergone all these stages already in his country, and he came specifically for the surgery. Now, Dr. Richa, the next question to you.
Yes,
what is your thought process when you decide the surgery? What sort of surgery and why robotic surgery would be beneficial for this patient?
This patient was given all options available. The different approaches that the different types of bariatric surgeries which are available are broadly restrictive, malabsorptive, and some are combination of both. In this particular patient, restrictive procedure wouldn't help given his BMI, which is beyond 50. So a combination or a malabsorptive procedure was offered to him, a Roux-en-Y and one anastomosis gastric bypass. He himself, being a doctor, a psychiatrist, a well-read person, so, and from Kenya, given that his follow-ups wouldn't have been that good, he opted for a one anastomosis gastric bypass surgery. Its long-term effects on weight loss being significant, good amount of weight loss it gives about, and the nutrient deficiencies, he was aware of it, the nutrition supplementation which would be required on a long term, which he would adhere to. And he wanted good control over his diabetes and his lipid profile, and he was a fairly disciplined person to go ahead with the surgery he had chosen.
So only restrictive procedure like a sleeve gastrectomy would not work in this patient, definitely. So what you would like is a combination of restricted as well as malabsorptive procedure. So something like a gastric bypass or one anastomosis gastric bypass which was given to him. The data suggests that, you know, if he had done a robotic sleeve gastrectomy on him, he would have initially lost weight and his some benefit, but eventually he would have gained back. He was a volume eater. So in these volume eaters, if you do a very restrictive surgery like a Roux-en-Y, they would really feel miserable. So we had given him one anastomosis bypass where he could eat a little, lose weight, and take care of himself. It was difficult to follow up, so in his country, there were people doing surgeries. So it's something that the point is that we have to tailor make all these surgeries. One shoe doesn't fit everyone. So next questions. So this is the so preoperative, Dr. Murli. So this patient comes to you in a preoperative, scenario, and you would look at him and you would say, okay, fine, I would really, this is the red flag that I want, and how you want him optimized before we take him for surgery.
Yeah. Obese patients are high risk right away, and we do not relegate these handling of these patients to novices. Getting an IV line is a problem. Measuring appropriate blood, non-invasive blood pressure is a problem. Getting into bigger veins like jugular veins are deeper, and they have sleep apnea syndrome. We have to have a pre-operative on-room blood gas so that we have a comparison to make post-operatively. If possible, get a sleep test done, and if the patient has got repeated apneas, he should prescribe a CPAP mask pre-operatively and ask him to get the same CPAP mask to the operation theatre post-operative room where we can put him on CPAP. And yes, intubation is difficult, and the patient positioning is difficult because if he lies down in his usual way, the airway will be far, far anterior. So we have to pack up his shoulders in such a way that the ear comes in line with the shoulder. That is the thumb rule, where we lift that and then do intubation. And during intubation, have an oxygen flow going, because they are very readily they desaturate, and the problem is that. And the second one is that there are some specific steps where we help the surgeons in passing the tube to guide your sleeve resection if required. And also, after a gastrectomy, the tube, the Riles tube which you place should be appropriately fixed. Some joker should not pull it out and then we will be in deep trouble. Those things are there. Post-operatively, we have very little incentive to extubate them. We ventilate them whenever it is not possible. Thromboprophylaxis should be done all the time. Pain relief should be excellent, but you don't want them to be sedated. Nowadays, you guys do laparoscopy, so there is very little pain.
Exactly my point, sir. So coming to that, if you are an anesthetist and you have done tons of the laparoscopic as well as robotic repairs, so in your experience, does a robotic surgery has an advantage?
Definitely, I feel it has got advantage, and the patients post-operatively are very, very comfortable. I think this emanates from the fact that the movement of the cannulas is very little in robotic, whereas it is too much in the laparoscopic. Second, the tissue damage, although maybe lesser than open, is more than robotic. So the patients are comfortable. We also have to take care of we have to be watchful about the diabetic status, because they say the diabetes goes even before the patient goes out of the ICU.
Yes.
So if you give the regular dose, they may become hypoglycemic. So we give nerve blocks, we give pain reliefs which are not sedative, and make sure that they are ambulated. Nowadays we ambulate these patients on the same day in the ICU. So these are some of the factors.
Dr. Richa, do you think that robotic surgery makes a difference as a surgeon in your surgery as well as the post-operative outcome of the patient?
Definitely, robotic has an upper edge during the procedure and post-operatively as well. Intra-op, what happens with these obese patients is they have a real thick abdominal wall, which causes a lot of this technical difficulties handling a laparoscopic instrument because of the abdominal wall torque itself. And this entire thing is gone when you're using a robotic endo-wrist instrument. So the wrist movement in robotics is inside the abdomen. So abdominal wall torque is bypassed. That is a major advantage surgeon faces during the surgery. Other traditional advantages of robotic surgeries are, of course, the 3D vision that we get, the stereoscopic vision we get, and compared to the 2D picture in laparoscopic surgery. So the depth perception at the console for the surgeon is much, much better in a robotic surgery. Hence the precision and the sutures that we take. So there have been evidences, there have been clinical trials where the evidence of leaks are much lesser in robotic surgeries compared to lap, despite the same technique. And the sure form staplers which are used in robotics give real good staple line benefit, very good hemostasis. We have seen having its AI inbuilt in it. So these are few advantages. Post-operatively, yes, the pain scores are much lesser because the action at the abdominal wall, the movement at the abdominal wall at the port sites are hardly any in the robotic, the fixed instruments. So the pain scores are much lesser. They are up and about early, which is what we want for a robotic, a bariatric patient. So yes, thromboprophylaxis along with patient early ambulation plays a role.
So I take this opportunity to reiterate that, there are a couple of more benefits here. One is obviously the Firefly mode, which tells us exactly how much is the perfusion at your staple site and the anastomosis. The second advantage is that in these obese patients, there's an abdominal torque, which is huge. So a lot of us bariatric surgeons who used to do laparoscopic surgeries before would keep the abdominal pressure as high as about 20 millimeter of mercury. But with the robotic instruments, what's happened is something called as leprolift. So we can go down the pressures, and we can easily do these surgeries at 14 also, giving a fair amount of advantage to the anesthetist who are fighting the P pressures and the other post-operative problems that would arise. The other thing that we request every time the anesthetist to give us to keep the patient a little underhydrated, because post-operative overhydration would cause a lot of problem in the breathing. So these are the few things that we would request from a surgeon's perspective. So this is surgery, but I know we have a positive time, so I think we just skip this part of it. And nutritional and rehabilitation is a very important part of this patient after the surgery is done. And we would probably ask Dr. Muli first, what is the immediate post-operative red flags that you would see in this patient? How would immediate, I mean, just in a couple of hours?
Immediate, like you said, there can be collapse consolidation of the bases because of the pneumoperitoneum that are lifted, and invariably the abdominal pressure is upwards of 15 because the visibility is not very good, so that enhances the pneumonia or consolidation in the postoperative period. If they are basically the benchmark PO2, PCO2s are low, PCO2s are high, you can't spin a magic by asking them to have a PO2 of 100 and PCO2 of 30. So we sometimes will have to ventilate them and extubate them without a magic figure of oxygen and carbon dioxide, because that is their usual. If you correct their oxygen too much, they will start hypoventilating because they are used to hypoxic drive. That is one. And also these patients are known to have positional injuries. We have to look for them diligently in the postoperative period. And like they have more tendency to bleed, they also have tendency to thrombose. So postoperatively, we'll have to keep on watching for pulmonary embolism. And we, in our unit, do transthoracic echo and look at the RV function. So if the RV is deteriorating, then the pulmonary artery pressure is increasing. These are some of my concerns.
Yeah, Dr. Shalini, the patient is operated and then you are supposed to see the patient post-operative period, and what are you going to see, and what are the red flags which you would tell the nurse there, the doctors there to look for?
For this patient particularly, the surgery is the beginning for us as an obesity medicine physician. So we will be rearranging everything. Basically, I mean, because of the excellent results from the surgery OAB, which Stampede trial shows, it is the drop in the sugar is weight independent. It happens within first few days and weeks. So if the patient is on insulin and sulfonylurea, it has to be completely stopped. Definitely rearranging is high blood pressure medications. Sometimes we have to adjust the CPAP machine, OSA. Definitely going to reevaluate the nutritional deficiencies. How is he taking the protein? So he preserves the mean lean muscle mass. And definitely follow him up closely and long term so that he does not have a relapse or regain.
Thank you. So, so now we come to the dietary part of it. This is a very important part of it. When the surgery is done and the patient is there, we are all following up, and then the patient starts to have liquid diet the next morning, and so on and so forth. How would you decide what to give him, and what advice would you give him long term and short term? Just quickly, because we are...
Yeah, yes, sir. So quickly, first the clear liquid diet starts as per the tolerance of the patients, then it's advanced to the liquid diet, 15 days on that, then semi-solid for 15 days, then soft for 15 days, then normal. So throughout the time, we have a follow-up with the patients, because we have seen that when there's a follow-up, they are best compliant. Otherwise, they may end up having either early dumping problem or late dumping. So this is what usually they'll be seeing. Many times they sip a lot at a time. So that also can cause issues. And hunger is an issue. Earlier, pre-surgical status, hunger was an issue. Now, post-surgery, satiety is an issue. They feel satiated very fast because granule is low and the stomach size is low. So they prefer not skip the supplements. That's the one which they have to depend on for the whole life for the protein requirement. We end up seeing them having a protein status loss, hair loss, and feeling fatigue. So constant reiteration is needed that they have to be compliant with the diet advices which is given.
Right. Yeah. Thank you. So, we in this scenario of ours, the patient is in a 1-year follow-up. He has lost about 60 kgs. He is still under observation. He writes very often to us. We follow him up. The two times that I have met him is at 3 months and 9 months, and he just wrote to me that he is so he's pretty happy there. Following this, the nutritional supplements have to go on for at least 3 to 5 years. The diet, the protein requirements is going to be less in this patient because they are largely non-vegetarians. So I think with this we conclude our session. Thanks a lot. Thanks, thanks panelists. I think we'll have to conclude this because thank you. Thanks a lot.
Thank you, Dr. Mishra, sir, and the panelists. Next, we move on to this third case under the MAS session. I'd like to call upon Dr. Manish Joshi, Director, Surgical Gastroenterology, Bariatric and Robotic Surgeon from Fortis Hospitals, to moderate the session on clinical dilemmas in GERD. I'd like to invite the panelists, Dr. Shalini Joshi, Cluster Head, Blue Metabolic Clinic, Fortis Hospitals, Dr. Sunil Kastugi, Consultant Gastroenterology, Dr. Mehta, Senior Consultant Internal Medicine, Dr. Chitra, Senior Consultant Internal Medicine, Dr. Sudhir BS, Senior Consultant Internal Medicine from Fortis Hospital. I'd like to call upon Dr. Sheila Chakravarti ma'am, Director, Internal Medicine, Fortis Hospital, BG Road. Dr. Sheila Chakravarti ma'am.
Sheila ma'am, please. We need one more chair here. Can we get one more chair for Sheila ma'am? Thank you all for being here. How many of you in the audience, after this sumptuous lunch, are feeling a bit of acid reflux? No? Not many hands are going up. Are you feeling sleepy? Okay, there are a lot of hands going up now for acid reflux, and today we have an eminent panelist here, and we're going to be discussing about an important topic that we all face, GERD, chronic GERD, and especially the clinical dilemmas that we are facing in managing patients with GERD. How many of you actually manage patients with GERD on a regular basis? Fantastic. Panelists, if you can hold one mic each. We have one mic short, but that's okay, we'll pass it on. But please hold it and make sure it is working. This is going to be a rapid fire question. Dr. Chitra, as a family physician, as having multiple clinics, roughly out of 100 patients that you see in a regular OPD, how many would be of gastritis or gas or GERD out of 100?
In the territory of family physician clinic, where we deal with ambulatory patients, 20 to 25% of patients do suffer from some symptoms of GI disturbances. However, what is surprising is 70 to 75% of patients who come to us with different chief medical complaints, when we take a detailed history and do a scrutiny, even they land up with some, not one, but cluster of symptoms of GI. So that could be as simple as gas burns, burping, bloating, and change in stool consistency, and gas reflex.
Sure. Dr. Mehta, out of 100 OPD patients, how many gastritis, GERD patients?
So I work as a preventive medicine specialist in the preventive health check department, and I will say 50 to 70% of the patients who come for a preventive health checkup definitely complain of
50 to 70. Okay.
Yes.
Now we'll move straight away to the medical gastroenterology colleague, Dr. Sunil. You are a specialist. In your 100 cases, how many are gastritis related?
Probably, I think around 30 to 40% we see as GERD or the spectrum.
30 to 40%. Okay, so that's the spectrum that we see. And I need to show me here. So I need to see it here. Okay, I'm just, if you look at the audience here, just wanted you to look at these three patients. You can see it on the TV here, ma'am. Out of these three patients, which one in the audience, and for the audience, which one do you think is a patient who actually we have done a anti-reflux procedure or a fundoplication or a robotic fundoplication? So first one is a 17-year-old, second is a middle-aged person, and third is a senior elderly person. Just first one, how many think that first one? Okay, second one, and how many think the third one? Thank you for participating. It's unbelievable for me also that we have done fundoplication in all the three patients, right from the 17 years old to the 92 years old, and we will come to the reasons why. But I want you to remember this picture because you will remember the clinical scenario better with these faces and why they underwent anti-reflux procedure, and we'll go along with the panelists to find out the reasons why these patients end up. And if you can see the ratio, a lot of physicians and one surgeon. And a GERD patient also has a typical journey, seeing all kinds of medical treatment, endoscopic treatment, and then possibly coming to a select few surgical patients. Do you agree on that, the panelists?
True.
Fantastic. So, quickly, Dr. Sudhir, I would like you to take up this question. Can you
tell us before getting the robotic reflex surgery?
Can you switch off the audio possibly? Audio off? Yeah. Dr. Sudhir, we are now looking at GERD as the common topic, the chronic cases, but in a clinical dilemma, which are the 2 pointers that you think you will worry about cardiac disease more than GERD? I mean, patient has come with symptoms saying, I have gastritis, probably give me some medications. But what are the 1 or 2 pointers in your clinical practice where it's a red flag or you get alarmed and you say, oh, it could be cardiac disease, cardiac issue, I need to rule out a cardiac event?
True. The patient profile, no doubt, and the acuteness with which he presents to you, that becomes an important aspect. Imagine if the first question is, have you had these issues in the past? If he says, never I have had an issue, last 24 hours or 48 hours I've been having some discomfort, something like that, that's when you will look at as a red flag sign. Clinical examination, you won't believe many of times we have picked up, and a good clinical examination in a short time, 5 minutes, 10 minutes, and the acuteness of the event would always classify a cardiac versus a GERD. The longer the history, you would obviously look at GERD.
Sure.
The shorter the history, you have to have a differentials.
Thank you. Sunil, do you want to add anything to that? What 1 or 2 things where you feel, no, this is not gastritis, it could be something else?
Generally, the cardiac patients will have the pressure sensation or that sort of chest pain. people with GRD, they don't have per se severe chest pain, we can say, or the radiating to back or radiating to arms. They will have just acid reflux or the pain or discomfort going to the throat or the upper chest part. And the symptoms will not be so severe or the so severe pain, and they will not have sweating and other things.
Fantastic. Dr. Shalini, do you want to add anything?
Sorry to just add.
Yeah, please.
Nowadays, in the last at least 5 years, we've been doing ECG for every other person. You won't believe it. Bedside. That's unfortunate. You can think about it, but 70%, 80% is nothing. But we are doing an ECG before he goes out.
So is it a good practice to have a ECG, clear out a cardiac issue, and
Always.
then confidently
We are doing it on a regular basis.
and medically GRD?
Definitely.
So
Fantastic.
basically it depends upon who is the patient sitting in front of you. It's a 26-year-old, male or a female who has been partying and he has no risk factors, no smoking, nothing. He's a classic burping and, laying down, symptoms increase, all the classic symptoms. Yeah, of course I'm not going to do an ECG. But if it is a 40-year-old above male, he's a smoker, or anybody in fact above 40, there is the symptom, according to the AHA guidelines and the GERD guidelines, one symptom, chest pain, you cannot rule it in and out. It's not specific or sensitive. So we have to do, unless proven otherwise, if the pain is new, severe, unexplained, you have to do the ECG biomarkers and then go on for a GI.
Yeah, thank you so much for that. Sheila ma'am, you get a patient, you diagnose that the patient is having gastritis and GRD. What lifestyle modifications or how do you manage the initial management for such a patient, a first comer?
The first comer, I think the most important thing is lifestyle modification is weight loss. Reduce the stress that you are going through these days. And I think first thing you should ask them to stop looking at a chat GPT and giving you the differential diagnosis. Because most of the patients are not interested in your advice, but they want to tell you what the diagnosis is. So once a person, I think you have to first get the patient to look at risk factors, smoking, alcohol, weight loss, stress, night sleep, and what is their quality of life. I think first you address all that, and then maybe look at medications and other options that the patient has. I would beg to differ. I would agree with Sudhir. Patients definitely, if the quality of the chest pain, new onset chest pain, patient has been having regular symptoms, suddenly has found a little different odd symptom, it is worth looking at a cardiac backup, because we've seen quite a lot misses if you are not really careful and assuming that it is GERD. No
Sure.
age is now free from having a heart disease.
Fantastic. One rapid fire question to all the panelists. One lifestyle modification in your practice you definitely recommend to all patients and you think it works. One lifestyle modification. Dr. Sudhir, if you can start from that end.
It's a tough thing. Everything in one.
One that you feel is suitable for all patients.
Keep a proper routine workup. That's it. In the sense, what time you get up, there has to be a routine in your day-to-day life. I think that's what will help.
So regularity, okay.
Even I'm going through the same
Sunil?
phase.
Diet modification.
Diet modification.
Main thing, the people say the citrus fruits are the common triggers, and
So
most
avoid
of the
citrus fruits.
and chocolates.
Okay.
Chocolates can cause lower esophageal sphincter relaxation.
Chocolates
We
go
see-
out of your diet now.
And
See a lot
so
of
many
young-
cafes outside. So I think first thing you should stop. That's what
See, a
we
lot of young females, 20, 30s, they eat a lot of chocolates and they present with GRD.
Fair enough.
So
Dr.
guys don't
Shalini,
eat chocolate.
chocolates off the table.
Guys don't eat chocolate, that's what it is.
Fair
So 1 in 4 in India is either overweight or obese. So weight loss.
Weight loss.
Definitely. And
Okay.
if they have nocturnal symptoms, and otherwise also gap of 2 to 3 hours before sleep.
Yeah, okay,
Diet.
one. We'll take
Only
weight
one.
loss. Dr. Mehta.
Smokers.
Smokers
stop
to stop
smoking.
smoking.
Alcohol definitely.
Stop
reduce
smoking,
your-
stop alcohol.
Yes.
So you're not going to be invited for today's fellowship, and all of you have to be very careful.
The others
Dr.
have
Chitra.
already answered. Yeah, not to mess up with the circadian rhythm, to maintain sleep and wake up time. So doing the day shift, night
The
shift. not to alternate.
IT capital is Bangalore, and she makes a very pertinent point not to mess up with the circadian rhythm, and especially with the US night shifts. We see a lot of patients coming with GERD, and there is no way where medications can help them, especially when their circadian rhythms are out of connect. Sheila ma'am, one lifestyle modification?
I think stop abusing PPIs. I think indiscriminate use of PPIs, I think, have really allowed us to stop understanding the disease itself.
Okay, so over-the-counter drugs, and it becomes very difficult. So one of the things which I feel particularly helps me with GRD patients, lifestyle modification, is to kind of keep the stomach 80% full, not overeat, not full stomach, keep the stomach 80% full. We'll move on quickly. Again, starting with Dr. Sudhir from that side, when do you ask a patient for endoscopy, a patient who comes as a first comer, and if they are a recurrent comers to you? When do you ask for endoscopy?
Generally keep 1 week to 10 days of his response. If the person does not respond in a week or 10 days, I'm sure you're going to look at the scopies, which was not the case 10 years back. So now 10 days, and then definitely 1 week to 10 days is what I would look at maximum.
Okay. Dr. Sunil, quickly, what are a few things that you find on endoscopy which make it valuable for a patient to undergo endoscopy actually?
I think we should look for the grading of the esophagitis, Los Angeles classification A, B, C, or D. And we should clearly mention the Z line and the diaphragmatic pinch so that we can say how much the length of the hiatus hernia. And on retroflexion, we should just assess the Hill's grading. Is it type 1, 2, 3, 4? We should rule out H. pylori infection.
Okay, I'm just going to put up on the, for the audience, this is a hiatus hernia. And the endoscopy picture is going to come up. Dr. Sunil, if you can just grade the hiatus hernia now.
I think it's of 4 types, type 1, 2, 3, 4. Type 1 is an intact trap. There is no gap between the endoscope and the G junction. Type 2 is partial disruption. Type 3 is moderate, and type 4 is complete disruption.
Thank you. So we're just going to look at any newer molecules that you have used which makes the treatment much easier. Dr. Sunil.
Okay. I think newer is the PCAP, the potassium channel acid blockers. They have got the slightly better in grade C and D esophagitis. And for people who are not PPI responsive, there is some benefit with the PCAPs, newer drugs.
Okay. Dr. Sudhir, at what stage do you feel that this patient is a candidate for anti-reflux surgery? And Dr. Shalini,
most of these, we would look at a check endoscopy at the end of 3 months to 6 months. And then if there is hardly any benefit, then we go in for that. You know, if a patient already has something like an early Barrett's, obviously we know that it's not going to be for surgery. But before getting into a phase of Barrett's, that's where we look at it. And many a times biopsy helps us, because sometimes there is a suspicion, take a biopsy, no Barrett's, tell him that, he's going to the next phase and surgery will be advised at that time.
Sure.
3 months.
Dr. Shalini, when would you refer a patient for a surgical consult for anti-reflux procedure?
I just wanted to add one line. Because in Indian context, people are already coming very late to you because they have already done their gharelu nuske, home, pudin, hara, everything for 2, 3, 4, 5 years. And literally when they cannot take it anymore, then they come. So my threshold of referring to a GI or surgeon is low, because I know the need, and it's not, they would have already done an 8-week PPI trial themselves, and they would be taking domperidone for a long time. So yes, I would refer a patient if I see any red flags, which has been already odynophagia, dysphagia, anemia, weight loss.
Fair enough. We have the indications for anti-reflux procedure. Mainly, if you look at the 3 people that we operated and the picture we put up first, the 17-year-old was on a follow-up for almost 4 years of medications, not able to study for his 12th exam. It was a very difficult decision for all of us to sit together, including his parents. And the patient himself said, I am anyway failing 12th exam. Otherwise, let me go ahead with this surgery. Because he has done all the research, and he was saying that nobody offered me surgery. And I said, you are too young to undergo surgery. But still, with his all inputs and counseling, we did. And he had a grade 3 hiatus hernia, for which he underwent an anti-reflux procedure and is doing well. He's got into MBBS seat as well, post-12th. The elderly gentleman was one where I would like to highlight this point. He says, in the last 10 years, I have not eaten anything food-wise. I've already been on diet. I'm eating little. I can't taste anything. And I want this procedure to be done. And he is aware, his family is in US. He has been offered GRD there. He wanted to get it done in India. So most important thing is also patient preference. I'm just going to quickly move ahead for the want of time. So there is also an endoscopic procedure, STETA procedure, which also is an anti-reflex procedure. If you look at the image there, the first one is the radiofrequency ablation probe. The second image shows the heat waves being given at 6 different levels, half centimeter apart at the lower esophageal sphincter. And the third image is what happens at the end of 6 to 8 weeks, where the muscle thickens and fibrosis occurs, causing an anti-reflex barrier. However, Dr. Sunil, do you want to take this? Endoscopic procedures, what are available for as an anti-reflex?
Yeah, endoscopy has not picked very well in this sector, I would say. Either it's the STRATA or GERDEX device or the anti-reflex mucosal ablation. There are 3 methods. This is an anti-reflex mucosal ablation. We just around 270 degree of the G-junction hiatus, we just ablate it.
So we have links, we have GERDEX, we have ARMA, we have TIF, we have STRATA.
So, yes, multiple TIF.
Any of these which you feel
not so successful, I feel so.
Okay, fair enough. Right now, not most of them are available in India also, and they are still in probably experimental stages, if I can say it like that, especially in India. And this is an anti-reflex procedure that we are doing, robotic fundoplication. And already it has been told that the suturing is much easy. The visualization is 10x magnification. Lot of benefits, a stable platform to do the procedure, and the patient definitely is recovers faster. Post-op day 1, they are sitting and walking or they are moving around. And this is the fundoplication which is completed. You can see the 4 stitches and the hiatus and the wrap that is being made from a surgical perspective. So I think I'll let this video in the interest of time. I would like to ask one last comment from all the panelists. What is one thing you would recommend the audience here for GERD? One thing I would like to recommend definitely is, in all the options that you're giving a patient with GERD, mention surgery as also an option, because some people come to us saying that if I had been told about surgery 5 years back, 7 years back, 10 years back, I would have considered that option. One last comment from each panelist about GERD.
I think give everybody a chance to go through all the options available and see, optimize correctly, give the right duration of treatment, and if the patients do not find any improvement in their, and it's affecting their life, give them that surgical option also, because that is the final option that the patient has and has the right to get that.
Dr. Chitra?
Yeah, I would recommend lifestyle modification because that is long term and is also curative, but giving an option will tell them not to use over-the-counter drugs, because NSAIDs over-the-counter is also one of the main causes, so I would advise them not to do so.
One message for everybody is definitely surgery will be the option. I'll start referring more patients to surgery, sir, after this, definitely. One lifestyle modification, like I said before, weight management, healthy weight. And like I tell my obesity patients with obesity, delete the delivery app. I can't say the names. So all the delivery apps delete if you want weight loss. So for the GERD patient, please don't have the urge to order one gulab jamun at the middle of the night. Gulab jamun is my favorite.
So I'm a medical gastroenterologist. I should say, like, we should have a low threshold for endoscopy. Probably in 4 weeks, patient not responding to medicines, I think probably one should consider an upper GI endoscopy.
Dr. Sudeep?
Drug dependency is what is the deciding factor. If somebody says that without a drug in the next 1 week or 10 days, I'm going to end up with GERD symptoms, definitely endoscopy followed up by surgery. Somebody who's drug dependent is a good indicator of surgery.
Thank you. This is one RCT that has been published and which has made us surgeons more aggressive in surgical management and offering surgical management, published in NEGM a few years ago, where for refractory heartburn, Yes, we know that surgery, anti-reflux procedure works for hiatus hernia. It works for as a preventive case for Barrett's esophagus, but for refractive heartburn also, you can see that 67% of patients get relieved with anti-reflux procedure surgery. And one last thing that I would like to say is this is all possible because of the team that makes it work. And this is the team behind all the things that we have been doing. Can we have a round of applause for all the panelists and the team at Fortis for making this happen? Thank you so much, all the panelists, for being there.
Thank you, Dr. Manish, for facilitating the session so well, and thank you all the panelists. Really appreciate your guidance in the discussion. We next move on to the innovative capsule session. I'd like to call upon Dr. Santosh Kumar Subudhi, Senior Consultant, Department of Urology, Uro-Oncology, Andrology, and Renal Transplant, Fortis Hospitals, to talk about innovative and individualized management of advanced cancer prostate.
Good evening, ladies and gentlemen. So this is a break for you all between the robotic, where you use something different here. So in cancer prostate, we have seen that if you remove the prostate, the solution is done. Means there is no head, no headache. But if still the prostate is there and then the metastasis has happened, then what? So with the cancer prostate metastasized or not, in the past, physicians and surgeons will be knowing that if you remove the testicles, then that is the solution for the cancer prostate. Means that was surgical castration. Now we are moving from surgical castration towards medical castration, where you use medications to treat the metastatic CA prostate. Welcome to SURGX 2026. The alternative or the medications which is used is called the androgen deprivation therapy. For a cancer prostate to grow, it needs testosterone, and the testosterone is produced in the body by the testicles. In surgical castration, when you remove the testicles, the goal is done. But if you don't remove the testes and you want to suppress the testosterone in the body, then the medical castration is required, and this is called as androgen deprivation therapy. We use either the LHRS agonist or the GnRH antagonist, which are the foundation. ADT alone leaves residual androgen receptor signaling. So you need for this also an alternative management, where newer medications like enzalutamide have been used. So the first thing is the LHRH analogs, which when you give into the body, that will increase the testosterone. So, but because of the negative feedback, then the it has to reduce this testosterone in the body. So this is one of the medications which is used. It has been seen that it is having efficacy within 4 weeks. And after 48 weeks, you see a significant PSA reduction. Because it can be given in 3 monthly doses or 6 monthly doses, patients are compliant. And because of this, the quality of life is also good. And when it has been seen that by 24 weeks, there is 95% reduction in the PSA, and they get castrate levels of 90% by 4 weeks of less than 0.2 nanogram per ml. So, and why it is helpful, this is the industry partner for us from the Bharat Serums, where they have a technology where you can use this for longer durations like 3 to 6 months intervals. The other thing is the antagonist for the testosterone to be produced. These are it's the relugolix. It's a gonadotropin releasing hormone receptor antagonist, where it is used in metastatic CA prostate. You give in a loading dose of 350 milligram, and after that daily you have to take 1 dose. Here, taking an injection is also not required, and it can be taken with or without food. If you miss the dose, within 12 hours you take it. If you don't miss, if you have missed the dose, within 12 hours you take it. If it is after 12 hours, you have to take, not to take that dose. So this is the, it will try to bind with the receptor in the pituitary of the GnRH, and it will avoid the release of LH and FSH where the testosterone cannot be released. So in a phase 3 trial of the HERO trial, where it compared the relugolix with leuprolide in advanced or metastatic CA prostate, it was seen that the relugolix got castration level by the day 4 in 56% of the patients, but there was none in leuprolide. And the sustained castration, it was maintained throughout the 48 weeks, and it was seen in 96.7% in relugolix in comparison to 88% in leuprolide. So, and also it has a 54% lower risk of major adverse cardiac events in comparison to leuprolide, where you cannot give it in with patients with cardiac risk. So this is the industry partner for us. The other thing which I told you is the androgen receptor signaling inhibition, where enzalutamide, it has been seen that in multiple trials that when you add this enzalutamide with the other medications like leuprolide or degarelix or organonist or relugolix, it helps in better survival rates. So to compare, this I have already told. To conclude, standard doublet like the androgen deprivation therapy plus enzalutamide for newly diagnosed metastatic hormone-sensitive prostate cancer is the gold standard now. Favor a GnRS antagonist in patients with significant cardiovascular risk. You don't use leuprolide in that, which is an agonist. Favor relugolix specifically when an oral pill-based regimen is preferred or injection access or toleration is a concern. Reserve leuprolide plus FAIR in comparison when an antagonist access, cost or reimbursement is the limiting factor. Adding enzalutamide meaning survival benefit across regimens. The AR receptor choice matters as much as the ADT backbone. Thank you.
Thank you, Dr. Subudhi. The next speaker I'd like to call upon is Dr. Shakir Tapres to speak on the topic high flow insufflation and robotic surgery. Dr. Shakir is the Director of Urology, Uro-Oncology, Urogynecology, Renal Transplant and Robotic Surgeries in Fortis Hospital. Welcome, sir.
Thank you, Dr. Punya. So they say that carbon dioxide is the only drug which is continuously administered throughout the surgery without prescription. Robotic surgery gets all the applause, but unless there is a pneumoperitoneum happening, it is like operating in a collapsed tent. We need that pneumoperitoneum to prop it up and actually give us visualization. Earlier, when we used to go to all these conferences abroad, when we used to see the videos, the clarity and how perfect they looked, we used to be upset, why are our videos not the same? And then we realized the quality of the insufflation, the continuous insufflation, and the smoke evacuation. So a robotic or a laparoscopic surgery is only as good as the pneumo we create, the spaces we operate in, and the clarity. Essentially, convention is that insufflation is continuous. It does not drop or go up depending upon the pressure. That's a big challenge. When there is smoke, our vision goes, and then by the time, especially if there's a bleed, all of us have suffered when there is smoke or there is a collapse in pneumo when we apply the suction. Now, these are problems practically, but we can't and we did not have an answer to it. This, especially when COVID happened, and then we got to know about these systems which continuously, almost 20 readings every minute is done, and accordingly the pressure, the gradient is altered. This is the only sensor-enabled port system that provides real-time sensing technology. So when we say sensing, I'll move on to that. So this is a 50 liter per minute CO2 insufflator with real-time measurement of the intracavitary pressure. So what happens is, it's not just about the gas and the flow that happens, it's also about it being heated. So the gas which is delivered into the system, what happens is, if there is a lower temperature CO2 which is insufflated in a warm intra-abdominal area, it causes fogging. And fogging is a big pain. Take it out, put it into warm water, put it back. So the warm, or rather the heated carbon dioxide, when it is delivered, it eliminates fogging, it reduces hypothermia, and hypothermia also reduces post-operative pain, the one factor we claim in robotic surgery which helps patient walk and get discharged as early as they do. So this is how smoke is eliminated. At any point in time, it's not that a surgeon has to do it. Whenever there is diathermy, there is desiccation of tissue, there is coagulation, and there is a small smoke screen which rises. So here, that is taken care of, and at the same time, when we do a desufflation, that is when we take the CO2 outside when finishing the procedure, there is no problem with it because the desufflation is done only, this vacuum seal takes care of it so that it happens gradually and there is no sudden drop in pressure. So essentially, this is the difference between the conventional and the real-time. Real-time as evidenced in the continuous CO2 flow insufflation that we use these days. So 20 readings per second, that changes. And then there's a continuous dynamic CO2 delivery. We don't have to alter the pressure according to the time that we are operating in, and it eliminates any pressure spikes. So these are the differences that you see: lesser lens fogging, better heating and humidity. Proximity is also very important. The closer proximity to the patient, the better the clinical benefits. So this you can see is to your left is how it looks when fogged. And imagine there is a bleeder in a very sensitive area. Sometimes you have to stop the surgery, bring his pressures up, and that is a big, big problem, a surgeon's nightmare. When it is heated and humidified, you are able to see it clearly and you can proceed with the procedure. So why does it happen, especially in our surgery, where robot is indicated is a robotic radical prostatectomy? So essentially, DVC ligation, there is a deep corridor that you're operating in. You're in the pelvis, which is such a small space, and then it is not an arterial bleed, it's a venous bleed. So there is a constant bleed, and at that point, we have to elevate or decrease the pressure. Here, with this system, high flow insufflation, there is significant pressure which is exerted in that step, which tamponades this venous bleed, and with good vision, we are able to take sutures without having to be frantic or in a rush and making one step go 2 steps backwards. What were the challenges faced in robotics and laparoscopy? One was loss of pneumo, whenever there was suction, whenever you used to exchange instruments. Second, the smoke which came up and blurred your vision. And the third, the gas which was delivered was cold, dry, causing hypothermia, increased cell desiccation, and the procedure time obviously was increased. That changes with high flow. Visibility is great. There is much, much less smoke or none at all. And finally, the hypothermia is also reduced. These are various papers which are the same, and these are the takeaways that you see. So stable pneumoperitoneum during DVC ligation, which for us urologists, we need a clear, unobscured view of the apex. Continuous smoke evacuation, sustained pressures, which also importantly from the head end, it reduces the cardiopulmonary stress and hence early post-operative discomfort. Finally, better vision, steadier physiology, much more efficient console window. Thank you for the patient listening.
Thank you for that crisp talk, sir. Next, I would like to call upon Dr. Shreyas Nagaraj, Senior Consultant, Urology, Uro-Oncology, Gynec Oncology, Renal Transplant and Robotic Surgery for Fortis Hospital, to talk on the topic ICG in robotic surgeries.
Good evening to one and all. The topic is ICG in robotic surgery. I'll stick on to the role of ICG in urology. So ICG is basically a torch in a dark room, which helps us to guide what the structures which we want to see. So what are the challenges in robotic surgery is mainly the difficulty in identifying any vascular anatomy, differentiating a tumor tissue from a normal tissue, identifying the ischemic segments, assessing the tissue perfusion, lymphatic mapping, and preserving the vital structure. So basically ICG makes invisible anatomy visible. So how this basically works is it basically binds to the normal tissues, and we have a technology called Firefly technology, which we use it in the Da Vinci system, which will be lit up during the fluorescence, and the normal tissue ideally take up this ICG, whereas the abnormal tissue doesn't. So this is how usually we can give it IV, and in case of identifying ureter, through the ureteral access sheath, it can be introduced. So once it is given, it combines with the tissue, and using this fluorescence technology, we can actually, the tissue gets lit up, and we can actually make out what is normal and what is abnormal. So preparation, the dosage has to be adjusted based on the body weight. So this is the standard dosing watch what we use. So the role of ICG in robotic urology has been for many, especially we use it for partial nephrectomy, in robotic radical prostatectomy, adrenal surgery, urinary reconstruction, especially for identifying the ureter, in transplantation to know the vascularity of the anastomosis and the kidney, penile and testicular cancers. So mainly the role has been for robotic partial nephrectomy. As I said, once it is injected IV, we have to see which is the tumor and which is the normal tissue. Along with ICG, we have a drop-down ultrasound probe which will identify the normal tissue from the tumor tissue. So adequate mapping is needed, and only the tumor tissue can be removed so that nephron sparing can be achieved better. So this is how it looks. So this is a standard white light, and that is how the kidney lights up and the abnormal tissue, so that the mapping, marking and the mapping can be done appropriately, and only the tumor tissue can be cut. So mainly for partial nephrectomy, as I said, the objective is also for identifying the renal branches. Selectively, we can clamp the artery which supplies the tumor so that the rest of the kidney is perfused well, and we remove only that part of the kidney which is affected. As I said, so this is how the kidney looks. It will turn into green once we use it. The tumor remain dark. So only the tumor-bearing segment becomes ischemic. Advantage, definitely it will reduce the warm ischemia, better renal perfusion, and less unnecessary ischemia to the other tissues. So in case of pyeloplasty, mainly for identifying the crossing vessel, the PUJ anatomy, perfusion assessment, anatomical vascularity. Ureteric reconstruction, when we are doing a BMG ureteroplasty, basically to identify in a ureter in a fibrous tissue where we can't identify where the ureter is running. So once we inject this ICG, so the ureter gets lit up, we will know where exactly the ureter is running, and we can isolate the ureter. So these are the various ureteric reconstruction techniques where the ICG can be used to identify the ureter, and appropriate anastomosis can be performed. So this is how the ureter tends to lit up when we do the procedure using an ICG. So in case of radical cystectomy, again same for identifying the ureter, to identify the bowel perfusion, because we need a segment of the bowel where the ureter will be anastomosed. So we have to use the segment of bowel which is well perfused, and also identifying the arterial arcade, so that we use an exactly what amount of the bowel which has to be harvested. So this is how we assess the bowel viability, identify the arcade, and we take that segment of an ileum or the appropriate bowel segment for anastomosing the ureter, so that the rest of the tissue can be spared. Radical prostatectomy, the neurovascular bundle preservation in case of lymph node mapping, assessment of bladder neck perfusion is one more very important thing where the ICG can be used. Again, as I said, sentinel lymph node mapping, periprostatic injection, fluorescent lymphatic, selective nodal removal, and other advantages are there, so that the lymphocele and other complications when we do a lymph node dissection is avoided. In case of donor nephrectomy, identifying the accessory artery when you feel there is a difficulty. In case of venous anatomy, perfusion confirmation after an anastomosis is done, how well the kidney is perfused, whether the kidney is perfused well, and whether the anastomosis has been done very well. The recipient implantation assessment also can be done through it. As I said, transplant immediate graft perfusion can also be noted with the ICG. If there is an ischemic segment, again, that will not take up the ICG, it will appear dark. Arterial thrombosis and venous compromise also gives us a fair idea as to how it looks. Adrenal surgery, it is mainly useful. Similarly, the principle works same. The normal tissue picks up ICG, whereas the tumor tissue doesn't. Similarly, in case of adrenal cortical tumor, differentiating adrenal normal tissue from abnormal tissue and preserving the adrenal vein. Thank you.
Thank you, sir. Next, I would like to call upon Dr. Mohammad Shakil, Consultant Infectious Disease, to give us a talk on novel therapeutic agents in the management of infections.
Good evening, everyone. They say that in conferences we learn medicine, and when we are back at hospital, that same medicine put us at test. So as the day will fall and we will all go back to our routine work, one thing which I really don't expect to face anyone is one call from the ICU. So suppose that this is a call that you get from your ICU saying that you have got a patient presenting with fever, hypotension, and when the examination was done, the graft side shows graft tenderness. Now we all appreciate what we are dealing here right now. And the lab very much reflects that this patient probably has landed into a graft pyelonephritis very early into the post-op period. So the empirical antibiotic is started, and the moment you get back to your work, you get again call from your microbiology lab. And we know when microbiology calls, it's not always pleasant. So the labs call and tell you that the blood culture which was sent last night has flagged a gram negative into the bottle. Very quickly, you ask for a rapid ID panel to be done, and that rapid ID panel is telling you that the isolate is E. coli and not a routine garden variety E. coli. Here we are dealing with a NDM variety of E. coli. This is the right point where you call up your infectious disease consultant, who will go back and check that this NDM E. coli is not something, a mutant variant. So we have now a E. coli NDM which are mutated to PBP3, CMY, beta-lactamase hyperproduction, all those things are there. So while your ID colleague is checking out of that, we now need to target his empirical antibiotic. So I have put up a list of options which I see people commonly using for such kind of isolates. And what do you think should be the correct option here, or should be the go way forward? While the audience take a couple of time thinking about the right option, let me walk you through what is the current epidemiology of these kind of resistant mechanisms. So when we call or talk about the NDM E. coli, so NDM is a gene which belongs to the metallo-beta-lactamase variety of Ambler classification. And that same Ambler classification tells us about all the various kind of genes. So if we look up the global predominance of these genes, mainly the NDM, VIM, and IM, India and most of the Southeast Asian regions comes with a high burden of NDM kind of metallo-beta-lactamases. Whereas if we look up the US, we look up the European settings, it's different. So the implication of understanding this is that we cannot just simply put our literature coming from the Western country to our clinical practice. We need to understand our own epidemiology and perspective. And this map will keep on changing as we talk about different mechanisms, different organisms. So coming back to our problem, so right now we are facing an individual who has got NDM variety of E. coli, and taking about all the options one by one. Tigecycline, yes, it do have NDM activity, but this is not the right individual where tigecycline should be used. Colistin, polymyxin, both of them works against NDM variety of E. coli, but taking into consideration the recent graft, the AKI happening, that probably again is not a great option. Plasmomycin occasionally works against NDM, so you need to check up the isolate before putting up for plasmomycin. Coming up to fosfomycin, so fosfomycin is a difficult molecule, comes with various layers of nuances, and therefore should always be preserved for the last resort of therapy as a salvage therapy. Now talking about the newer beta-lactamase inhibitors combinations like ceftazidime avibactam, ceftolozane tazobactam, imipenem relebactam, and meropenem beborbactam. All of this BLI does not help against NDM isolates. So that leaves us with only two practical molecules. The one, cefiderocol, which is utterly expensive, very difficult to procure in India. So practically for most of the time, we will be using a combination of ceftazidime avibactam with estrionam. So how does this actually works? So it is actually the estrionam which is the killer, which goes and is stable against the MBL enzymes, and that's the one which is wandering. The avibactam just provide a shield to the estrionam so that the estrionam is able to work. So this gives us a rationale that is actually the estrionam and avibactam which are actually playing the role. The clear-cut role of ceftazidime in this combination is not well defined. And that's why now we have come up with a single molecule which has both these entities of estrionam and avibactam. The benefit of this single agent is that you don't need to check it separately in the lab. You don't need to perform the synergy testing into the lab. Very easy, very convenient, two different IV lines, and it can be easily given. And overall has been seen that it performs better compared to cefiderocol or ceftazidime avibactam plus estrionam combinations. So it practically works against most of our problematic bugs. Where it do not work is important. It do not work against carbapenem-resistant acinetobacters. It do not have anaerobic activity. So if you are using it for anaerobic indications, must be added with metronidazole. So this is the agent. It is given as a loading dose of 2.67 grams, and then it has to be infused every 6 hourly. It's 4 times a day dosing with the infusion rate of 3 hours. And whenever you have a CKD where the creat clearance is less than 50, it requires renal dose adjustment. Also for ESRD, for CRRT, for SLED, there are separate dose adjustments which are required. Thank you so much.
Thank you, sir. Next, I would like to call upon Dr. Shubha Charita, consultant anesthesiologist, to give us a talk on ERAS protocol to precision.
Good afternoon, everybody. Thank you for having me here. So today, I will talk about ERAS 2.0, that's Enhanced Recovery After Surgery. I've organized this talk around mainly 4 verbs, that is predict, personalize, optimize, recover. These are not just slogans. This represents a genuine shift in the mindset of anesthesiologist from one size fits all to make it more precise to the patient specific. We all know about the surgical stress response. If untreated, this won't stay contained. This will directly relate to the post-operative outcomes, including more complications, increased length of stay, and increased healthcare costs. These are the core components of ERAS. All components are important, but I feel 2 things are most important than any. One is patient's willingness to recover. So what we do is we counsel them before even they come up to the operating table. And second thing is continuous audit and quality improvements. So that's what makes us better each day. This is how typically robotic urology patients will be on table. A steep Trendelenburg of 25 to 35 degree. And you can see various changes. The robotic urology has very unique physiological footprint which demands a strategic anesthesia management. I would call we are the silent architect of ERAS. every decision we make intraoperatively directly translate into postoperative outcomes. Surgical skills matters as much. A better technique will lead to better outcomes. What is the most important take-home message here is every intraoperative decision influences the postoperative recovery. So it's a multidisciplinary action. All this doesn't make sense if I don't provide proper data and evidence. So ERAS improves postoperative outcomes. This is a meta-analysis done in 2024 by Nelson et al., which shows 29% fewer complications, a shorter length of stay by almost 1.88 days, no increase in 30-day readmissions, reduced postoperative opioid requirement. This is our own home data. This is still a preliminary clinical outcome. The outcome may change as the cohort expands. We have ERAS adherence of up to 94.9%, independent ambulation by patients by POD3, that is post-op day 3. 92% are started on oral liquids by 24 hours after the surgery. 84% of them pass their first flatus before 24 hours. 79.2% are on soft diet by post-op day 2. And mean post-operative length of stay, specifically in robotic radical prostatectomy, is 4 days. Considering we have a geriatric cases, and most of them come with plethora of comorbidities, this is the best outcome is what I feel. In spite of such outcomes and such data, we still face challenges implementing ERAS. It's basically difficult because we start preoperatively, we continue intraoperatively, and continue postoperatively. So these are the challenges we face. One is the knowledge and awareness barriers, resource and infrastructure barriers, leadership and cultural barriers, teamwork communication barriers, protocol barriers, and monitoring and sustainability barriers. We have worked on how to overcome these barriers one by one. First is education and training, institutional support by leadership commitment and resource allocation, multidisciplinary collaboration by shared protocols, standardization by evidence-based pathway, audit and feedback, continuous improvement by quality improvement cycles. This is the road ahead from protocol to precision, where we integrate ERAS with AI. Preoperatively, we need identify risk early with AI analytics, stratify patients for individualized pathways, optimize before they reach even OR. Like we check the frailty index, those patients who are very frail, we involve dietitians, improve their frailty index before even they are taken up for the major case. By personalizing intraoperative management, we tailor anesthesia and surgical care, the real-time decision support where the AI integration helps the clinician to make a good prediction and better outcomes. There is goal-directed physiological guided care intraoperatively. Post-operative, we continue whatever we started intraoperative management, the data-driven feedback and learning systems, and the patient is monitored with the help of AI even after they get discharged home. So we get better outcomes with lower cost and happier patients. ERAS is more than just a protocol. It's a culture of precision, collaboration, and patient-centered recovery. These are the QR code for references and evidence. Thank you.
Thank you, ma'am. With that, we come to an end of the innovative capsules. We move on to the surgical oncology case discussion. To moderate this session, I would like to call upon Dr. Sharad Chandra Pingali, Additional Director, Surgical Oncology, Robotic and Lab Surgical Oncology. The panelists, Dr. Sushin Dutt, Additional Director, Department of ENT, Cochlear Implants and Skull Surgery, Dr. Rahul S. Kanaka, Additional Director, Surgical Oncology, Dr. Abhishek S., Consultant, Department of ENT, Dr. Suneet Kaur, Director, Laboratory Services and Technical Lead, Agilis Diagnostics.
Thank you, Dr. Punya, for the introduction. So welcome panelists. Myself, Dr. Sarachandra, Surgical Oncologist at Fortis, Bannerghatta Road. Welcome Dr. Rahul Kanaka, Additional Director, Surgical Oncology, Dr. Sushin, Additional Director, ENT, Dr. Abhishek, Consultant, ENT and Head and Neck Oncosurgery, and Dr. Suneet Ma'am, Head of Lab Operations. So quickly we will go to the presentation. This is about robotic thyroidectomy, which is being practiced nowadays in certain high volume centers in order to give patient a scarless surgery that is scarless in the neck, a thyroidectomy which is scarless in the neck. So I would go to the slide. First slide, please. Is it on? Yeah. So what is the context? Why are we talking about this? Thyroid surgery has been done for decades in open surgery. First thyroid surgery was done in 1600s, and now we know that if we take an incision in the neck crease, we know that hardly it produces any scar in the neck. But of late, we have seen some patients who have, in patients who don't have a prominent crease in the neck, the post-surgical scar, if it's a hypertrophied scar, can look really ugly. And nowadays, because some centers are offering this, patients themselves are requesting for this if they can avoid a scar in the neck, which is why we are discussing about this robotic or minimal access thyroidectomy. So the basic question is it entirely a fashionable thing, or is it a medical necessity, or is it somewhere in between? Is it just an option? So as we go through the slides, by the end of the discussion, probably we will know in a better way what exactly it is. So this is the context, what we are discussing. You can see a lady with a central neck scar, especially young women, they have a lot of psychological issues nowadays with the presence of a scar, especially they don't have a prominent crease in the neck. If you have a prominent crease, you can take an incision and it merges in the crease later on. But if they don't, then it might cause a hypertrophic scar, and most of the times when they come for the follow-up, they will be wearing a scarf-like thing. They adapt the way they are dressed themselves. So sometimes, because some surgeons are doing, the people who don't do, they also started feeling bad that, if I had known this technique, if I expedite this technique, then we could have offered patients these procedures. So this is the context. Minimal access or remote access thyroid gland removal. So where is the access? It could be, I will tell you different techniques, which will be part of the panel discussion. So now we start the panel discussion. This is a case, 43-year-old lady who came with a swelling in the neck. Ultrasound shows it was a 2 centimeter thyroid 5 nodule, which was suspicious papillary carcinoma on FNAC, and she had no suspicious nodes. The slides are not playing there for the panelists to see actually. Yeah. So it was a 2 centimeter suspicious papillary carcinoma. So we planned surgery. You can see is the usual position of the patient which we do for the thyroidectomy, and in this case we did a modified Baba approach or a rabbit approach. We have 4 ports, 2 near the axilla, 2 near the breast. And then, can you play this video? So the robotic surgery, unlike in abdomen or in thorax, where you already have a natural cavity, you are, you insufflate the gas, and then, as Dr. Shakir said, it lifts, and then you can operate. Here, there is no natural cavity. You have to create the cavity. So where do you create the cavity? You create it in the pre-sternal region and in the lower part of the neck. So you make it become like an abdomen, and then you maneuver the instruments. So you can see we have done the initial space creation, and then we do the robotic docking. Can you play this video? Yeah. So this is the initial laparoscopic phase, we call it, where we use the lap instruments to create the space pre-sternally. You can see we are lifting the breast tissue over the pectoralis fascia and the pre-sternal region. Once you raise these things, then you make space for insertion of the robotic ports. Once the robotic ports, the 4 ports are inserted, then you do the docking, and then when you do the docking, you also do what is called burping. Means you should just lift it up like that, because this is not a natural cavity like abdomen. So this is not a natural cavity like thorax. It's an artificially created cavity, and then the ports are inserted. And once the the laparoscopic phase is converted to the robotic phase, we raise the neck flap. We identify the 2 sternomastoids, which are V-shaped, and the strap muscles in between. So we are trying to just create a cavity-like thing in the pre-strap muscle region. You can see here, if you see any anterojugulars, you will be addressing that. So these are the 2 sternomastoids you are seeing, and in between we are creating the space. We have lifted the strap muscles, we are entering in between, and then we are going between the strap muscles. Both the sternohyoids, the deeper will be the sternothyroids. And once we do that, you can see the thyroid lobe. In this case, since the FNAC was suspicious of papillary carcinoma, we have done a right hemithyroidectomy and centrifugal frozen section, which has confirmed the actual papillary carcinoma. We went ahead and did the total thyroidectomy. So I will just, because of shortage of time, I will just quickly show only the right-sided steps. Can you actually play the video? Yeah. So this is what the inferior pole is being addressed. You identify the parathyroid, you address the vessels, the isthmus is divided. I think he has gone beyond the division of the video has gone beyond the division of the superior pedicle, that's fine. So this is the superior pedicle being addressed. So the steps are the same like open thyroidectomy, only thing you will be doing by remote access by creating a space. So we will go to the next slide. Yeah, we will start a quick 5-minute panel discussion. Go next slide. So, Dr. Sushin, I would like to put a question to you. Can you go back slide? Yeah, sir, how do you put forward the context for robotic thyroidectomy? All of us do open thyroidectomy. We have done a lot of cases and nothing happened to the patient, and mostly there are no major concerns. Now, how does this come into the context of discussion?
So one of the most important talking points in terms of counseling to a patient is a cosmetic surgery. So typically the young population, especially women, in fact, one of the early patients that came to us asking for robotic thyroid surgery was an air hostess.
Okay.
So, the patient, the prospective patient being an air hostess, there was a need for us to consider the cosmesis of the surgery. So I would say definitely the scar and not giving a cosmetic, bad outcome to the patient is one of the primary things when we consider the robotic thyroid surgery.
So when I worked in Andhra earlier, a lot of them were Arogyasri scheme patients. They would not be bothered about the scar. They are happy if you do the surgery free of cost. But now we are treating more air hostesses and VIPs and celebrities. Now the cosmetic part is also, that's what you are trying to tell. So that's a good point, sir. So Dr. Rahul, Rahul is our additional director, surgical oncology. So does it have, putting apart the cosmetic aspect of it, if you look at the outcomes, the recovery part, the complications part, how does the robotic surgery compare with the standard open surgery?
So as per the available data with respect to the oncological clearance, there is no difference between the robotic thyroidectomy and the open surgery. In fact, there is no inferiority complex. Though we cannot say it is superior to the open surgery, but as per the available data, it's not inferior to the open surgery.
So it is equal, both are equal. Yeah. It is not harmful, it is safe. So talking about in general, because we are cancer surgeons, we are traditionally taught that the surgical clearance scores over the function preservation of the organ, which scores over the cosmesis. But in suitable early stage cancers, we need to give importance to the factor 2 and factor 3 also. So whenever possible, we try to meet all the 3 endpoints, which is why this surgery might be having a role in future. So Dr. Abhishek, what are the different ways by which you can do remote access thyroidectomy? Does remote access thyroidectomy always mean robotic?
No, it can be endoscopic also, where they used to do transoral, or it could be transaxillary. So because And other robotic approaches are transaxillary, post-oral, and also Baba technique, where you can do a rabbit
So
technique.
what he is trying to tell is we can do with the laparoscopic instruments also. So it's just you are accessing from a remote area in the axilla or from the mouth or from the, near the areola. So earlier this was done with laparoscopic instruments. So what were the problems, Dr. Sushin, with remote access, like using laparoscopic instruments?
So one of the approaches that we use is the transoral transvestibular approach, wherein we go from the floor of the mouth. So unless the lesion is a small one and is in the midline, we have a limitation in terms of how much we can
the
access.
structural suitability of the disease to the approach, that is what is important. Not only that, the actual constraints of the neck spaces, neck is not like abdomen. So the constraints of the neck spaces and also the laparoscopic instruments being straight instruments, it is difficult to maneuver these instruments, in order to get a satisfactory surgical outcome. So Dr. Rahul, does robotic technology help overcome this problem of space constraints and decreased maneuverability of the straight instruments?
See, when compared to laparoscopy, where we have a 4-dimension, only 4D movement, where you can either move the instrument straight, front, back, or upside down. Whereas in robotic, the 3D image, which is a magnified image, helps us to identify structures very clearly. And second thing is we have a 7-degree freedom of movement, where you work almost like when you are operating with your hand. So this overtakes the laparoscopic, which was endoscopic approach, and robotic helps us to overcome all the limitations that come with an endoscopic
So
procedure.
whatever limitations are there with respect to doing a remote access thyroidectomy using the lap instruments, all those have been overcome, most of them by the endo-wrist manipulability of the robotic instruments and 10x magnification that you get with the robotic procedures. So this is what it is. We have overcome those problems with minimal access by the advantages offered by the robotic technology. Now looking at the comparison with the open surgery, Dr. Abhishek, so these are the various headings under which we compare robotic thyroidectomy with open thyroidectomy. So safety and feasibility and cosmetic, you can just enumerate, you can see the headings.
So cosmetic outcome, like how Dr. Sushin and Dr. Rahul Kanaka was saying, it is obviously better because we have access from the away area and the scar is away from the neck, which is not visible for anybody. And when you compare the operative time is definitely more because the learning curve is still there for the robotic surgery.
But once you learn, the operative time is almost the same.
Almost the same. And complications are the same in both open and in robotic surgery. In fact, in robotic surgeries, because the structures are visible very clearly, the complications are very less. Lymph node yield also is same compared to robotic and in the open surgery.
Yeah, we know this is little costlier than the thing, but yes, if the benefits do offset the concerns, then definitely this is going to be a big option for patients who are really desirous of avoiding a scar in the central part of the neck. So, are there any studies? There is a large meta-analysis which has compared more than 6,600 thyroidectomies. It has, including 11 studies. So that's whatever Dr. Abhishek has mentioned just now is just the conclusion of this meta-analysis. So what are Dr. Rahul, what are the different approaches and what are the pluses and minuses of what are the different approaches of doing a robotic thyroidectomy?
So earlier, robotic surgery for thyroid was started as a gasless procedure, where basically a retroauricular approach or a transaxillary approach was used. But we needed a big chunks retractor, which would lift the entire flap, and then we can do the surgery without gas. But then with the availability of Baba technique, which we are moving on now, we can use the gas, and even single port robotic surgeries are being proposed now. But Baba technique seems to be the best of all the approaches as of now.
Yeah, so fantastic. So these are the points by which we can compare the different approaches. We are not going into depth because of the shortage of time. But for high BMI patients, trans-oral approach is supposed to be a good approach. And then there are specific complications like brachial plexopathy for transaxillary approach, which we have overcome with the Baba technique. And nowadays, most of the places where the surgery is done, the Baba technique or modified Baba technique, the rabbit or the rabbit are the methods to do the robotic thyroidectomy. So the patient selection, Dr. Sushin, do you have something to say about whom to suggest this particular thing, especially if they want to wish avoiding a central neck scar?
Definitely. So early on, I would choose smaller lesions, smaller nodules, one-sided, and when the patient has no.
So it is basically the simple cases: small lobe, small nodule, not much thyroiditis. Because in Indian patients, thyroiditis will cause a lot of pericapsular adhesions and all, which would make the dissection difficult. And of course, the surgeon experience and the hospitals doing large volume cases, these are the ideal setting for doing the robotic thyroidectomy. Dr. Abhishek, are there any contraindications for the robotic thyroidectomy?
If there is a substernal extension and if the patient has any previous radiotherapy, or if the patient had undergone a previous neck surgery where the scarring will be more, or if the nodule or the cancer itself has an extrathyroid spread, then it's better to avoid in this patient.
Okay. Madam, Dr. Suneet ma'am, she is the head of our lab operations and South Agilis. Madam, is there any role of frozen section? We keep pestering you every time we post a thyroid case. So how good is frozen section in differentiating benign and malignant tumors?
Actually, if you have seen the recent
Because patient wants surgery tomorrow, we cannot be doing all the tests that you advise.
Yeah.
So that is the common scenario.
So if an option is available, I think FNSE is always the best choice to do pre-operatively and plan it properly a day before or a week before. But definitely on-table frozen, if it is done just for a confirmation of tumor, yeah, maybe for a papillary, it will help. But to differentiate between a follicular adenoma and carcinoma, no, because again, you need an extensive sampling of the capsule. Or maybe if you have incidentally find a lymph node where you want to know if there is a metastasis in the node, yeah, it can help that time. Or if there is an extrathyroidal extension, if you have a doubt on table, or some ectopic tissue if you find suddenly.
Okay, ma'am. So I will ask you one more question, which I ask you every time when I call from the OT. At least can you try telling whether it's benign or malignant? We know that it is difficult, but will you try or not?
No, I will not try for adenoma versus carcinoma.
Sometimes you will
it can
be able
be
to
misleading. Unless there is any obvious capsular infiltration, and we are very sure. I think it's not a good idea to commit that.
But sometimes I think you will be able to.
Sure.
I am concluding on your behalf, as I usually do.
As surgeons, we can never deny. That's always sure.
Thank you, ma'am. So, Dr. Rahul, are there any special counseling points which you have to do in this method, when you are doing this method, in addition to what you generally talk about open surgery?
So as you are aware, this is a remote access thyroidectomy. We are not entering from the actual area where you should enter, which is the neck. So due to raising the flap, which we are starting from the axillary region, there will be a lot of numbness because of the nerves which we damaged during the raising of the flap. So numbness and paresthesia over the chest will be expected. So these things we should explain to the patient before taking up for surgery.
Yes, we have to explain this because people who ask for scarless thyroidectomy are very particular about even small consequences post-surgery. We have to be very careful in these patients. So regarding the frozen section, I have already discussed with Dr. Suneet. Dr. Abhishek, what are the steps? Quickly.
So first is the
three phases,
space,
1, 2, 3.
creation, and then is the docking, and then is the console stage where.
Yeah. So the pre-sternal space creation, number 1, number 2 docking, and number 3 the console stage. Do we always use CO2 insufflation?
Yes,
no, because earlier in transaxillary method, it was done as a gasless technique, as Dr. Rahul said. So all of the techniques, nowadays the BABA technique, we used a CO2 insufflation. So these are the phases of the surgery. Dr. Sushin, in open surgery, sometimes we use nerve monitor to preserve the nerve. Can we use that even in robotic?
Yeah, it can be used.
But do you feel it's routine, or what is your practice?
Even in open surgery, it's not used as a routine. But yes, because in robotic thyroidectomy, since the field is a 10x.
So basically, it's the same as open surgery. It's not different. Okay, yeah. Thank you. So, Dr. Rahul, can you use Firefly technique, ICG technique, and what are the applications in doing a thyroidectomy?
So basically, to differentiate the thyroid from the parathyroid tissue, where sometimes ectopic thyroid tissue will be there, to differentiate that part, it is very important. We can use the ICG as it lights up on the Firefly technology, so we can use it.
So ICG is a dye given intravenously, and within few minutes, because the parathyroid glands are highly vascular, they light up before the surrounding tissues light up, and even the nearby lymph nodes or fat lights up. These are the first things to light up. So sometimes it helps really in identifying and preserving the parathyroid glands. So everyone is talking about AI. Does it offer any special advantages? I have recently, can you play this from somewhere around 3 minutes in the middle of the video? Staff sitting there. Can you go to the, can you play it for somewhere around 1/3? Can you play it? Yeah. So you can see this actually. So this is a video published in an international journal recently. So they are showing how, you can see that some indication it is giving. That white is indication it is giving. We are doing a lobectomy, thyroid lobectomy, and it is showing the possible location of the nerve by the blinking thing, the white thing you can see there. So this actually is published last month in one of the international journals. So the surgeon finds it very easy to guess the location of the nerve, especially in difficult surgeries and large tumors. This is a simple case, it looks, but this can be really helpful if it comes up in future. So definitely AI is likely to offer much more top-up advantages to the already existent technology. So hopefully, but it should not eliminate the role of the surgeons totally. So in spite of a lot of doubts and criticisms, whenever patients are desirous of avoiding a central neck scar, when they don't have a prominent crease in the neck, definitely robotic thyroidectomy, initially in the first time, we thought whether it's a fashion or a necessity, but it is actually a good option. But yes, one needs to learn good numbers, and then we have to have strict patient selection, and in a high volume center with surgeon expertise with individual decisions, we can do a good job with respect to these procedures. I thank you, Fortis, for giving this opportunity, and all the panelists for actively engaging in this beautiful session. Thank you very much. If there are any doubts, sir, yes, sir. Sir wants a mic. So this is an option. It is not, we cannot force it on anyone. It is an option.
Thank you very much. This is Dr. Sunil Joshi. I am a HOD of surgery in Chikballapura Medical College, so Government Medical College. So I know that this is advanced technology that you're talking about, and so we all find it very easy to do an open procedure, and thinking of doing a minimal invasive and taking a port from there and here, and I'm being honest. So it's all difficult. So anyways. It is for those people who are affordable, those people who want it, those people who think that. Is there any definitive benefit in patients who undergo a total thyroidectomy? Because I've had people in whom I've done a total thyroidectomy and had problem with the recurrent laryngeal nerve.
Sir, because of the echo, I am not able to.
Recurrent laryngeal nerve injuries.
Sorry, sir?
Recurrent laryngeal nerve injuries is what I'm looking at.
Recurrent laryngeal nerve injuries.
Yes. That is the most important thing in a thyroid surgery, especially when you do a total thyroidectomy.
Yes, sir.
So, do we have any advantage in robotic surgery, Rahul?
So basically, because we have a 10-time magnification, the recurrent laryngeal is seen better. And we are able to dissect over the recurrent laryngeal nerve with a bipolar, which is a very fine bipolar. The chances of injury are less. We are actually dissecting the RLN over which we are going and then removing the thyroid gland.
Sir, and Maryland bipolar that comes, the bipolar energy RB source, which is usually part of the system, robotic system, which we are supposed to do only short bursts of the bipolar activity. We cannot do like in open surgery. As you said, yes, definitely one has to be very careful. You can't tell I have driven for 10 years, nothing will happen to me when I drive. Still you have to be careful.
Thank you.
Basically, the indication here is to avoid scar in the neck. We are not telling that we are trying to promote this as the first line of treatment.
Yes.
It is an option. It's
do
not
we have any additional benefit
in
in terms of injuries to a recurrent laryngeal nerve by robotic? That's what I want to know.
Sir, 100% we can injure recurrent laryngeal nerve whether in robotic or laparoscopic or open surgery. We have to be, whatever be the approach, yes, we have to be 100% careful. Especially when we are doing these kind of techniques, because in open surgery, if there's neuropraxia, people will accept. But with this, they will tell it is, they might tell it is because of this, so we have to be extra careful with this.
Yeah, I just have a patient from yesterday whom I'm dealing with right now. So recurrent laryngeal nerve is the issue.
Sir, in any form of surgery, some magnification is recommended. Even when we do a tonsillectomy, there are ENT surgeons doing a tonsillectomy with a microscope. And we have a lot of surgeons that use loops routinely for parotid surgery. So if the robotic approach offers you a 10x magnification, perhaps it can make up for a lot of deficiencies which we might have with the naked eyes. So as a general rule, magnification is good for any surgery. So it is the same for recurrent laryngeal nerve in thyroid.
Thank you.
Sir, sir wanted mic.
Regarding the parathyroid injury also I am talking about, which scores over whether this robotic surgery scores over
Sorry sir, can you put the mic closer?
Yeah, now it is okay. So regarding this parathyroid injury while operating,
yes,
the surgical procedure, normally what is being followed till now, is it the one better or the robotic surgery is better because of
Sir, definitely the magnification of a robo is, I mean, sir, as you are asking with a lot of skepticism, even surgeons, we are very reluctant to change our techniques and approaches. So when we actually do it, we find it very advantageous because you can actually see the branches of the inferior thyroid artery supplying the parathyroid. They come from lateral to medial. Both the parathyroids on either side derive the blood supply from inferior thyroid artery. So we can actually, see very flimsy fibers and you can do a fine dissection, but yes, definitely it is easier in a robotic surgery. But as of now, the evidence says that the complication rate is same with robotic and open. But we are able to see that when we do robotic, definitely the magnification is convincingly, it is very clear, sir.
Whether it is parathyroid or the recurrent laryngeal nerve, I think hemithyroidectomy is much safer than the total thyroidectomy. And when it comes to total thyroidectomy, I think probably the robotic has an edge over the open procedure.
But having said all these things, the man behind the machine is important, sir, whether it is open or laparoscopy or robotic. It doesn't just mean that the machine is good, the man is good. So we have to be very careful, sir.
Thank you.
Thank you very much, sir. Thank you, panelists, for the participation.
Thank you, Dr. Sharath, and all the panelists for that precise walkthrough into the topic. We have our last case discussion on pediatric urology. The topic is about pyeloplasty, and I would like to invite Dr. Basavaraj Neelagar, Additional Director, Urology, Uro-Oncology, Urogynecology, Renal Transplant and Robotic Surgeries at Fortis Hospitals. Dr. Prem Kumar, Additional Director, Urology, Uro-Oncology, Urogynec and Renal Transplant and Robotic Surgery. Dr. Suraj Jayadeva Reddy, Consultant, Urology, Uro-Oncology, Urogynecology, Renal Transplant and Robotic Surgery. Dr. Yogesh Kumar Gupta, Consultant, Pediatrics. And Dr. Geeta Muniraj, Senior Consultant, Cardiac Anesthesia.
Good evening, everyone. The last case, we'll keep it as brief as possible. So the brief history, 1-year-old male child presented with the recurrent episodes of fever since birth. Afebrile at presentation. Antenatal history of left hydronephrosis detected on antenatal ultrasound at 7 months of gestation.
I'd also like to invite Dr. Chandra Teja Reddy to join the panel members.
Ultrasound showed the left kidney gross hydronephrotic with ballooning of the renal pelvis. APD of left renal pelvis 21.3 millimeter. Findings suggest of left pH obstruction. Right kidney was normal. And this is the renogram image preoperative. The first question to Dr. Yogesh. With the history of antenatal hydronephrosis, when the baby is born, how do you manage these patients? When do you follow up? How to evaluate?
See, nowadays we are getting early referrals. In the sense, when the ultrasounds are done during antenatal period itself, we are able to find out there is a PCS dilatation. So we are alerted, and then we alert the surgeons also in that way. So see, there are certain criteria which we need to follow. One thing is we need to know antenatally how much is the APD diameter. If we know the APD, like anterior posterior diameter, based on and whether it's unilateral, whether it's a bilateral, then is there any history of oligohydramnios in the mother? So these are the risk factors which alert us that things may be bad than what we expect. As the baby comes out, we need to again reevaluate the whole thing, and then we categorize them into different categories, into mild, moderate, and severe category. Severe category, definitely if the APD is more than 15, like in this case, we have to immediately go for early procedure before we kind of lose the parenchyma. And mild can wait. So in that case, we advise follow-up. Follow-up, usually when we discharge the baby, we tell them to get a renal scan, again, ultrasound done maybe on day 5 or day 6. Because if we do early ultrasounds, we might miss on the real numbers. It will be dehydrated baby, and then the numbers may look small, but actually it may be more. So 5 to 7 days ultrasound, if that is okay, and then we follow them up after 3 to 6 months. Moderate category, we usually follow it up after 1 to 3 months, and severe, as I mentioned, we need to immediately refer to urology.
Okay. Now we have got the EC renogram done for this child. Dr. Chandra Teja Reddy, what age you would recommend? Any particular age group? Age is there where we can undergo a baby can undergo a scan, and if so, what scan you would prefer?
So coming to your second question, sir, first, what type of scan? So there are 3 tracers, DTPA, EC, and MAG3 available. So kids, their DTPA is a glomerular filtration agent, but kids, the glomerulus will be immature till 2 years of age. So we prefer either MAG3 or EC. MAG3 is very costly and is not available in India. EC is an indigenous product prepared by our chemist, and we are all happy with the results of the EC renogram. So we should go for the EC renogram. And coming to what age we can start doing the scan, going by the guidelines, it will be at least 3-4 weeks. But if it's a very severe hydronephrosis, we have done at 7 days age also.
Yeah. How do you interpret an obstructed system versus a delayed drainage?
In this case, it's a straightforward case. So there is an upsloping curve, that is type 2 renogram, and delayed images are also showing significant obstruction. So there is no doubt in this, it is obstruction. And we see some cases like type 3A renogram where initially the curve will be upsloping, and after the diuretic effect, the curve will come back to normal with no residual obstruction, no residual tracer retention in the post-void images. So these 2 cases, they are straightforward. The problem comes in type 3B curves, where the curve is slightly dipping or it's plateaus after diuretic effect. So in that cases, we see the post-void images and delayed images after 1 hour. If we see significant retention, will give us obstruction. If we see the tracer excretion is complete, will give us delayed non-obstructed clearance. But these cases also has to be followed up. We can't just go by that. Yeah.
Okay, thank you. Now we have made a diagnosis of pH obstruction. The child presents to Dr. Prem, the urologist. What treatment modality you would choose, and why?
Depending on the age and particularly the weight of the baby, I would have probably a very younger child, maybe with a 3 kg or lesser weight, I'd probably choose a open pyeloplasty. I think larger than that, robotic is always preferable because laparoscopy as such is a little difficult. Intracorporeal suturing is a little difficult in laparoscopy cases. So robotic would be a better option.
So either an open pyeloplasty or a robotic pyeloplasty, that's what you would prefer?
Robotic, obviously, robotic cases.
So, Dr. Suraj, before we go to the surgery, I would like to ask Dr. Geeta, our anesthetist, what are the challenges you would face in this case, and how do you manage the intraoperative period?
Yeah, I would like to say the smaller the baby, the bigger the challenge is for the anesthesiologist. As we all know, once the baby is positioned and robo is docked, it's difficult to handle and have an access to the baby. So my preparation starts with securing a good IV line, induction, proper ET tube positioning and ensure that it's not gone into the right endobronchial intubation is the most important thing. And after the baby is induced, we secure a internal jugular vein, triple lumen, and even a radial or a femoral artery, both under ultrasound guidance. And once the baby is positioned, in this case we position the baby in a lateral position. So the most important thing is ET tube fixation and IV lines securing. And as the insufflation of the peritoneum starts, these babies are more prone to bradycardia with sudden insufflation. So we have to be alert. And I would suggest the surgeons to take it as a gradual insufflation and limit the insufflating pressure to around 6 to 8 and maximum up to 10. And IV fluid management is very crucial to prevent fluid overload. Baby temperature monitoring and regulation and keep the baby warm at all times. And in this era of fast tracking, we even give caudal block or erector spiny plane block under ultrasound, and we aim to extubate the baby under on table. So I would say we have to be on toes all the time, and careful continuous monitoring is very much required, and watch for any complications and immediately address it. Thank you.
Thank you. Dr. Suraj, can you take us through the procedure of the robotic pyeloplasty? How would you do that?
By the concept wise regarding the pyeloplasty, there is no difference between the open or the lap or the robotic approach.
Can you play the video,
it is
please?
just that I would like to highlight in the points what we need to look into in a robotic procedure. So because the area which we have is quite smaller, so we cannot have the advantage of using the fourth arm for retraction. We'll just have the two working arms, and a 5 mm port as an assistant can be used. And the procedure is very similar. You do the colon drop and then identify the ureter, trace the junction that is between the pelvis and the ureter, that is the actual PUJ. Look for the narrower side. Then look for any crossing vessels. If they are there, they have to be saved or protected. And then divide the ureter from the PUJ, excise the narrow tissue, and then re-anastomose with a stent in place.
So as you can see, the grossly dilated pelvis and the dismembered Anderson-Hines pyeloplasty is being performed. So that's the PUJ being excised. So in a 1-year-old child, the ureter will be very narrow. So the suturing laparoscopically is extremely challenging, intracorporeal suturing, whereas the robot takes away that drawback. So your instruments move like how the human wrists move. So the anastomosis is better, watertight. So then post-operative follow-up, how do you follow up these patients, Dr. Yogesh and Dr. Chandra Teja Reddy?
Post-op follow-up.
Post-op, usually, if it's robotic or open, whichever we are doing. So, of course, being a child, we need to be a little careful with because hemodynamics are a little different in a child compared to an adult. So, close monitoring at least for next 4 to 6 hours in the ICU. Usually we observe them and just keep a watch on drop in hemoglobin or any increase in drains, on how about the urine output and vitals. And usually if they are doing well, everything is okay, then we usually start oral feeding early, because it's a little difficult to contain a child and hungry. And then if they're stable, we usually send them to the ward, and then usually another 2 days they stay back and then can be discharged. We just follow one more policy, is that we give oral antibiotic for 5 days, and then usually we say to stop it unless if there is drain which is being kept or catheter which is being kept due to any other reason. So usually we tell them to continue at least prophylaxis till the catheter is out. Apart from that, there's no other restrictions in the normal diet and activities of the baby.
Okay. Dr. Chandra Teja Reddy. when do you suggest we do a repeat nuclear scan? And
So post-pyeloplasty renogram interpretation is not that straightforward. So for this, pre-pyeloplasty renogram plays a very important role. We have to compare with the pre-pyeloplasty renogram. In the previous renogram, you can see significant cortical thinning and hardly the split function is like 10-15%. Here you can see in the first 2-minute image, there is no difference between the two kidneys. That itself indicates the kidney regained function well. And in this renogram, we can see curve coming down to normal, but around 66% of the cases, curve will not return to normal. So that's where the pre-pyeloplasty renogram plays an important part. Even if there is a mild improvement in the cortical function with improvement in the drainage pattern compared to pre-pyeloplasty renogram, we should consider it as a good improvement, and we normally label it as post-pyeloplasty pattern. So without pre-pyeloplasty renogram, it's very difficult if the curve is not becoming, there is a high chances that we'll be mentioning again residual obstruction.
any question from the audience?
Hello. Thank you. This is Dr. Sunil Joshi.
I couldn't hear you
properly. Hello. Dr. Sunil Joshi. I'm a HOD of surgery in Chikbalapura Medical College. Just have a little question. Of course, I'm sure you will ask for, do you operate without any pre-operative pyelogram? Is my question. Do you ask for everyone?
Pyelogram or renogram?
Renogram, yes.
Yes, sir. We'll definitely, while interpreting the post-pyeloplasty renogram, we'll definitely ask the patient if they have a renogram done before.
Okay.
If it is not there, then we'll give a benefit of doubt.
I'm sorry, I missed some of this discussion. How long should we wait for a normal resolution of a PUJ obstruction in children?
See, we usually see it's not about normal resolution. That's what we say. Pyeloplasty is not about correcting the deformity. It's about preventing a further renal damage. So that's what we are doing by doing a pyeloplasty.
Okay.
So usually we follow them up for next 3 to 6 months. Varies from child to child, depending upon the fibroplasticity of the child, ureters and all, how the things heal. But mostly we have seen what we follow is the drainage improvement, no worsening of renal function or stabilization of renal function, a good growth of the child which is gaining weight and developmentally normal.
Yes.
And of course, finally doing the renogram, maybe once in 6 months, I guess. Yes.
The basic question is how long should I wait before I refer it to you?
There is no wait, because see, it's not a fixed number that, okay, within 3 months you will have. It can be as early as we have seen 3 months child's renogram becoming normal, 49, 51, whereas sometimes it takes six months also, but at least 1 year follow-up is important.
Fantastic. Do you really see pre-delivery PUJ obstruction in the prenatal?
Antenatally?
Yeah, antenatal probably.
Yes. Actually,
and how do you manage that? And that's the question.
Actually, we are seeing a lot of. We see now maybe because of the good sonologist as well as good machines what we have. The pickup rate has increased, and now we are getting a lot of cases, APD is this much, so they come for follow-up, counseling they come, if what happens, if this increases and all. By second trimester, only third trimester, we kind of prepare them. So recently we had one child, a baby was born, and antenatally they had diagnosed, I think APD was 25 and with severe oligohydramnios in the mother. So that child was taken up for the surgery immediately. As you mentioned, now you asked about how much time did it take. Now we know that more than 15, 20, 25% of the 25 millimeter diameter, if you're taking 35 millimeter diameter, then it's a bad prognosis because already the parenchyma has thinned out. But then still we have to give a benefit of doubt, and we went ahead with the surgery. And now that child is doing well, though his scan is pending now next month because he's just going to be 4 months, 6 months now. So, but he's passing urine well, RFT is normal, no palpable mass, ultrasound is showing decrease in hydronephrosis.
Good. So how long does it take for cortical degeneration or to have some complications, or it alters their renal functions,
worsening of the renal.
Yes.
See, again, It's initially, we won't go by the scans initially. When, let's say, if we talk about post-operative period immediately, we go by the basic things like how is this urine output. Usually post-obstruction, when we release, they have a good polyuria, more of urine they pass, and we know that things are working well.
Yes.
We had one child, long time back, where there was a stent blockage, and immediately it got alerted that, look, something is wrong, and re-exploration was done, and then things improved. But monitoring wise, I think is ultrasound only. That's also not immediately we do. We do it maybe after a month or after 2 months only, as long as other things are okay. Like the vital, the weight, the growth, and of course the urine output.
Thank you.
Thank you. Thank you, panelists.
Thank you, Dr. Basavaraj and the panelists. Moving on to our innovation capsules. The topic is thulium laser. And to talk on this, I would like to invite on stage Dr. Santosh Kumar Subuddhi, Senior Consultant, Urology, Uro-Oncology, Andrology, Kidney Transplant and Robotic Surgery. Please welcome Dr. Santosh Kumar.
Good evening all. We will know about thulium laser in urology. Not working. Now it works. So welcome to SURGX 2026. So these are the thulium laser fiber machines which we use. These are from IPG, which can be used only for stones, it can be used for prostate, or the single machine can be used for stone and prostate. So in urology, basically we use holmium or thulium, but thulium is far superior for stones and also for the prostate, so we are fixed on to thulium. So thulium acts has an emission line at 1940 nm, closely matching major water absorption peak in both the tissues and calculi, providing 4.5x lower ablation threshold of calculi and tissue that holmium YAG laser has only 2x. That's why we use thulium. Stone has a structure which has cavities in between, where the laser, when it produces the cavitation bubble, it will break the stones. So after you start lasering the stone, the cracks have been expanded and then there is fine dusting of the stone with the laser. So what are the advantages is the fragmentation is up to 2.2 times more than the holmium. The dusting is up to 2.6 more. Fine dusting is up to 3.6 times more, and the popcorning time is reduced by 0.3 to 0.4 times. And also the advantage is the retropulsion. When the stone is fired with the laser, it can move. So that is called as retropulsion, which is also very less with laser. The temperature effect, because it is a laser, it uses heat. So the temperature effect is almost the same, but the fiber usage or the burn back is less. So there are different laser settings for different types of stones in various portions of the urinary tract. If it is a kidney, then there is a different laser setting. If it is in the ureter, it is a different laser setting, and if it is in the bladder, it is in the different laser setting. But we can do on our own whatever the laser settings we want, we can reduce or increase depending upon the requirement. So preset parameters have been given by the companies. They tell that if you have a kidney stone, you use this laser setting. If you have a ureteric stone, you can use this laser setting, but you can change. So this is a ultra mini PCNL where you do the puncture. see how this is only a 8 French, means 3 millimeter incision is being done. The instrument is used, and then when you go in, you see and see the stone, powder it with the laser. See how fine dust it is. And once you do it, you need not put a suture also, because it is only 2 to 3 millimeter of the size of the incision in the skin. Next. So the other thing is where you go endoscopically into the kidney and then see the stone. You put an access sheath. Next. So you are seeing the stone and then you are powdering it with laser into fine powder. Next. Next. So this is a newer thing which is coming up. If you have a bigger stone, then if you are not able to clear it through PCNL or through RIRS, you combine both the procedures in one patient in the same setting. It is called as endoscopic combined intrarenal surgery. Then one surgeon will be operating from below for the RIRS, other surgeon will be operating from above for the PCNL. So it combines both. You see in the image, one guy is punctured from above and other guy has a flexiscope from below. So the indications are large and complex renal stones, staghorn calculi, if there is any anatomical abnormality or if there is any failed previous monotherapies. The advantages either way is that you have to clear the stone in one sitting, so you use this, and fewer access tracts. If it is a bigger stone you want to go and do with the PCNL, you reduce the tract by going from below, and you reduce the intrarenal pressure if you are doing with the RIRS. So if you do a kidney puncture and do the PCNL at the same time, the pressure in the kidney is reduced, and because you clear the stone, the operative time is reduced, and then the stay is also reduced. So this is the position for the procedure. It's called as a Galdakov modified supine Valdivia position, where this side the puncture is done and from below the other surgeon can go for the RIRS. This is the other thing where patient has stones on both the sides of the kidneys, and then one guy can operate from above, other guy can operate from below. This is called as simultaneous bilateral endoscopic surgery. So you do PCNL on one side and RIRS on the other side. So for the prostate, you do the two types. You can do whole prostate can be enucleated or you vaporize. So in this, you have started the enucleation, you are giving a cut forward. So you see it is continuously some more forward, and it is cutting whole of the lobe of the prostate. So this is called as enucleation. Once the lobe is enucleated, you do morcellate the tissue. End it. Next. Forward. See, in this is the vaporization where the tissue is vaporized. You don't do any enucleation, so there is no need of any morcellation in this. At the end of it, whole of the tissue is morcellated. Finish. So this is the last slide where you have the freeze. This is the settings which you use in the laser. So for various types of the stones or for the prostate, either you want to do a hard stone or a soft stone, whether it is a URS or a PCNL, these are the settings which the company has given. You can use this, or if you want, you can use your own settings depending upon the requirement. If you see that the hard stone is there and it is need to be more, then you increase the energy levels like that. Thank you.
Thank you, Dr. Subudhi. For our next talk, I'd like to invite Dr. Suraj Reddy, Consultant Urology. The topic is ESWT.
Good evening. Let me keep my talk as short as possible, highlighting just a few important points. So ESWT is a therapy which is identified based on the previous history of success in the breaking of the stones through ESWL, which is a very old technique for management of renal stones. In similar way, ESWT is a transcutaneous application of acoustic energy to the surface, which can lead to other medical benefits. So there are multiple ways how this acoustic energy can be delivered. It could be radial, linear, depending on the object or the targeted tissue and how deep the tissue is. If it is a surface area where you need the target to be achieved, it is more radial probes. And if it is a deeper tissue, like in the case of a prostate, so you will go for a focused ESWT or a linear ESWT. So the mechanisms which are applied over here includes predominantly the neovascularization because of the acoustic energy which is delivered to the tissue, forming newer blood vessels, stem cell regeneration and tissue remodeling, and also reduces the inflammation around the tissue by anti-inflammatory effects. So as I told you, there are multiple devices like the focused ESWT, the linear ESWT and the radial ESWT. If you can see, the focused ESWT has a greater tissue penetration of 3 to 12 centimeters, and radial ESWT is less than 3 centimeters, that is for superficial tissue. So the predominant use of ESWT, which is well proven and also the part of the EAU guidelines in the management of erectile dysfunction. In fact, it has to be told as a bridging therapy between oral PDE5 inhibitors like drugs like sildenafil and also prosthesis, where patients are always asking, sir, is there anything else apart from PDE5 inhibitors? They are not working for me and I don't want to go for a prosthesis because of social stigma. Yes, ESWT comes in place. So ESWT offers this therapy by delivering acoustic energy which causes neovascularization and also release of endothelial nitric oxide synthase, which helps in improving the blood flow around the tissue, and it is predominantly used for vasculogenic ED. So if you see on the left side, left part of the slide, so the ideal candidates are patients with mild to moderate form of erectile dysfunction, and there is a role even in psychogenic ED where it might act like a placebo at times, and also in patients with post-prostatectomy erectile dysfunction. So these are the multiple studies on which the evidence is based on use of ESWT for erectile dysfunction. And the last line shows the EAU guidelines which have been come up in 2024 showing there is grade B recommendation for use of ESWT. So this is the schedule. It's difficult to go with everything, but I would say it is roughly around 6 to 8 weeks, one session per week, and then it would be a maintenance phase of around one session every 6 to 8 weeks once. So it is also used in treatment of Peyronie's disease, predominantly in the acute phase. It is not used, it should not be thought that it is used for treating curvature caused by Peyronie's disease, but it is only in the acute phase by anti-inflammatory action. ESWT also has a role in chronic prostatitis patients. These are a group of patients who always trouble the physicians, coming back with the similar complaints, no improvement. Yes, ESWT could be an answer in these patients, and there is some evidence that there is some improvement because of the anti-inflammatory effects. And the other emerging applications are in the form of stress urinary incontinence, overactive bladder, and interstitial cystitis. Interstitial cystitis is very similar to CPPS. And in male infertility, the predominant action is through, again, neovascularization, but there is no enough data to be proved. There are very small cohort studies which have shown evidence, so it is still in preliminary form. So as of now, contraindications predominantly are any open wound around that area, active bleeding around that area, and also patients who are on blood thinners, and also patients who are on warfarin or anticoagulation. So these are the guidelines, and So I would like to end my talk by this take-home message that ESWT is a bridging therapy, and it is also a very good therapy for vasculogenic ED as an intermediate. So well proven in vasculogenic ED, erectile dysfunction, and also in the acute phase of Peyronie's disease, has moderate evidence in the treatment of patients with chronic prostatitis and pelvic pain syndromes, and upcoming in other fields, so we have to wait for it. But for the other 3 conditions which I enumerated above, it's a proven knowledge. Thank you.
Thank you, Dr. Suraj. The next topic is ESWL relook. For this, I would like to invite Dr. Sunil Kumar, APV, Consultant Urology.
Good evening, everyone. ESWL relook. Already Dr. Suraj declared that ESWL is a old technology where using using which we beg the stone. This company people also felt that, and they reduced the frequency and started designing emission of ESWT anyway. So coming down, see in the era when RIRS is available in look and corner, and surgeons are trying to do that, is ESWL still relevant? Is the talk today. Next slide, yeah. Yeah, so why are we asking this question in 2026 when it is an age-old technology? See, still, why this question is relevant now is because, see, ureteroscopy case load as such increased. This is, this is an American data. Indians are pioneers of stone management. We decide the protocols, how the stones should be managed in the world. But still, see, 15% of the ureteroscopy procedures are increasing from 2012 to 2019. And my seniors, Dr. Tripathi or Basra says that during their post-graduation time, they were doing ESWL and were writing discharge summaries. So frequently they were doing. Now, during my residency, I didn't see many of ESWL. See, 2.5 times surgeons are more performing URS more. And again, the living example, when flexible ureteroscopy was initially taken, it was the cost of the equipment is around 10 lakhs. Now it come down to 20,000. Chain is made, chip-on-tip scope is available with a good vision to clear the stone. And so single-use and disposable flexible scopes are available where no sterilization is required. And Dr. Subudhi explained the thulium laser, which is faster and produces fine fragmentation of stone. And we have flexible vacuum suction device available to suck out the fragments from the kidney comfortably. And a daycare RIRs can be done. But see, again, for the stone clearance part, there is no argument. Flexible RIRs is way superior to ESWL. And need for retreatment is also, RIRs is more comfortable than ESWL. There is no question about that. But stone-free rate is not the same as patient benefit, because ESWL is a procedure where anesthesia, anesthesia is not required, and it is relatively pain-free compared to, and complications are comparable. And coming to economics, while taking economics into the consideration, ESWL is relatively cheaper than flexible URS. Even the guidelines says the same. AUS still suggests that distal ureteric calculi, URSR, ESWL is preferred modality for a stone which is size is less than 1 centimeter, and if it is less than 2 centimeters, still URSR, ESWL is the preferred route. If it is more than 1 centimeter in the lower calculus, PCNL is the route. Even EAS suggests the same. ESWL is first preferred line of management. In Indian picture, when we see that even in Indian picture, when lithotripsers are widely distributed in districts and tier 2 and tier 3 cities, and flexible ureteroscopy and holmium or thulium is not available other than in tertiary care centers, still ESWL is a preferred mode. So even, the cost-wise is for a single sitting of ESWL is around 10,000 to 20,000 rupees. A stone size of 7 mm may require 2 2 sittings, which comes on to 40,000, and RIRS 50,000 to, the range is 50,000 to 1,20,000, we can do the procedure. So, in Indian series as such, see this is if a lower pole stone is less than 1.5 centimeter, the stone clearance is practically 33% in ESWL, and in corporates we usually stent the patient before doing ESWL. Stenting for taking him to OT under minimal sedation, still it's a procedure. Meanwhile, in the same setting we can do RIRS is the logical sense, but every time stenting is not required for the ESWL procedure altogether. But the stone clearance still, with a stone of less than 1.5 centimeters, mini PCNL and RIRS have an advantage. So, if a properly performed ESWL, where we take the consideration of the stone density, stone strength, distance from the skin, and stone diameter, if it is properly selected, then ESWL is a wonderful option for the stone clearance. So, do ESWL properly or don't do it at all is the final thing I want to say. So, practical way to divide is, these are the different factors: stones less than 10 mm, density less than 1000 HU, and the stone position in the kidney will decide whether ESWL should be practiced or straight away go for RIRS. So, if in our case, in Fortis we have all the equipment in the world, we have ESWL also with us. So if the stone is, can be used as ESWL as an additional thing when we are performing RIRs. In case the stone is located in a lower pole which is inaccessible for flexible scope to go down, we can still use ESWL to push the stone, propel the stone into the accessible area, so that when we go re-look, it is easily accessible to clear the stone. That's how we are trying to manage in our center. So, what could change? The answer again is burst wave lithotripsy is when ESWL is performed with short waves and properly done, or ultrasonic propulsion. Instead of using acoustic repositioning, we use ultrasonic propulsion to push the stone out, and a smarter candidate selection where we use AI, where we can load the CT scans, which can, with the density determination, it can say whether ESWL is useful in this patient or not. This will guide us in future whether ESWL should be performed in the patient or not. Thank you.
Thank you, Dr. Sunil. The next topic is ECMO in robotic surgery. For this, I'd like to invite Dr. Geeta Muniraj, Senior Consultant, Cardiac Anesthesiologist.
Good evening, everyone. Everyone must be wondering what's ECMO doing in a surgical conference. This is typical example of thinking outside the box. So we are just extending the limits of operability from high risk to safely operable. Next slide. So, next slide. So case scenario, a 42-year-old gentleman, known case of ischemic cardiomyopathy with terminal heart failure, was diagnosed to have left renal cell carcinoma, posted for robotic left radical nephrectomy. Deferred surgery elsewhere. Would you proceed with this case? Next slide. So, excuse me, how to go for the next slide? Okay. Play button. Okay, fine. So second scenario, we are operating a robotic surgery and ventilation fails mid-case. So we are unable to ventilate this patient. Patient is desaturating, carbon dioxide is rising with severe respiratory acidosis. How would we manage this case? So these are the two typical complications during robotic surgery. And what is ECMO? It's an artificial life support system which supports the heart and lung function when it fails. So we have just, it's an extension of cardiopulmonary bypass regularly used in cardiac surgeries. So ECMO is a modification of that, and here we have tried to implement this support system in a case of complications during robotic surgery. So basically we have two types of ECMO. Veno-venous ECMO provides basically the lung support, and veno-arterial ECMO supports both the heart and the lungs. So these are the typical approaches for ECMO support. We usually put a large bore cannulas onto the femoral artery and the femoral vein in case of VA ECMO, that's peripheral ECMO, and central aorta and RA cannulation for a central VA ECMO. So whereas pulmonary support, we put two large cannulas, the outflow cannula on the femoral vein and the return cannula onto the right IJV. So why ECMO in robotic surgery? Since morning we have been discussing the various physiological changes happening due to the positioning, due to the pneumoperitoneum cause, the borderline functioning heart failure patients and the lung failure, like COPD patients or a restrictive airway disease patients may not tolerate the stress response of a robotic surgery. So severe cardiac dysfunction facing major surgery, steep Trendelenburg and the pneumoperitoneum combination is a deadly combination for a restrictive airway disease patients. So refractory hypoxemia or hypercapnia, VV ECMO offers a rescue pathway, and it's a planned safety net for high-risk cases. So how did we manage the first case? Terminal heart failure patient, we managed him on a VA ECMO. So soon after induction, we put him on a VA ECMO via peripheral cannulation, and then we positioned him in a lateral position, and then we did a radical nephrectomy case. Over the few hours later, we weaned him off ECMO and managed him with just inotropic supports, and we extubated him with next 6 hours post-operatively. He was discharged 6th post-operative day. So this was the hemodynamic stability on ECMO during surgery. So ventilation fails mid-case, we had to undock the patient, insert the femoral and internal jugular venous cannula access to establish VV ECMO, and the circuit took care of the oxygenation and CO2 clearance and lung successful completion of surgery in a nearly apneic ventilation case. So once the patient is on ECMO, it also comes with an equally challenging, as we have to maintain the and the cannulations, and due to this artificial circuit, we have to give heparin to the patient, so it poses bleeding risk. So once that is done, we obviously have to wean and decannulate this patient safely. So complications associated with this bleeding and vascular injury, hemolysis, infection, limb ischemia, thromboembolism, as it is an artificial circuit. So why ECMO? It obviously turns the inoperable into the operable. So thorough multidisciplinary planning, ECMO lets high-risk cardiac and pulmonary patients previously denied surgery undergo complex robotic procedures in a safe, monitored environment. So what is more important is proactive planning. So plan support before positioning and docking, not after clinical decompensation. This is the most important thing. And tailored support, VV ECMO or on the indication for the support. And obviously, it's not going to be possible without a multidisciplinary team, including the perfusionists, cardiac surgeons, cardiac anesthetists. And this is what I would want to convey. We are doing the unimaginable with the ECMO support. And thanks, Dr. Mohan, sir, for including this topic in this SURGX conference. And thanks for giving us an opportunity to be present here. Thank you.
The next topic is Polaris, the future of cancer prostate in decision making. For this, I'd like to invite Dr. Suraksha Rao, Lab Head, Fortis Yashwantpur.
Good evening, everyone. Imagine a patient with elderly gentleman who is otherwise healthy except for probably stage 3 CKD, has a PSA score of say 6.5 and a Gleason of 4+3. So urologist would probably think, should we treat, should we wait, surveillance versus surgery? Whereas nephrologist will think, the more aggressive, will the kidney even survive the treatment, or would the patient even survive? So that's where probably precision diagnostics, and the topic for today is Prolaris, which is a genetic test, comes into picture. So as we know, prostate cancer is a very indolent but highly variable cancer. Two people with the same PSA and Gleason can have different outcomes. One can be aggressive, whereas one may not be aggressive. So most of the prognostic models are based on PSA and Gleason scores, and recently with the multiparametric MRI. But all these, as I told, there is a thought whether we are over-treating an indolent cancer or are we under-treating a quite aggressive cancer. That leads to unnecessary anxiety. Over-treatment leads to more morbidity, and under-treatment leads to different side effects. So coming to how the treatment is generally done, it's basically based on the score and clinical parameters. So it's either active surveillance versus definitive treatment, which includes surgery with or without radiotherapy and with or without ADT. So that's what is Prolaris basically. It's a mRNA-based genetic test which gives a score, and this is basically for only people diagnosed with indolent and clinically localized prostate cancers, not for people with aggressive. What does the test report? So, So the test basically gives a score which gives a 10-year risk of prostate disease specific mortality and also the 10-year metastasis risk after surgery. So here the Prolaris test basically checks for the cell cycle proliferation genes. So more the proliferation, higher the score, which means more aggressive the cancer. And this score which the test gives is called as the Prolaris molecular score. So this individually acts as a prognostic factor which can, every increase in score doubles the risk. So how the score is basically calculated is based on the clinical variables as well as the cell cycle proliferation or the gene proliferation. So they use the Capra score and the cell cycle proliferation gene, and with this combined we get the combined clinical risk score or the CCR score, which gives 10 years disease specific mortality as well as 10-year metastasis risk after the treatment. So based on the score, if the score which we get from the test is low, then the patient is more suitable for only active surveillance, whereas the single intermediate and higher score puts the patient more for single modality or multimodality treatment. So there have been a lot of validation studies across the world which have shown quite an increase in change in the decision making based on the score, where they were able to stratify the patient more as for active surveillance who were overdiagnosed. So the test also gives something called as the multimodal stratification risk score, where below the score you can keep the patient more for single modal treatment, and above that threshold score indicates the patient is more fit for multimodal treatment. So the sample used for the test is nothing but the needle biopsies from the prostate, and ideally it needs a 0.5 millimeter core with more than 75% tumor in the core. So this is how the report generally comes. It's a 3-page report where it gives the active surveillance risk, and it also gives mainly the score, and it says it stratifies the patient based on the score, whether is the patient more for single modality or multimodality treatment. So coming to AI, addition of AI. So this adds the third dimension, digital pathology, as part of the Prolaris, where the slides are digitally scanned for subtle histology patterns which can get missed, and this adds to the score. And in the report, we get it as a PathMake AI score, which says the probability or likelihood for a higher Gleason score in future biopsies. So based on this, even in the active surveillance, it can be decided how intensive the active surveillance should be based on the score. So Prolaris definitely does not judgment, it just refines the treatment option, adding the molecular basis to the decision. Thank you.
Thank you, Doctor. The next topic is ITIND, elegant solution for BPH. For this, I'd like to call Dr. Nagareddy Patil, consultant urology.
Hello there, good evening everyone. So now I'm going to talk about ITIND, newer device for the BPH. Why it is an elegant solution for the BPH, let's see it. So traditionally the modalities of treatment for the BPH have been like from drug medications to TURP, and for the larger glands we had open surgery and robotic surgeries. But there are some set of patients where the TURP, which is a gold standard method, might not be applicable, or patients might not prefer it for certain reasons like retrograde ejaculation or urinary incontinence risk. So there are patients who want no permanent implant and they want preserved erectile and ejaculatory function, and they don't want any anesthesia and rapid return to normal activity and durable relief of obstructive symptoms. In these set of patients, ITIND can be a good solution. So what is ITIND system? It is basically a self-expanding nitinol frame. It is in second generation form right now, and it is a temporary implant. So the modus operandi is a mechanical. It is not any ablative procedure, or it won't cause any cavitatory effect there. And it was first marketed in 2016 in Europe, and later in 2020 it got FDA de novo classification regulatory permission. So basically it has got three parts. One is the struts. You can see the metallic frame there at the 3 level, and then there is a polyester suture which is used for retrieval of device later, and then there is an anchoring leaflet in the downside. So the length of device is around 5 centimeter and the height is 3.3 centimeter. It is a nitinol made up of nickel and titanium. So mainly it is elastic in nature, which expands over the period of time in 5 to 7 days. The mechanism of action, basically these 3 struts apply focal pressure necrosis, which causes scar in the incision area, and which remodels in 5 to 7 days. After 5 to 7 days, patient comes back. We can remove this implant in an office as an office procedure. So even to insert this implant, it is office procedure with mild sedation and local anesthesia. We can do this procedure, and just a rigid cystoscope or flexible cystoscope is sufficient for this. And the duration of procedure would be around 10 to 15 minutes. So this is an insertion modality. Through the cystoscope, we can just deploy this device, and positioning is very important. The struts should be at 12, 5, and 7 o'clock position. The anchoring leaflet should be at a 6 o'clock position. So you can see here the ideal position of the device. The 6 o'clock position, there is an anchoring leaflet that should be exactly at the bottom of the bladder neck. And in the below, the real clinical pictures before the surgery, after the surgery, you can see wide open bladder neck and prostate fossa with the incisions there, mechanical incisions. So this is a video. And who are the suitable candidates? It is preferred in engaged males and the people who are very much old, more than 80 years, who cannot tolerate TRP or any extensive procedures. And we can do this procedure in the patients where we cannot withhold the blood thinners. And ideally, the prostate size should be less than 60 grams. And the patients who want quick fix, in those patients also we can offer this as and it should be avoided in patients with large median lobe or prostate more than 75 grams or who have got active urine infection or there is a stricture or any prostate cancer. And there are clinical studies which support this implant. There is a good improvement in IBSS score and QMAX values also. And there are separate set of studies done by MT, this Meditate company. Like there are study 2, 3, 6, and 8. All have shown good improvement with respect to IPSS score and QMAX. And where the site fits comparing to other minimally invasive the procedures and TRP. So yes, there is no permanent implant, there is no tissue removed, and it is typically done in light sedation or local anesthesia, and there is no need of catheter and good sexual function preservation. Yes, it has got some limitations, like some side effect, adverse effects like infection, retention, implant migration, and some kind of storage. And yes, there is no level 1 data or no long-term results, but up to 6 years, we can say that it can be effective. So finally, so it is an elegant option for selected patients where like it gives rapid symptom relief and lowest post-op catheterization rate and preservation of sexual function and suitable for patients with high or tight bladder neck, and it is a temporary implant. Thank you.
Thank you, Doctor. Our next topic is restorative gynecology with UltraFem 360. For this, I'd like to invite Dr. Rubina Shanavas, Additional Director.
Good evening, everyone. Good news, I'm the last but one speaker holding you back from the very interesting session on future in robotics. Not so good news, you have to bear with me for the next 4 minutes. This is very similar to the not so good news patients give me when I tell them go do pelvic floor exercises and come back. And when they come back and say, I did it for 2 days when you told me, then I forgot about it. And this is 3 months after. They are conditioned. I know I cannot help them with surgery because it's not anatomical repair, is not going to fix. We need the muscles to work. We need neuromuscular coordination. So the good news is in this, we have bridge therapy. The analogy I can give you is very similar to the market where the GLP-1s have entered now. So you tell, we all know exercise, diet, how many of us do it? Why is the market there so much for Mount Jaro? Very similarly, here comes the MCLA chair and the BTL 360. Because it does what the patient should be doing, but we don't do because of lack of consistency. So going on, earlier it was only aesthetic gynecology. In the last 5 years, the shift has moved towards functional gynecology, where we use this OPD, no anesthesia, just an OPD procedure, 8-minute sitting, where the energy is delivered in the vaginal probe, just like a transvaginal ultrasound. So this is the main indications are for vaginal laxity, GSM, and SUI, which doesn't warrant surgery. So what is the difference? Now, everything we all know, even I thought everything was laser. No, this is a radio frequency device. So where there is no injury to the epithelium. So in the earlier laser technology, there used to be continuous discharge for a couple of weeks. Patient could not go back to her usual lifestyle. But in this, no downtime. 8 minutes, done, go, come back. And the other one, we had to wait for 3-4 weeks till we do the next session. So we couldn't offer it to patients who are not from Bangalore. or who couldn't stay here long enough. This weekly once, 3 sessions, each 8 minutes, and they are done. So that is what is monopolar RF, what we have recently acquired, the UltraFem 360. This is a brief mechanism of action. I'll let this video run through, and then I'll move on to the EMSLA check. Collagenesis, which happens with the MPRF, monopolar radio frequency device system. It can also be used for this condition. Dermatologists didn't have a treatment, we didn't have a treatment, we didn't know what to do for atrophic vulvitis. But with this, we are seeing beautiful results for women to be confident always, whatever be their age, and live their life as they want to, any age. And so this is the clinical, this is the next EMSLA chair. I think most of you must have heard of this. This is, the patient doesn't even have to change. They sit fully clothed. On this, it is for males and females. It delivers supramaximal Kegel's contractions, 28 minutes, and it is 2 sittings per week, and it is done for 6 sittings in total. The only thing is, because it's electromagnetic technology, whatever is there within the periphery, like, where you're sitting in the chair, from that handle to where you sit, there should not be any magnetic device. So if there is an IUCD in situ, it's a contraindication, and knee joint is okay if there is any, implant which is kept. Again, a wonderful way to detox. You cannot use your devices while you're sitting on this. So you should see the number of devices. Apple Watch comes out, your headset comes out, phone comes out, sit and read what you're given. So this is EMSLA chair, and it is a walk-in, walk-out procedure. It's called so this is the mechanism of action, where it gives the electromagnetic high-intensity energy to the pelvic floor, and it results in a supramaximal contraction to the pelvic floor. So all these are for those indications we know it will help, but people don't do. And this ensures we give the correct result while not over-promising or under-promising. It's the perfect bridge therapy, and it ensures that we as team urology and urogynecology are able to give 360-degree care to the patient, come what may, be it invasive, non-invasive, or advanced technology. Thank you everyone for your patient hearing.
Thank you, Dr. Rubina. Our final topic for today, indigenous innovation and MAs from Bengaluru to the world. For this, I'd like to invite Dr. Shakir Tabriz.
Good evening, everyone. Even better news, I'm the last one, standing between you and what comes next. So I'm here to quickly talk about a homegrown company. So this is somebody who's been partnering with us and our team for years now. And it is from Bangalore to the world. We've seen all companies make their products elsewhere, and then we're using it here. But this is a homegrown company who have seen what everybody has seen, and they have thought what nobody has thought. So what does this lead to? This is our partner, Blue Neem. So they have a beautiful factory. For those who are interested to visit, they can take you right here in Bangalore. And the products they make are very thoughtful and very, very helpful to our patients. We've been speaking about so many procedures, so many theaters, and intraoperative, but always a patient goes away with this tube. So we need to make this tube comfortable, we need to make this infection-free, and catheter-associated urinary tract infection needs to be avoided. So with their help, we've been using this, which is an antimicrobial coated latex Foley catheter. So this helps to reduce the urethral irritation, inflammation, and also infections. This is a device which we use in most of our stone procedures. We are able to pass a basket, grab the stone. Now we want to pass a laser. So we didn't have, then this homegrown company came up and said, why don't we pass a laser through the core? where the stone is gripped, we pass a laser through it, and it stays there waiting for you to break it into pieces. So this is how that helped Lasermatic. So the accuracy is enhanced. We are going through, breaking the stone doesn't migrate. Stents. When we put in a stent, we usually remove it in 2-3 weeks, but then we need, sometimes there are these strictures or there are malignancies where you have to have the stent for a year or more. Now, these are stents which have a metal coil and silicone base. So these are silicone stents which we can use. They are long-term. Once you put it in, they have to come back only a year later, and they are a lot less irritative in the bladder when compared to the usual PTFE stents. Often we have this procedure called self-catheterization, where a patient has to pass a catheter through by themselves, and that is a very, very difficult thing to do. Here, this relief CSC catheter has a gripper, which is very ergonomic, easier to hold, and then the flexibility and stiffness has a nice balance so that it can be passed easily and then urine removed. This is intraoperative. We use this catheter for hypospadias surgeries, and this is what is used as a scaffolding around which the repair is made, and very, very helpful. This is a biopsy. The fully automatic gun is for solid organs. The semi-automatic is when we are near blood vessels or very delicate organs, where we place it, we locate it, and then we fire. So that's a semi-automatic. And the last one, the wire localizer, it tells us where exactly the lesion is. Like, it's placing a flag and telling the surgeon where to bomb his missiles. So that's how that works. And of course, drainage products. As I promised, I'm very scared of that buzzer. I'm stopping much before it. Thank you. Have a nice day.
Thank you, Dr. Shakir. With that, we conclude our case discussions for today. Throughout the day, we've had clinical discussions, innovation capsules. So now we have 2 interesting panel discussions. Please bear with us for some more time. Post that, we have a little surprise also for you. So we'll begin with our first panel discussion. May I request to please have the arrangement on the stage, please. Our first panel discussion brings together leaders from Fortis as well as Intuitive India, our lead sponsor for today, for the 2-day conference. And to moderate this panel discussion, I'd like to invite Dr. Mohan Keshamurthy, Principal Director, Renal Sciences, Fortis Hospitals, Bengaluru. Joining him on stage are our panelists, Mr. Rohit Mahajan, Vice President and General Manager, Intuitive India, Mr. Abhijit Patwari, Senior Director, Clinical Sales, Intuitive India, Mr. Anil Vinayak, Group COO, Fortis Healthcare, Dr. Bishnu Panigrahi, Group Head, Medical Strategy and Operations. Over to Dr. Mohan.
It's a privilege to have everybody who has, I won't say sponsored, energized the robotic journey that I have had as an individual and as a leader of a team that has built possibly one of the strongest robotic programs in India. Each one of them here would actually lead India forwards in the robotic revolution that we have. The reason for that is Da Vinci platform has done about 20 million procedures so far. They did 3 million last year, but India does only 0.5% of those procedures. We anticipate by 2030 we'll do 4% of those procedures, with an annual Da Vinci surgical procedure volume being 5 million. So India is on the anvil of a revolution in terms of adaptation of robotic surgery, but there are vital questions to be answered of how exactly are we going to define this revolution. So I'll start off with my first question. Anil sir, what do you think will define the next decade of robotic surgery in the Indian context?
So I've seen the last decade, because about 10 years ago in my first hospital, we got a robo for the first time. And I remember that it took a lot of convincing by a lot of people to bring that platform in. There was a lot of concern about whether there was going to be any real benefit to patients and whether the ROI will ever sort of work out either. Whether enough people will be able to demonstrate high quality surgery. But happy to say that over the last 10 years, that picture has changed completely, right? So I'm sure the next 10 will be the next level of evolution, from answering the simple question about whether robotic surgery is the future to how do we penetrate much more. Today, like laparoscopy is almost universal. How do we make robotics virtually universal? Obviously, a lot of things will have to come together for that to be possible. But I do believe that that is the future.
So,
for the next 10 years,
so the point is, it may not become as ubiquitous as laparoscopy. We'll define why. But there is this common man perception that at least in half the times I have addressed non-doctors that the machine, the robot itself does surgery. And with the concept of Elon Musk that the surgeon is replaceable or the doctor is replaceable, the question to Rohit is very simple. Will AI become an assistant, an advisor, or an autonomous surgeon with intuitive platform?
Well, that's a phenomenal question. And I must say, I get that same question from everyone I ever meet. Because you have the driverless cars, so people are thrilled to see if there will be surgeon-less surgeries. The short answer is no, not in near sight. But the long answer is that, when we look at surgery, it requires a lot of kind of adaptability, communication with patients, with their families, a lot of, gentleness, precision, judgment, which is taken during that surgery. These are all human and are going to stay human for a very long time. But having said that, the world of AI is here, and we have to embrace it. The way we see at Intuitive, this is through a stack of data and its foundation. So what we see already happening is that all the 20 million surgeries that Dr. Mohan, you mentioned earlier, already has given us a lot of foundational data on our outcomes, on the procedures. Now what we're going to do with that is how do we leverage that data to give us insights, right, for surgeons to be better. And with that, what would happen is you would start getting intraoperative guidance, which is not now just before the surgery, but also during the surgery, bases all the machine learning and AI that runs at the back, right? So the surgeon now gets more and more empowered, right? And the fourth layer on top of that is augmented dexterity. What that means is, can we look at some parts of the surgery which are more mechanical, which perhaps can be duplicated by the robot itself, and can we take those small parts? It can be retraction, it can be a simple suturing, and can we leverage that 20 million procedures and give that to the robot? So that's where we're headed. All of this doesn't exist today, But we are hopeful that in the future, we're able to have supervised autonomy is what we want to call that, wherein the surgeon is always in control, but the AI and the data stack helps them take the right decisions and perhaps give them autonomy at the places where it really matters.
Because the issue for young robotic surgeons in the audience would be, do we have a job? Because my son, when he joined computer science in the US, 4 years ago, coding was what he thought will make his living. But coding didn't exist because ChatGPT took away his job. So the point is, it will make better surgeons, good surgeons better. It will improve outcomes. It will fine-tune reproducibility and possibly help education of a newbie surgeon. The learning curve will be shorter. So that's about summarizes what you said. Now, Bishnuji, who is our Bhishma Pitamaha of robotic, Fortis robotic program, there's one question which everybody asks. Is telesurgery going to be a practical reality in India or just a fad that fades away? And if you do think it will become a reality in India, how do you think it will be practical across this vast country?
See, on the telesurgery, presently it is sub judice. So till the Supreme Court, they give a clearance, we can't do that. Because if you recollect, one of the honorable judges in his remarks, he made, are you asking that Virat Kohli will be playing cricket and also commentating? That was a comment. So he gave that so I think so till that is there, we can't do it. But the National Medical Council, I'm coming straight to the point, is that the National Medical Council was asked by the Supreme Court to come and give some suggestions. So they were supposed to give it last year in July. It was shifted to September, to November, and we have finished 25. 26 is midway. I have not seen the light of the day there. But there is work happening at the background. So one of the things that's coming up is that the NMC has to give guidelines that this is for training. And so at the back end, that work is happening because being part of the FICCI Health Services Committee, there's some insights I have. But still, you know how the government works, how the various functions work. It is slow. But there is the caveat is that if someone really wants it, because in every place, the district medical officer, chief medical officer is the head of the health services for that district. So if you ask for permission from directly, they can give it because the Supreme Court is still given this still because it is still sub judice. So some people ask that till you all give us the clearance, what do we do? Because we are using it also for academic purposes. So if you go to if you give it in writing and to the chief medical officer that we want to have a seminar where we'll be having students there, we'll be having people from other places also to come and see how we are adopting this new technology. So this has happened. And again, but I do see telesurgery to have a potential going forward, but we have to clear the legal
hurdle first. And that's exactly the reason Da Vinci is the only platform which is still not, although telesurgery capable, it has not been a platform that has been used for telesurgery. That's a common question I got in the audience today. Why does Da Vinci not allow telesurgery? Beautifully answered that we still need to clear a legal hurdle, then a logistical hurdle, then a medical legal hurdle, or who is responsible? Technology, doctor at one end, doctor at the other end, or all of them put together? Who is culpable? Now coming to the next question, what do you think separates programs that thrive from those that struggle after initial enthusiasm? And once you answer that, I would want the man who has led the two largest robotic programs in the country, Max and Fortis, to comment on that reply. What does industry think matters to make a robotic program successful? And what does a man who leads operationally, the two, Max and Fortis are the two largest, volumetrically the two largest programs in the country. He has led both. So I want him to comment. From your side, what do you think works? And from his side, what makes sense?
Sure. Thank you, Mohan. Thank you, Dr. Mohan. It's a good question. I think, given my experience of the robotic programs across the country, what I have observed is the programs which are successful, they have this ability of viewing, the robotic programs as a long-term strategic initiative rather than just a technology purchase. And if you ask me 4 things that I see pretty common across all the successful programs. There are some programs which have failed, but one of these would be missing there. But the 4 things, I'll come back to that. The first one is they have a very strong and a committed surgeon champion. So in Fortis's case, it's Dr. Mohan. But they have a strong surgeon champion or champions. Sometimes it could be multiple surgeons from multiple
That is
specialties.
more true in my case.
Yes. So it could be one or multiple surgeons, but we need those surgeon champions. The second and the most underestimated important point is the alignment with the leadership and the executives. This is the most underestimated. Wherever this is missing, we have seen programs fail. The third is, I think, the multidisciplinary approach on robotics. Many times we see, it's changing now, but there is an exclusivity around robotics saying that only this particular department or specialty should have robotics, the others should not. Whereas we are seeing so much of growth in multiple specialties that you can adopt robotics into. And fourth, of course, the focus on continuous learning as you grow the programs. Along with that, Dr. Mohan, I have also seen that these institutions have built good governance around, training, training not just the surgeons but even the care teams. Then they have case selection. They have good governance around which cases to be selected for robotics. So case selection is another thing. System utilization, where there is logistics involved, so you need to be very good at that. And of course, the tracking of the performance metrics on robotics. So I think these are the parameters. Ultimately, the sustainability of growth is going to come from institutions where, the culture is that robotic surgery is a part of their DNA, and they need to speak about it in terms of long-term development.
I would request Anil Sarji to tell his perspective.
So I'd say the champions today in today's context is very important. A group of people, preferably, who are absolutely passionate about learning and developing a robotic program. I think the one element that you've missed is that there needs to be a reasonable volume of work that happens in that center, because in the absence of that, the program really will not be able to take off. You need enough work that's happening already in the center, and that then is a place where robotic can thrive as well. I agree with more or less the other points that were mentioned earlier.
The next question obviously is to Rohit. What will it take for any platform, robotic platform, to advance the access to more patients in India? So we are talking of Tier 1 cities. We are started talking about Tier 2 cities, but we are 1.7 billion. So we are still, as I said, we are 0.5% country. Countries like Taiwan, Korea, which are not even the size of Bangalore, possibly have a much larger program. So the question to you, from the industry perspective, what do you think will drive greater acceptance of minimal access procedures, especially on the robotic platform?
Yeah, that's a great question, Dr. Mohan. And by the way, as you speak about numbers, when I represent India at our global forums, everyone knows the opportunity size in India is huge, and which is what Intuitive also, like other industry partners, recognize that we have to be more agile, we have to be nimble, but we also have to create solutions which are appropriate for market. So a lot of focus on that side as well. Coming back to your question on how do we scale this beyond Tier 1, make it accessible, right? So I think we've kind of we've written the playbook once, which is what Abhijit and Mr. Anil just said, which is for large centers. The question now is, how do we write the playbook next time? Correct. But this time, this is for maybe smaller volume centers, maybe in Tier 2, Tier 3 towns. The way I think about this, and we imagine this is, it's a combination of few things. First, training. We have to make sure in India today, despite our surgeon population, we have only 2,000 surgeons trained on Da Vinci. So first step we have to make is talent and training. So more centers need to attract that surgical talent, and we need to make sure that they are trained, provided exposure, and built early in their careers. So they start looking at robotic assisted surgery as the default preference versus going through that transition, which everybody else went through, just open lab and robotics, right? So I think the first and most critical thing is that. I think to help us in that, Dr. Mohan, we have technologies today. For example, we have telepresence. Dr. Bishnu mentioned in future telesurgery, but which is predominantly, again, telecollaboration. How can we embrace these technologies faster, make sure that tier 3 city also is able to log in, see your procedure and learn from you faster, and be that person who can then do the surgery later, is going to be very, very critical. Right? So, yeah, you want to comment on that? I just have
one big comment is you skirted one possibility of that cost sensitivity of the Indian market. The metros can afford, the secondary metros can hardly afford, beyond the secondary metros. So the one question we have is, you have reasonable insurance penetration. Can we look at India as a market where Intuitive or Da Vinci or any robotic platform has to look at a lower cost per surgery? That's a difficult question. I will let you answer it whichever way you want.
It's difficult, but let me tell you, this is the most frequent question that
I've asked you many times in private, but as Vishnu sir offered me a DV5 in public, I'm not asking you to commit to anything, but what is the thought process?
I think the total cost is an extremely important aspect. The way we look at this is, of course, there's this cost of robot, but then there's cost of consumables, instruments, and the service as well. So there are a few ways in which we think about it. We at Intuitive are thinking, how can we cut down the upfront cost? Which means, can we look at high quality remanufactured, reconditioned products, which come at a lower price, but can then open up the market, right? Is one part. The other aspect is on the operating expense side. How can we look at instruments which can potentially have more lives? There's a constant innovation stream that goes on in our Sunnyvale office, where constantly we are trying to see how can we get more lives, which means your price per case keeps on coming down, right? We did it once a few years back, and then we're always evaluating that. The third aspect to make a program financially viable is, where do we meet a customer where they want us to meet? Which means, for example, if they don't have enough capital to support that purchase, can we offer them lease? Can we offer them flexible payment methodology, like pay-per-use in other areas, in which we can really support and back the volumes that actually Mr. Anil spoke about? So if there are volumes, if there are patients who want to get treated, can technology lower the barrier of cost upfront and make sure that we go, there we are able to pay, or the institute is able to pay as they go, are also things that we are already thinking about.
So one thing is technology, lowering it. I'll leave you with one comment. Lowering costs can actually make technology more accessible, but that's for a discussion another day. But I will now ask Vishnu sir, what should healthcare leaders be focusing on the next 3 to 5 years to maximize their own robotic programs?
I'll first go from that question that you put up to them. In fact, during the lunch break, I was just telling him this also. I'd mentioned it earlier. I think so India is a volume player.
Correct.
So don't weigh us in the Western world metrics. So if you could look at that costing, you can increase the penetration in your tier 2 and tier 3 cities. And that is the challenge. That is where the growth is going to happen over the next 10, 15 years. It is going to happen. It's happening, and it will happen. So and I've told it very categorically to them also, is that if you all don't do it, you all will miss the bus, because there are other players who are coming out with, they're competing with you all, they are copying you all, they may be as good as you all, even better also, because that's how technology evolves. And if you all don't come down on the price points, tier 2 and tier 3 cities, you will miss out on that. It will become a Kodak moment.
Absolutely.
So don't mind my words, but I'm being honest here.
Absolutely. The one issue which is difficult to discuss in public is cost. But the one issue which will drive volumes, which will make extraordinary technology available to your deserving patient, is cost.
I'll come to your... sorry.
I have one more element of cost here. So you need the insurance side to support robotic surgery. And I think what's coming in the way of that is lack of evidence in India. We need more data that proves that robotic procedures are able to produce a benefit for the customer.
I was coming to that.
And once we are able to produce that, I think once insurance opens up, then that also is a big lever for potentially increasing penetration.
Yes,
Because
they will pay more if they can get a better outcome.
Moni was
Agree
asking
with
about that. Moni was asking about how do healthcare providers look at it. So I think we have to start looking at what are the outcomes that these are delivering. So that's the discussion that I was having with them. So unless that because outcomes are objective, I think it's not subjective. So if we can have that for whether it's for robotics, for urology procedures, gynae procedures, for GI and general surgery, and hardcore evidence always, hardcore data always tells the truth when it is picked up honestly. And this is what the insurance providers also will look at. And globally also the data is coming out, but we require Indian data. Now, if Intuitive has taken the lead in the robotic space, they should have come out with data by now.
Agree.
So which should have happened yesterday is not happening today, will happen tomorrow. So Rohit, I'm being too passionate about outcomes, but to Anil's point is very clear because he gets the push from the insurance providers. I'm seeing it. So they require data. So I think so. To be fair to the insurance providers also, because in one of the insurance meetings also, I was asked by a senior CEO of an insurance provider, Doctor, if you can do it with lab coli, why should you do robotic coli?
Absolutely, that's the question.
So, but if data is there, why this is better? Like your length of stay, blood loss, pain, all the other things, and how this will open up more beds for patients too, because you can't keep on opening beds. But these things are not coming through. So I think if that is there, and to your point on
Vishnu,
how will technology how will we look at technology for the future? I think so. We are very fortunate in India to have the best clinicians. Even in USA, they say the Indian doctors, we go to them, their morbidity is less when the patients go to an white American doctor. So this is told by many people. Even I'll not mention the names of other politicians of US who have mentioned this. So we are fortunate to have a very good pool of clinicians. So we as healthcare providers will see that we enable them with good technology. They'll be the drivers. AI, to your point, AI cannot be the driver. AI will be an enabler, and the driver will be our clinicians who can do it. So again, to Anil's point is that we have to have the volumes in that hospital to sort of
to drive data. Yes. I'll let you rebut everything, Rohit.
No rebuttal. I'm actually, this is all one team, so there's no rebuttal. We're all talking the same language. When he said Kodak moment, it just reminded me, almost 9 months back in our US office, I had a similar conversation with our CEO and everybody, and I made the same remark. I told them that, hey, we don't want the Kodak moment to happen in India in robotics. And so things have changed also because we've realized as a company that the needs of a market like India is very different from what is needed in Taiwan and Korea. So there's now huge appreciation thanks to pushbacks we've got from these two gentlemen sitting here and several others who keep telling us. So that's number one, that everyone's taken note. And this is not just about price, it's also going to be about future products. It's also going to be about future coverage. I think if you look at these three are very unique in India. You need to have the right products, you need to have right coverage, and at the right price. So definitely going along. And on insurance, I think we are all together. Actually, Dr. Vishnu joins me on several of those industry forums where we've started presenting now Indian data. And you've been part of some of those studies and several others.
We have been part of studies, but the point wonderfully made is you need volumes, but if you want volumes, you'll need lower the cost. Yeah. Only if you have volumes, you'll have data, Indian data. Only if Indian data, insurance company will support the procedure. Yeah. Only if the insurance company supports the procedure, it will be greater volume. Now, where do we start? That is why I put all four who possibly decide it in one row.
Someone has to take a bet, because in this country, interestingly, great products, great quality has been delivered consistently at a much lower price. And I think COBG, we were talking about a while ago, a cardiac surgery in India is the same price today as it was 5 years ago, 10 years ago maybe. And it is best in class on outcomes anywhere in the world if you compare, right? So good quality and good pricing have to come together for this country to really open up in terms of volumes. But once those two come together, then the volumes are incredibly large.
Absolutely. Now, I will end this with one difficult question for all of you, starting with Rohit, then with Abhijit, and then the two gentlemen who have energized our program here. We expect 10,000 by 2029, maybe the first Asian program to reach there. But the two gentlemen have really energized the imagination I've had without a business case backing. So I'll start off with the question. This was about beyond the console for robotic surgery. If you would want one disruption in the Indian space to energize robotic surgery across this country, what it would be? So I'll start off with you and all four of you. What is the one thing you think in the next 2 to 3 years that can change the adaptation of robotic surgery beyond the console, beyond the obvious top tier cities?
I can give you two. let me tell these two, which I think are very important. First one is all the young surgeons, all folks who are passing out of college. We call them catch them young, right? So they need to be exposed to technology. We at Intuitive are already planning on rolling out exposure programs. So the idea is, can we share with them the advantages of robotic surgery while they're studying? So we set up a training lab at AIMS recently, and there's a lot more which will come. So that's first which will be needed. Second, I think the awareness, the patient awareness is going to be a huge unlock. And I actually hear this from folks like Mr. Anil and other large CEOs and chairmen of big hospitals, is that now patients have started walking into hospitals and started asking, can I get robotic surgery done? But this is still happening in tier 1 cities. Yes. How can we make sure every patient knows two things? One, I can get robotic surgery done and can get better outcome, better treatment, blood loss, length of stay, readmission. But second, my insurance company also needs to cover it. So I think if kind of this virtuous cycle gets closed.
So the one thing you want is when they Google, they should say insurance will support your AI claim.
Whether it's a chat GPT or Gemini, you should be able to get all the info. So for which a lot of work needs to be done.
I understand.
But we are all together as industry and hospitals.
I understand. I was just pulling your leg. And on that note, we got our first student last week of post-MCH, FNB, DNB recognized fellowship in robotic surgery and kidney transplant at our center. We are the first corporate hospital to get a student beyond the institution, AIMS, JIPMA, which shows that there is interest in the evolving area of robotic surgery, and the government is bringing in bright people with a certified course. Nobody has a degree in robotic surgery at this point in time, but the government is coming in. Dr. Bishnu has done phenomenal work in credentialing people who can and who should, and even today morning he said we should publish at least 4 test data and relook at our own selves. So there is inward looking and an outward looking, but I understand education for young people to continue the legacy of robotic surgery in an organized fashion. That's your point. Abhijit.
Other than what Rohit has covered, which are important points, I still feel we have seen this cycle with laparoscopy also earlier, Dr. Mohan. Whether it is insurance reimbursements, whether it is adoption, direct to patient and things like that, I still feel the value that robotics is delivering today, it's a matter of time before first the surgeons realize, then the patients realize, and then the larger insurance companies, government, that recognition will come. And we are well on that phase. I joined Intuitive 9 years back when the scene was completely different. And we never even thought about IRDA approvals for robotic surgery, and we have now IRDA approval of robotic surgery to be covered, whatever procedures, but it's already on. That means we are on the path and we are moving really fast. So I remain very optimistic about support from government, most of the government institutions getting into robotic surgery, and insurance companies. The second part, I would say, is you asked me the question about 2-3 years, what's going to change dramatically. I think we started from oncology. We are getting into general surgery. The opportunities in the other specialties are so huge. I mean, we were talking about cardiac surgery today morning. adoption of robotic surgery in cardiac, in HPB, in many of the benign procedures. I think this is going to just take off like anything in it just takes about 2-3 years, and you're going to see so many specialties getting into robotics.
We will look at the industry perspective. Anil sir, what do you think should change?
So I've seen the growth over the last 10 years, right? And it is accelerating every year. So, you're right in saying that it'll grow quite rapidly. If the question is growth, I think that's the linear path that will definitely work. Having said that, if you were talking about transformation,
yes,
then I think it will come from innovation of robos, innovation in terms of pricing, both of which eventually will come down to lowering the barrier to entry for both the institutions that want to invest in it and the patient that wants to use that innovation.
Absolutely.
I think both will happen. And I can tell you it's a matter of time. This country is not going to stand still.
Absolutely. If A equipment doesn't work, you will look for jugaad. You will make the B equipment work for you.
And somebody else will create that. And sometimes the innovation turns out to be even better
than the original process.
Right.
We are the masters of jugaad. So jugaad is what we shall do. Vishnu sir.
I was a young lecturer way back in the late 80s in my medical college in Cuttack, when actually laparoscopic surgery started. And I'm giving this example is that there was a huge resistance from the senior professors. But when it came in, I saw the youngsters, the postgraduate students and the younger lecturers looking at it favorably. And they picked it up quickly. So what I'm giving that example is that our focus should be on seeing that we get a lot of youngsters exposed to robotic surgery. So wherever high volume robotic surgery is happening, we should be interacting with our medical colleges in our neighborhood for postgraduate students to come and view that, because they'll be the ones who will go out into the tier 2, tier 3 cities, even if they stay in the metros. But that is what's happened. When I look back as a young lecturer and now as an old man, I'm looking at from this side. So I think so that will be a game changer. And what I keep saying, that the entry barrier has to come down by bringing down the prices, and it's a volume game. You will be rocking.
Getting youngsters to adapt robotic surgery was the whole purpose of the CME. And that's why all of us are here today. Not just to say Fortis does it well, or Fortis outcomes are good, or Dr. Mohan's team has numbers, but it is to get the young people in this country to learn robotic surgery and, as Mr. Anil said, to innovate, to see it reaches the last person who deserves robotic surgery. On that note, gentlemen, wonderful discussion on where robotic surgery will take us. Thanks for your time and your presence.
Thank you, everyone. I request all the dignitaries to kindly remain on the stage. I request all the dignitaries to kindly remain on the stage. We have a small token of appreciation for each of you. May I request Dr. Anant Rao to please come onto the stage to kindly present the tokens of appreciation. Dr. Anant Rao. May I request the volunteers to please come forward with the mementos. We have a small token of appreciation for each one of you. May I request the dignitaries to kindly remain on the stage, please? May I request the dignitaries, Vishnu sir, Anil sir, Mr. Abhijit, Mr. Rohit. Yes, Dr. Mohan. Dr. Mohan, back to the stage, please. I would like to invite Mr. Gautam and Mr. Praveen Wali also on to join on the stage, please. The Intuitive team would like to felicitate the Fortis leadership. Thank you, everyone. Our next panel discussion is on AI and tech in healthcare, transforming the future of patient care in India. To moderate this session, I would like to invite Dr. Anant Rao, VP and Business Head, Fortis Hospitals, Bengaluru. Joining him are our panelists, Mr. Bipin K. Chaudhary, Chief Information Officer, Fortis Healthcare, Dr. Bhaskar Rajkumar, Advisor, Art Park, CEO, Charaka, Government of Karnataka Initiative, Dr. Amrut Kadam, HOD, Radiation Oncology and Deputy Director, RGUHS, Mr. Vijay Jain, Investor and Board Member in AI and ML, Energy and Defense Companies. Over to Dr. Anand.
Thank you, Jessica. Good evening, everybody. So this is the topic of the day, the year, the minute, the month, whatever you can call it. And we are having this most abused word called AI. So we'll try to make it more responsible in its use possibly in the next 20 minutes. And I have a very erudite panel here because they're all working on different spheres of AI and the way it can be utilized in both, private sector, public sector, education. So we have these stalwarts who are sitting here, and also in terms of, how it can be more beneficial to all of us, both in the audience as well as to the community at large. So first of all, congratulations on all the great work that all of you do. I have known, a couple of them from a little earlier, and I understand, the nature of the work that they have been doing and focusing on. So I would like to just, possibly look at it from a question that will kind of stir all of us. So this is a very generic question, and I would like to start from Bipin, my colleague. A very generic question. I think all four of you can just pick up maybe 2 or 3 liners on this. So with the development of technology like AI and robotics, a general perspective on where are we heading as an industry?
So I think, AI and robotics, if they go hand in hand, so what they're doing is actually they are making the treatment from reactive to proactive. They also give you opportunity to get the information far better, far quicker, and precise. Let's suppose if you don't have robotic or AI, I mean, like, you will ask multiple questions. You will, compare it with your past experience. You will take some time. You may make some mistakes as well. But with AI and the data and the kind of trained models which are available now, that makes things faster, quicker, and also precise, basically, in my view.
Yeah. Dr. Bhaskar? We have one more mic here. Maybe you can just, it'll be easier to share here.
So, in my opinion, to keep it simple, right? So, if you look at any technology which has come into healthcare or any sector for that matter, what it's really done is make life simpler for the practitioners of that sector. In this case, what's another thing which is really happening with AI and robotics coming in is it's giving time back to the practicing physicians. That's the most important thing, right? So how can we really give that quality time back to doctors, be it practicing physicians, clinicians, surgeons, anybody for that matter? More is the quality time I get in hand, better is the quality of care I can deliver. I think any technology today is focusing only on 3 things, accessibility, affordability, and quality. Here, the majority, what we are looking at as an expectation in robotics and AI in surgical field is to give that quality time back to the surgeon.
Thanks, Dr. Thank you, Dr. Bhaskar.
Thank you, Anand, for this opportunity to come present our views as well in AI. But I think surgeons are the tough people to convince. So I'm very happy to be in a surgeons forum here to talk on AI. So coming to technology, now you like it or not, this AI has created a lot of help for a lot of engineers. And I think if they don't repeat the word AI 5 times in a day, I think we may have to send them to hospital for counseling or something. That's the kind of scenario technologists have. But having said that, even in education space and even in healthcare, now there are 3 things which everybody knows now: ChatGPT, Gemini, and Claude. These are 3 commonest terminologies which everybody uses. But this is also changing the way healthcare is moving. So the patient is already uploaded all their reports on ChatGPT, coming with some response from it, and we have to deal with this kind of scenario. Unless we are able to, when we were practicing, in my clinic, so there was not much information available digitally for us to collate all this longitudinal data, because I work in cancer space. There's no longitudinal data for me to interpret in the short amount of 15-20 minutes window of OPD consult I have. So it's a very, very difficult scenario. I think technology is to stay. We should embrace it so that we can augment the way we are providing healthcare for our patient.
Thank you, Dr.
Okay, it's a very broad question. So what I will do is I will divide it into 3 parts. Okay. So basically, overall healthcare system, if you look at it, one is your diagnosis. Okay. Another one is your medicine, and third one is your operation. Right? So I will briefly touch all 3 of them. So when you talk about diagnosis, I think AI is going to play a huge, huge role, okay, in predictive also, and even, existing day-to-day basis also. So just to give you an example, how many of us know that looking at eye only, I can tell you that 50 of your blood parameters, how they are operating, okay? And this technology exists, by the way. Okay, I have invested in one of these technologies. Only thing is, until unless somebody signs on it, saying that these results are valid, you cannot launch the product, right? So AI from diagnostic perspective is going to have huge, huge impact. We can see our heartbeat today, we can see our blood pressures today, and all those things. So it helps in preventive care, and at the same time, it will help in identifying critical and more disease that might require intervention. That is one part. Second thing is where we are talking about medicinal part. With more and more data available, more and more information available, you can do, you can go away with medical trials of the medicine. That's how I see it in future. I see it like 10 years down the road, a medicine will be developed and it will be launched within 5 days. Not like 5 years of studies you will have to do and so on. Third part is surgery. Okay, that's where it becomes complicated. Okay, so on the surgery side, I believe that no surgeon has to worry about their jobs, as Dr. Mohan was asking that whether it will reduce or not. Robotic is a mean. Okay, it's not going to replace the surgeon. Okay, so now what will happen with AI in the surgeries, and we are running some trials on it as well. So certain things you can do is, I have a patient. I have understood all the parameters and everything. Now I can run in AI simulation on that surgery that can tell me that what is the probability of success. Okay, that's all I can get. Then that data has to still get into all the robotic equipments at a later stage to make it even more helpful and integrated into the system. Last point in this is, when even you are talking about surgeries, okay, you will be able to do simulation and all those things. I still don't see it on horizon for next 20 years. The reason I will tell you right now is exactly what Sir was mentioning, is the regulatory. So not any patient's data can be shared until unless you have all that data going in to AI from all the hospitals, all the surgeries across the world. Till then, you cannot make it learn and you cannot make it more efficient. Thank you.
Thank you. So what I quickly gather is from proactive to being responsibly reactive. We need to embrace technology. Technology is here to stay and possibly it will make life easier. It's all about improving the quality of the patient's outcome. And finally, the three spheres in which AI can possibly act, but we are worried about regulations. All of us are. I think, my colleague also knows this much more than any one of us. So the second question is more specifically to Dr. Bhaskar. India has a very tired approach to care delivery. So we have, primary healthcare, secondary healthcare, and then, the accessibility, affordability. All these questions have come in, and we have a very tired structure. Sometimes we don't even have a referral structure within the same tier. So how do you think any of these innovations like AI, robotics, etc., is actually going to reach and breach this gap of having a multi-tiered structure to making it look possibly more simpler? Because you have been on the ground, so I understand you will have better perspectives.
Very great question, rather, right? Looking at India as a whole, we have multi-tiered healthcare structure, and also the problems are very multi-tiered. It's not the same problem what we see. For example, cancer diagnosis, what you'll see as a primary healthcare center is very, very different from cancer diagnosis, what you'll see at Fortis as a tertiary care center, right? So how do we answer this question for multiple tiers? How will really technology help at each level is something what you'll have to really answer. My co-panelists were just mentioning about oculomics, right? So oculomics is one of these technologies which is picking up now in the AI space, where we are doing vision screening at a mass level across India. Can we pick up beyond just the vision? You are anyways looking at the retina. Can you look at retina or the fundus image and see for other diseases also? What will it really help? Identifying early and screening for multiple other diseases at a mass level and filter them out who should be referred. Now what is happening? All these people, they are directly coming into the tertiary care center, and the overload is happening at the tertiary care center. Can we screen them at that level? This is where majority of AI innovations are really happening today. There are multiple examples for that matter. One is oculomics. You have Niramai who's doing for breast cancer. You have Cure.ai doing for tuberculosis. All of these guys are working at the layer of screening. Beyond that is where your primary or the secondary care comes up. So when it's primary or secondary care, what we really need to look at is how do we enable the practicing physicians there. At the first layer, we are looking at the frontline health workers, your ASHA workers, ANMs, etc. Here is where we'll have to enable those practicing physicians. What do I mean by practicing physicians? Do I have a urologist or a cardiologist available at a district hospital? We don't have. Can we build in layers of AI which can help them diagnose and screen better, look at which are the really necessary cases which should be sent to a urologist, right? So out of 10 cases which comes to a urologist in a tertiary care center, 8 need not come there. They can be handled at a district hospital. How do we manage that load? Only then we can deliver care to the people who really needs that care in a tertiary care hospital. Now jumping into the tertiary care hospital, here is where the real depth of technology can be accessed. So how can we make these technologies deliver better for the ones who are already experts? This is where precision medicine comes into play. So in onco, what we are looking at is we are using genomics to see targeted therapies. We are using today proton cares to see how can you really target and deliver that kind of care. So these are multiple layers of AI or robotics or multiple new age technologies which are playing at the primary care or below that, secondary care and tertiary care. What has really not happened is, have we tied all of them together? Is not happened. Also, what has not happened, like my co-panelists also mentioning, is how do we tie policy and the insurance layer around this? So till this is solved, the accessibility and the referral pathway will not be solved. Technology exists at all levels.
Yeah, I think the perspective of trying to be, penetrative with technology alone doesn't work. I think, the complete picture is still, at least for now, it looks like a jigsaw puzzle that's not yet sorted. But yeah, payers, they have to play a final role in trying to decide how things go, considering, how the country is progressing in terms of coverage for the insurance coverage. I think, sir, you see a lot in your current hospital that you work with in the tier of patients that Dr. Bhaskar is talking about. So would you have any perspectives that you might have heard from colleagues or patients that possibly weighs in, equally or better?
I'm looking at, see, when I wanted to implement technology, I want to just generalize because in government we are not much forward because digitalization has come very, very recently to us. Maybe, I think, maybe 8-10 years back, we implemented this HIS systems because we had a lot of legacy systems, independent vendors who never shared data, there was interoperability challenges. So we brought all these people on a single platform. One thing which I have seen in government is the technology partners who are developing solutions for healthcare, they want healthcare to adopt to their technology. So I think that's a major challenge. Technology has to adopt how healthcare is delivered. Because of this friction, if you see, the scale at which technology is penetrating in all industries is phenomenal. This is the one challenge I see why it is not infiltrated healthcare as of today. So there is no seamless integration of technology. So this is one part of it. Regulation definitely is a big challenge as of now presently. We have some rules in place now. We just have to see how it's going to pan out and how people are going to embrace and share data now. Now, being in a public institute, public health institution, I have seen that not only private, even government departments are very, very privy of their data. There is no seamless integration of, for example, in Karnataka we have medical education department which comprises of medical colleges and super specialty hospitals. Health departments has a PHCs, CSEs. We do not share data among ourselves. So we have two ministries. So this is one challenge. So what I'm trying to drive here is seamless integration of technology and policies and data, which is challenging. I think even large players, even corporate players, if you see, ABDM has come so much, but even then, how many people are using portability? Yeah. No one. So that's because everybody thinks data is mine, why should I share? So people are not contributing to the whole good. So that is one thing which I see is a challenge.
Thank you. That's a different perspective to it. So I will divide this question into two parts. One to my colleague, who runs our entire engines behind. So how do you look at this gap? How do you perceive this gap where we flip the equation and say technology should adopt to healthcare rather than healthcare trying to be forcibly adopted to technology? And how do you look at it as an investor after him, Mr. Yeah.
Sorry. So the point raised by him is quite valid, and as somebody who is managing this, I can guarantee that this is what is the reality. Now, how we are addressing or how anybody should be addressing it. I'll give you one example. He spoke about ABDM. We are also working on ABDM. And while discussing with the authorities, we got to know that it can be done within 2 weeks. And they have already done some assessment, and they have got some partners who have done it in 2 weeks. We spoke with them. And when we understood that they have designed something which will never work in healthcare. And we have worked with them on architecture. We have, given them one architecture where they have to develop again. They will take 4 months from now, and they have agreed to deliver something. So this gap exists, and we have to work with those partners. Now, the good part with Fortis is that multiple things we have in-house. Our HIS in-house is in-house, and we have multiple things which we have done either in India or abroad. So we have acquired EMR, for example. Right. So whatever we have which is related to healthcare, majority of them are either developed by healthcare experts, or we have acquired from somebody who has the expertise of healthcare. Except couple of things which we cannot develop. For example, ERP, we cannot develop, and we should not be developing it. But something related to, maybe NIC for that matter, or any health, heart-related cardiology, or anything. I mean, like those kind of applications should be developed or procured from a partner or from a vendor who has some healthcare background. Now, talking about AI or innovation, that doesn't come with if your applications are kept in silos. For example, in healthcare, you have HIS, you have EMR, you have PACS, you have multiple different blood bank, you have multiple different applications. They all have their own set of data. And if you have to create one inference about a particular patient, it is only possible if the integration is there. Otherwise, somebody will look at the X-ray, somebody will look at MRI, somebody will look at the blood report, and then it will take longer than what it should actually. So with the seamless integration, or in one window where you have all the data, and then AI works in the back end, then it gives the inference which is actually required. So this is how it should work, and thankfully we are going in that direction.
Yeah, I think we are fortunate in taking that route. Yeah, because it's well curated now. Yeah, we can see that. Mr. Jain, as an investor, this gap is too much to handle. So how would you want to, even put your dollar there?
No, that's a very, very genuine concern. So first thing, whenever there is a disruption, okay, disruption is not based on solving a problem. Okay, so AI in any field is a disruptor. So it's not meant to adapt to a problem. It's meant to disrupt the overall system and then create a chaos theory to bring everything to some senses. So that's where you will not see. This is again like me being in investment field in this area. So I see not many people are going to develop applications or solutions based on a particular problem solution. Okay, AI has the potential to handle multiple problems at the same time. Okay, so it will be always a disruptor to existing system where the other person will start thinking that I don't know anything. Okay, I surrender, and that's when the whole integration starts. Okay, yeah. So that's what my view is.
Thank you so much. This is to the two medicos on the group. How do you think industry should be balancing innovation, patient safety? Because now with all these things coming over, robotics, of course, is one of those things that we've evolved so much. So are we good enough in balancing innovation and patient safety? And what is the role of AI in trying to keep this balance?
So even before I jump answering to how industry should be preparing, I have a small take on the previous point and discussion.
Sure.
This is one data point to bring forward is healthcare is in no dearth of data. So if you really look at the amount of data what healthcare is actually contributing to the overall pool of data, WHO number says 30% of all the world's data is healthcare data. Right? So that's like of every 10 words we speak, 3 words are related to healthcare. With that amount of data, how much amount of data is really used to generate whatever kind of models or retrain or enhance the kind of work what we are doing is not even 1%. That's where the real gap is. Right. So how do we bridge that gap is somewhere we'll have to really work. Only when we bridge that gap, we'll have solutions. So ABDM we are talking about, when ABDM was conceptualized, thankfully I've been involved with the government to work very closely with structuring and implementing ABDM. The initial idea was to look at if ABDM can be the UPI movement for healthcare, right? So universal healthcare access is something what we have been talking about. The imagination or the concept was to bring about something which will make like UPI, everybody has access to their healthcare data, everybody has access to healthcare. But did it really happen? No. So two of the biggest gaps my co-panelist was mentioning is, will it really work in private setups? It's a big challenge still. Will it really work for all the patients who are seeking care? It's a big challenge still. Will it give access to all the patients' data? It's a big challenge still, right? So how do we solve all of this? If we solve all of this, only then it will become an UPI movement. So I'll stop there. Coming to the second question, what should industry be getting prepared with? One, of course, we'll have to move away from silos. That's a sincere request, both as a person who's been involved with healthcare technology for a good decade and a half, and also from the public representation perspective, from the government perspective, right? It's a request both for the government and also for the private. Because when we are looking at a patient's data, we are not looking at patient's data from a hospital perspective. It is from the perspective of the disease, how he is presenting. Fortis might have wonderful systems. Similarly, 2-3 other hospitals also might have wonderful systems. Until and unless all of us don't come together, we really are not solving for the society. It will not be a benefit for everybody. Somehow we'll have to figure out a way where all of us can come together and generate a pool of it. It has to be a collaborative effort. That's one part of it. Second part of it is also about awareness and capacity building. Our previous panel was also talking about how do we build capacity among a lot of young doctors who are coming out. This is also real when it comes to doctors who are coming out who are using AI, right? So this generation who is going to get into practice, they will get into practice exposed to AI on day one itself, which they may not have got exposed to in their medical college. So they'll have to get used to this technology. We'll have to bring in that awareness and training. Those are two key areas. Third key areas is, as practicing physicians and hospitals, we'll have to bring in a lot of knowledge to our patients also. So they have been a lot misguided about technology. They have been a lot misguided about use of AI, what's good, what's bad. 3 points. So all three, if it happens, we should see a significant improvement in all the three factors what I was mentioning: affordability, accessibility, and quality of care using these technologies in the next 3 to 5 years.
Yeah, thank you. That speaks volumes on how much you have been on the ground with this. Dr. Amrut?
So coming to innovation in what do we do, why technology is not moving forward, I think healthcare transformation happens at the speed of trust. Okay, so now people are very scared of technology. Okay, they're not ready to embrace. So having said that, I'm not, because I usually, I am a strong advocate of using technology in healthcare. But having said that, there are no strong regulation or guardrails for how to do it. But that should not stop you from doing small experiments. You have some scope, you have something. For example, somebody comes, some startups comes and say, sir, I have this surgical tool which will help you see better. For example, your camera is fogging when you do because this is a surgical group, your camera is fogging. I have this technology, when I go to your camera, it does not fog. So that will give you something different. He may not be from a healthcare field. So there has to be some cross-pollination between disciplines as well. Because engineering, we have a lot of, we have IITs, IIMs, not talking to healthcare at all. So we need to form a platform where all these people are coming. Now many large universities and previously all universities are coming together and making this interdisciplinary streams as well. So which is already doing some space to encourage innovation. Government of India is also promoting this kind of innovative challenges where in fact for this AI summit we had this catch grant where we had our national cancer grid collaborate with the AI India. So the participants had to find a partner for a hospital, NCG group hospital who will partner and help them. So these are kind of things which innovation will come. Now, my take, one message to everybody is, you should collaborate with people so that we contribute to the science, so that it moves ahead. If we are very scared and we stay in our own silos, we are not going to go anywhere. So that is what I have to say.
Thank you. So I think at IHH and Fortis, we are very fortunate. We curated a program called Catalyst, where we have looked at, young innovators who got some ideas, that we wanted to curate as a part of the group innovation. So that's I think we are on track. Yeah. So, sir, your favorite question, Dr. Amrut. This belongs to you. This is your favorite question. How AI and radiology is defining healthcare today?
Radiology, I think Bhaskar will tell you. Now, coming to radiation oncology, we have this precision-based planning system. Now, we use imaging a lot. So we have a lot of scope for, so I remember 2 decades back when I started radiation oncology, it used to take me almost 6 hours to contour. One nasopharynx case, if I have to mark all the volumes, it used to take 6 hours. So over a period of time before this AI came, it reduced to over a period of time 3 to 4 hours. Now I don't even have to do anything. So within 5 minutes of loading these images, it will give me volumes. I may spend another 10 minutes to tweak these volumes. I'm done with it. Similarly, even the treatment planning systems have also increased. So what planning used to take almost 2 to 3 days, now it is present in 30 minutes. In some models, we have already seen that adaptive planning is what we use, and it is instantaneous. So we are able to give precision, we are able to image the patient on a daily basis and superimpose a plan and adapt our plan accordingly. So this has done phenomenally in the case, because everybody, if you see, when I was studying, everybody used to say radiation is current kodtare, current room hoge. So that's the kind of attitude people had, but now it is much more tech savvy and it is much more better, and the side effects what we see are reduced.
Precision is much higher. Yeah.
No, I think most of it is covered. How far AI has really gone within radiology, all of us know. I wouldn't want to take too much of time there. Rather, being a radiologist 10 years back when Elon Musk said radiologists are going to lose their jobs, I shifted my careers and stopped practicing. But I repent now. So, jokes apart. But
college days, we used to call it the green card.
Yeah. So, rather, if you really look at artificial intelligence, be it in radiology or anywhere, how far has it really come? It is still not artificial intelligence per se. It is only augmented intelligence, right? So none of us, even radiologists, we are really giving all of our decision making to AI still. It is doing very good job, like he was mentioning, with respect to contouring and drawing the borders, etc. But is it really doing the full-fledged job of a radiologist in diagnosing? In few areas, yes, but not across the board. It will take at least another 3 to 5 years. It will fall back on the previous discussion what we are talking about. How far is the data accessible to the AI models? Yeah. We are still far away from that.
Yeah. Although image processing is something that's been quite advanced, and that's possibly the most advanced application that we know of. Yeah. So this is to my panelist, Mr. Jain. This is typically a question that all of us battle with, and after that I will come to general closing comments with all of you. So technology comes with a cost that's humongous, and with this kind of cost, are we able to create equitable healthcare access? So, and what is your perspective to this? Because you must have seen applications that you have invested, curated, and possibly not reached the last mile.
No, very political question. I will tell you, because the reason I tell you everyone is, there is a whole group of people who talks about there is going to be AI bubble burst, right? So much investment has gone in. There is another one that is saying that it is going to do wonders. So let me just say 2 things. One is, like Dr. Saab rightly said, this is AI means artificial intelligence to where it gives you enough data to make the final decision. Like it's happening in all the bombings and everything. Cloud is giving all the potential targets, and then they decide whether we need to do this today or not, okay? So AI is a machine that is taking data from all the libraries everywhere and all those things and giving you in fractions of a second. That's all it is doing, okay? So now to do this, you need access to all those libraries. You need access to all those datas. You need access to everything. And when you are doing that, you are spending a lot of money, okay? So I can tell you, in next 10 years, not even a single AI company will be profitable. Not even will break even, okay? So that's the situation today. But as the adoption increases, okay, as things continue to happen, because today I have talked to like 10 people, and 8 of them don't understand AI. AI for them is ChatGPT. It's not that. AI is artificial intelligence. It's replacing your intelligence or giving you some intelligent information. What we are talking, everyone is talking about is a fast search engine, which is not artificial intelligence. That's the differentiation. So I see AI will take a lot of time, okay, to even break even. Cost component is going to remain very high right now. Companies like, if you see in quick commerce, companies are burning cash. Similar situation is going to happen in AI. And this I can tell you based on my interaction with even Elon and all those people in past life. When AI hits medical sector, okay, its cycle is 50 years. Its cycle is not 10 years or 15 years or 20 years. Its cycle is 50 years. So we all need to keep that in mind, that we are still in infancy of where we are supposed to go. Thank you.
Very politically correct answer, sir. Yeah, so some closing comments, Vipinji, from you.
Yeah, so my view is...
before that, I did not want to touch the point on education and reforms because it's done in the previous panel. Yeah.
Yeah, so in my view, AI is going to pick up very fast. Yes, I understand in the clinical aspect, it may not be that speedy, but in operations, in patient care, for example, you'll see multiple applications coming in picture where you'll have chronic disease management coming in, post-discharge management, some triaging will come in picture. So those things will come in picture, and yes, of course, it is not going to replace the human, but yes, the human who doesn't know AI will get replaced.
Right.
Yeah, slightly radical closing comments, but my request is, like my co-panel is also mentioning, from today onwards when we are looking at least as practitioners looking at AI, what I would urge is look at it from the physical AI perspective, right? So not just the GPTs of the world, right? So how it can work with the existing systems, how it can really work with my robots, how it can work with my diagnostic devices is very, very important. So that's where the physical AI world we'll have to look at. That is what which will really change the way we are practicing. My second request is, as practitioners, especially who have been in this sector for good decades, we should also look at how do we develop indigenous solutions out of India using the technology base what we really have. Today, government is supporting a lot of such kind of initiatives. If private hospitals who have access to patients, who have access to talent, who have access to such great, amazing doctors who are practicing with them, contribute some bit of their time to drive innovations, we will have wonderful medical innovations coming out of India who can stand eye to eye to international brands. So those are two urges from my end. Thank you.
Thank you, Dr. Bhaskar.
There are some things. For example, my kids use AI to make their essays for school. So I keep telling them, what is AI, do you know? So you see that intelligence, artificial intelligence, where did that intelligence? We are the people, we are the intelligence. This is just artificial. Yeah. We are the people who contributed to make it AI. So do not forget that, that is what to do. So coming to the point, like we need to see, we have to be the human in the loop to use these technologies, and we should embrace technology and do small experiment. That is one thing which I would like to say. Second thing is, as Bhaskar mentioned, collaboration. Now when I mentioned, you mentioned that Fortis is already doing, but you're still doing it in silos. You should join hands with academic institutes or center of excellence, where they will, I think, the scale of, because whatever you learn, if it is not shared, it is of no use. Right? So it grows by sharing only. So there's no, so you should look at collaboration. I'm not telling that you just collaborate with government or something. You collaborate with other private partners as well. So I think there is one lacking thing in healthcare sector. where there are different chains of hospitals who are much more competing against each other. There is no common platform where all these people meet. So there is no dialogue happening. For example, now one of your CEOs moves to another hospital, he will not talk to the previous hospital, even though he knows what's happening. The knowledge what he takes from this hospital is being maybe a little bit used there, but vis-a-vis, there is no large-scale exchange which is happening, based on which it will not happen. So that is one thing which collaboration is the thing.
Yeah, I don't think we are good at sharing best practices between the government and us. Yeah.
So one closing remark I would like to say, I see a lot of sponsors here who are from equipment robotic manufacturer side, okay? So my humble request to them is, if you want this adaptability to increase, create simulators. Okay, if you have the Vinci, because we're talking about surgery, that's why I kept it for the last, that do one thing, that create simulators, because even today, just take an example of an aircraft. Any aircraft comes in, any new pilot is trained, initially that person has to go over hundreds of hours of simulations, right? Robotics is exactly the same thing. Plane is no different than a robot, okay? So it's exactly the same thing. So the more you can create simulators, more you can provide them to medical institutions, more students will know, more people will be aware, they will be talking in their families that, okay, this is what we are doing in their circles. It should be part of curriculum. That's how I see it, that simulations, robotic surgery should be part of the curriculums of all the medical colleges. That's how you can progress it. Thank you.
Thank you, sir. So to me, I think, just like a closing remark, I should say, if I can take a Dolo 560 instead of a Dolo 650, I think AI has done its last mile job. Yeah. Thank you all. Thank you very much. Yeah. Thank you, everybody.
Thank you, everyone. I request all the dignitaries to kindly remain on the stage. We have a small token of appreciation, and to join Dr. Anant on the stage, I request Dr. Mohan to please come on to the stage. Can we have the mementos, please? Can we have a big round of applause for the panel? Thank you so much, everyone. Now, I'd like to invite Mr. Anil Vinayak, Group Chief Operating Officer, Fortis Healthcare, to share his thoughts and reflections on this remarkable journey. Please welcome Mr. Anil Vinayak.
Thank you. It's my absolute pleasure to be here today. Thanks to everyone who's here, the senior faculty, the clinical fraternity, all our partners and many, many international delegates as well. Thank you for taking the time to be with us today. Compliments to Dr. Mohan and his entire team. To see a hall full at this time of the evening is quite something. I've been to many conferences, and the sheer attendance here is a testament to the quality of the agenda as well as the credibility of the organizers themselves. Of all the innovations in surgery, I think robotics is one of the big ones. I would put it just after laparoscopy. And I think over the years, we are seeing the momentum build up in that area. So a conference of this nature obviously is an effort to try and popularize this further. And I congratulate the organizers for having made this happen. I'm very proud to say that with over 3,000 robotic surgeries having been done at Bangalore, this is one of the leading programs in the country. And I say that not just in terms of numbers, but also in terms of the complexity of work that is being done, as well as the sheer width of surgical programs in which robotic surgery has been adopted. At Fortis, we remain in the forefront as well. I described the first robo that came in about 10, 12 years ago. And today we have 22 systems. In some of our facilities, we have 2 robotic platforms. In many, many others, some of them are in the tier 2 cities as well. We now have robotic platforms as well. And we are seeing the benefit to our customers as well, to our patients as well. Since its inception about 25 years ago, our first hospital came up in Mohali 25 years ago in July of 2001. Since then, as a group, we have grown from strength to strength. We now have 35 hospitals across 14 cities in India. And we're also very proud to be part of the IHH Healthcare Network, which is one of the largest healthcare chains in the world, having brands such as Mount Elizabeth in Singapore, the Prince Court in Malaysia, and the Acibadem chain in Turkey, which is one of the largest providers there. So as Fortis, we are very privileged to be part of that. Our mission is to be a trusted brand which is known for clinical excellence and service excellence as well. And I, again, would say that the efforts of clinicians like Dr. Mohan and many, many of his team members who are here today are instrumental in building that position for us today. So thanks once again, everyone, for being here. And I hope that, and I'm sure that the day has brought a lot of value to your patients and to you. Thank you very much.
Thank you, sir. I request you to kindly remain on the stage, please. Sir, request you to please back onto the stage. We would like to felicitate Mr. Anil Vinayak, and to do the honors, I would like to invite to join on to the stage along with Dr. Anand, Dr. Priya Sridharan, Director of Medical Operations, Mr. Sameer Arora, SBU Business Partner Finance, Mr. Ravindra, Business Partner Sales, Mr. Ganapati Hegde, International Sales, Mr. Ganesh Rao, SBU Head HR, Thank you, everyone. Thank you, sir, for joining us today. We have come to the last but not the least segment of our program today. Please bear with us for some more time. We have a awards and recognition ceremony. For this, I would like to invite Dr. Mohan Keshamurthy. Over to Dr. Mohan.
This is the most important part of the day. It's expressing gratitude for people whom you don't get to see, but who are the reason why we have done 3,000 successful robotic surgeries. It's a matter of great pride that the strongest chain is only as strong as the weakest link. And at Fortis Robotic Surgery Program, we do not have a weak link, and that's why we are standing here today proudly to celebrate. I would request Mr. Anil Vinayak and Dr. Bishnu to be on stage. This is the only segment of the day I'm emceeing, because I want the credit to go to those who are least seen, but who actually are the ones who have made us bring this program together. So I would want you both on stage, and then we'll start off. Not for felicitating you, sir. Please be on stage. So one of the things that most robotic programs lack, and Fortis has perfected, is its ability to keep the supply chain going. And keeping the supply chain going is extraordinarily difficult because a surgeon decides at 12 midnight that he wants a particular consumable. Would request Mr. Chamaraju to come on stage, our supply chain manager, who keeps every robotic procedure happening on time. The other part of any robotic surgery program, especially in minimal access surgery, which is expanding at a rapid pace, is what we call in Fortis as a service line manager. What it translates is what the surgeon doesn't want to do, he or she does it. So she manages the surgeon, manages the patient, manages the outcome which is not good, manages insurance, manages moods, emotions, problems. So for the minimal access program, which has grown hugely beyond urology, would request Mrs. Vinuta to come on stage. SLM minimal access surgery. So 3,000 is a number, but the reason why we have caught the global eyeballs is our robotic kidney transplant program. We accept patients from across the world. We accept patients with everybody else refuses, and we send them home with a good outcome. Most people think Dr. Mohan is the reason for our success in the robotic transplant program, but it isn't true. It is because of the collaborative practice that we bring to the program. I just want one example of what collaboration does. I heard it repeatedly from a good gentleman, Dr. Amrit, collaboration. And this is collaboration. So a patient comes to Fortis looking for a transplant. The first person he meets is not a doctor. He meets my transplant coordinator, Mr. Joshua David. Would request him to come on stage. I will continue the story and will felicitate everybody together. Then what happens? He then decides the patient, donor and recipient, are they fit for each other? We then send this patient down to our world-class transplant immunology lab where Dr. Suneet tells us, will this donor and recipient match each other? Would I request Dr. Suneet to come on stage? And then we need to know whether it is medico-legally correct, whether it is ethically correct, whether it is as per the credentialing system of the government of Karnataka. That's where Dr. Priya, our medical head, leads a committee which stringently examines whether this donor and recipient are right to be, as per the legislation, appropriate to be transplanted. Then this patient goes to our transplant nephrologist, Dr. Manjunath, who decides whether it is worthy to go ahead and have a successful transplant outcome. Then this patient, once Dr. Manjunath says is fit to go ahead with the transplant, meets our transplant anesthetist, Dr. Murli Chakravarti. Can I have Dr. Murli on stage? Then two gentlemen, one on donor, one on recipient. We are one of the only places in the world where we have two robots, both for the donor and recipient, happening simultaneously. Two brilliant colleagues of mine, Dr. Karthik and Dr. Basavraj, are the surgeons on the donor and the recipient. But it doesn't end with the surgeons. We need a tech and a nurse. My longest serving colleague over 23 years, who has traveled across 25 countries, done more than 1,000 transplants with me, Mr. Krishnaji on stage, please. We also need a nurse to assist us in the procedure. Mr. Guru Prasad, our robotic nurse. And then when the procedure is done successfully, we all go home. There's a nurse to take care when we sleep. Can I have, on behalf of Mrs. Ruth, our transplant ICU in charge, Mr. Shivkumar on stage. So it takes this many number of people to do one transplant. That's the point I wanted to convey, and that is the reason I wanted you to wait. It is with gratitude that I want to express. It is not easy to run a transplant program, let alone a robotic transplant program, but it is a privilege that I have this many people to send that one patient who comes to Fortis Hospitals, Bannerghatta Road in trust, to go home to whichever part of the world he or she belongs. It's a privilege, ladies and gentlemen. Please give them a wonderful hand. Thank you. That's the transplant team, and for those of you who want to build a transplant program, you have to gain the trust of this many competent people to listen to you at any time of day or the night. I'm not an easy person to work with, I'll confess, but it takes a visionary leadership, especially based in Bangalore, because the Delhi gentlemen can refuse to answer my call. But the ones in Bangalore, I'll go to their room and bang on their doors. So it takes a visionary leadership to accommodate a robotic program of my size. I have 45 consult surgeons. We're the largest corporate sector urology program in India, if not Asia. So would request the visionary leadership that has put together a robotic program which possibly will be the first in Asia to reach 10,000 procedures possibly in 10 years. So I would request Dr. Anant Rao, Mr. Gautam, Mr. Ravindra, Mr. Praveen, Mr. Samir, Mr. Ganesh, and Mr. Ganapati to please come on stage. There are one young man and one young woman hiding out there who actually put together every piece of graphic which everybody said is gorgeous. The girl actually woke up at 3 a.m. to set it up two nights ago. The other gentleman is a very self-effacing gentleman. Both of them happen to be Bengali. I don't know what makes Bengalis hide but do wonderful work. Would request on stage Mr. Samrat and Ms. Debar Peta. Our branding leaders working in silence and making us all better than we are. On me. So I started my journey 8.5 years ago when I got a phone call on a Diwali day by Dr. Bishnu saying there's a robot in your basement, do you want to use it? Abhijit from Intuitive, my good friend who introduced me to a robotic steering committee which made us who we are, handheld a novice robotic surgeon at age 50 trying to be better than himself. I didn't know that I could do an open procedure of a radical prostate in an hour and a half, and he was trying to convince me I can do it in 8 hours for a better future. This was a day possibly you meant. I didn't see it then, but you saw it then. Mr. Abhijit on stage, please. And Intuitive stole every robotic manager with me who did well to lead a program elsewhere. And there's a long list of them. But then finally they sent me a very young man who actually has been good Vastu for us, brings a lot of chulbuli energy, has made the younger members of my team like him. So I don't hear any crib when something goes wrong because they solve it themselves. Would request Mr. Robin Rajpurohit on stage, please. I guess Intuitive held back the best for the last, the youngest of the managers I got, but who has given us exponential numbers in a short period of time. this event, entire magnificent event, was curated by two women. One, I call my Woman Friday, Sumati Raju, SLM for Urology, who has taken every challenge to the extent even my son from the US calls her for help rather than me. And Miss Jessica Cynthia, our PR lead and the brain behind this magnificent event, single-handedly, between the two women, is the spectacle that they have created for you. It's a privilege to know that the entire event has been engineered and orchestrated by two women who have spent most of their time, including Sumati's daughter's birthday yesterday, on site to see that this event happens. Thank you. And finally, we come to the last part of this story. It's a long emotional journey for me, from being somebody who thought robotic surgery is not for me, to lead possibly the largest program in the country. I was alone in 2009 as a solitary urologist who went wherever the case was. That's when both Dr. Bhaskar and Dr. Amrut know me. Our only thing then was that I hunted alone. Two gentlemen joined me from that period of time and have stayed till now to make what we call Team Urology. From Dr. Mohan to Team Urology, two people have defined our destiny, positive destiny, and made us who we are. Would request my brothers in arms, Dr. Shakir Tabriz and Dr. Prem Kumar Krishnappa on stage, please. Thank you, gentlemen. It is a privilege, and that is the journey of gratitude. For those of you out there, it's never about one individual. It's about a team that supports, delivers, creates, and lives behind a legacy. Thank you for your patience.
Thank you, Dr. Mohan. Congratulations to all the awardees. We have come to the end of the program. We have a special entertainment programs curated for all of you. Please sit back and relax. Post that, we will disperse for dinner. I request the performers to come onto the stage, please. Sorry, apologies, my bad. We have a small cake cutting ceremony for our 300 robotic surgeries. Sorry, 3,000. Sorry, 3,000. Can we have the cake on the stage, please? I request all the robotic surgeons to please come onto the stage for the cake cutting. All the robotic surgeons. Request all the robotic surgeons to please come onto the stage from all the departments. All the faculty, the speakers who have participated today. Can you please hurry up? Can I have all the robotic surgeons on the stage, please? We want to conclude this ceremony as soon as possible. We're already running late.
Ruby is here only, no? Call her. MS, anybody's there?
All the robotic surgeons across specialities.
Ready for CG event 300.
Can we have a big round of applause? Thank you, doctors. Can we have the cake removed, please? So we have our special entertainment program now. I request the performers onto the stage. Before they sit up, I would like to thank all our partners for SURGX 2026, our affiliate partners, Surgical Society of Bangalore, ASICC, the Association of Surgeons of India, Karnataka State Chapter, Bangalore Society of Obstetrics and Gynecology, ARIS Association Robotic Innovative Surgeons, our lead sponsor, Intuitive India, our supporting sponsors, GE Healthcare, Healthware, Axis, Meditech, Teleflex, Glenmark, Sun Pharma, Medimart, IPG Photonics, Agilis Diagnostics, Medtronics, Lexion Stores, BTL, Jogo, Roche, Blue Neem, Shiva Scientific, Johnson & Johnson MedTech, Cipla, Everlife, CPC Diagnostics, Ansel, BDR, BSV, Olympus, Zydus, and Sanofi. Thank you everyone for your partnership, cooperation, and collaboration for the last 2 days. Thank you so much. Also our event partners, V5 Events, Mr. Santosh and team, Mr. Shashi, our photo video partners, Media Connect, Mr. Mukund, Mr. Somashekar, and our F&B venue partners, the Lalit Ashok. Thank you so much, everyone.